Good morning to one and all. It's my pleasure to introduce Dr. R.K. Srivastava. Sir is a professor and consultant, plastic surgeon, Department of Burns and Plastic Surgery, Safdarjung Hospital, New Delhi. Sir has completed MBBS and MS, General Surgery degree from MNN Medical College, Allahabad University. MCH degree in burns, plastic, and maxillofacial surgery from Delhi University. He has worked at LNJP Hospital and joined at Safdarjung Hospital in June 1992. On 16 January 2018, he joined PGI MER and Dr. RML Hospital, renamed now as Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi. Sir has a very long profile. Along with his professional work, he has involved in administration work too. He worked as a designated estate officer at Dr. RML Hospital. He was designated as the first appellate authority for RTI at Dr. RML Hospital. He was the nodal officer for institutionalization of undergraduate medical college, ABVIMS, at Dr. RML Hospital and started that in a record time of 2 months along with his team. He was posted as additional medical superintendent at Safdarjung Hospital, New Delhi. He is also holding the post of professor, consultant, and head of the unit in the Department of Burns and Plastic Surgery in the hospital. He has been the administrative in charge of COVID-19 hospital section of Safdarjung Hospital, New Delhi. He has several scientific publications in national and international journals of plastic surgery. Sir has presented his scientific works in lots of national and international conferences. He has been associated with administrative works for a long time, both at Safdarjung Hospital and Dr. RML Hospital. He is associated with National Burns Prevention Program of India and participated in training programs for doctors from different parts of the country and abroad. He is a member of various scientific associations related to plastic surgery, as seen on the screen. Sir is also the president of National Academy of Burns, India. He has been the past president of Society for Wound Care and Research in India, 2016 to 17. Presently, Dr. Srivastava is one of the trustees of SWCR Association of India. He has been the joint secretary in the executive body of National Academy of Burns of India for 6 years. He has been associated with the general healthcare programs of few NGOs and social organizations in India. He has been associated with the healthcare programs of District Council of Leh District of Ladakh and has organized camps in Leh and Kargil every year for the last 9 years. He is the Honorable Secretary of Allahabad University. We are proud to have such a distinguished personality among us. We welcome you, sir. Over to you. So I'll just hand over to them.
आप सभी को मेरा नमस्कार। अगर मैं हिंदी में बोलूं तो आप लोगों को ज़्यादा समझ में आएगा या अंग्रेजी में सुनना चाहेंगे? क्या राय है? आप लोग हाथ उठा के बता दें, आवाज़ तो नहीं आई। हिंदी में बोलें, ठीक। फिर से आप सभी को, सभागार में जो उपस्थित हैं, सभी को मेरा नमस्कार। मैं डॉक्टर R.K. श्रीवास्तव आज आपके सम्मुख प्रस्तुत हूँ। मैं आपसे सिर्फ इस बात की चर्चा करूँगा कि हमारे भारत में इस वक्त बर्न केयर को लेकर कितनी जागरूकता है और कितना हम समर्थ हैं एक बार बर्न इंजरी होने पे उस पेशेंट की केयर करने के लिए। थैंक यू। लेकिन आप सबसे इस चर्चा करने से पहले मैं आपको यह बताना चाहूँगा कि मैं हमेशा हर जगह कोई भी चर्चा की शुरुआत इस एक सेंटेंस से करता हूँ, वंस अ बर्न पेशेंट ऑलवेज अ पेशेंट। हिंदी में अगर आप एक बार जल गए तो आप हमेशा के लिए किसी न किसी रूप में एक मरीज की तरह रहेंगे। चाहे आपके शरीर पर थोड़ा सा आपकी स्किन का कलर अलग तरीके से हो जाए, या छोटा सा स्कार आ जाए, या कोई डिफॉर्मिटी आ जाए, लेकिन आप हमेशा किसी न किसी चीज से ग्रसित रहेंगे। इसलिए जहां तक हो सके जलने से बचें और दूसरों को भी बताएं कि इससे जलने से बचें। इसको आप इस तरह से समझ सकते हैं कि किसी आदमी के जल जाने पर क्या प्रभाव होते हैं शरीर पर। जैसे एक घर होता है जिसकी छत और दीवालों को हम निकाल दें या किसी तरीके से वो क्षतिग्रस्त हो जाएं, आप समझ सकते हैं कि घर में रखी हुई, जैसा कि इस चित्र में भी दिखाया गया है, उस घर में रखी हुई प्रत्येक वस्तु हर चीज के लिए प्रस्तुत रहेगी, चाहे वो पानी हो, गर्द हो, धूल हो, चोरी हो, किसी भी तरीके से। इसी तरीके से शरीर पर जलने के कारण प्रभाव पड़ता है, क्योंकि स्किन, त्वचा शरीर को प्रोटेक्शन देती है और एनवायरनमेंट के साथ इंटरैक्शन करने के लिए भी उसका उपयोग होता है, और वह शरीर को आकार भी देती है। जहां तक बर्न इंजरी की बात है, 95% बर्न इंजरीज प्रिवेंटेबल हैं, उनसे बचा जा सकता है सावधानी रखने से। इसलिए सबसे ज़्यादा जोर बर्न केयर पर हमें जलने से बचने के लिए करना चाहिए। अगर हम ओवरऑल सिनेरियो देखें तो हायर इनकम ग्रुप की कंट्रीज में जलने की घटनाएं कम होती जा रही हैं, क्योंकि उन्होंने अपने जो भी सावधानियां अपेक्षित हैं उनको रखने में सफलता हासिल की है। जबकि भारत में हमारे पास दुर्भाग्य से ऐसा नहीं है। आज भी हमारे यहाँ देश भर में, वैसे तो सही डाटा उपलब्ध नहीं है, लेकिन फिर भी हम ये कह सकते हैं कि 70 लाख से ज़्यादा लोग एक साल में जल जाते हैं, चाहे वो छोटा सा जलने का इंसिडेंस हो चाहे ज़्यादा, जिसमें से कि करीब 1.5 लाख के करीब तो डेथ हो जाती है, और 2.5 लाख से करीब के लोग किसी न किसी प्रकार की डिफॉर्मिटी से ग्रसित हो जाते हैं, और वो लाइफ लॉन्ग डिसेबिलिटी होती है। हमारे सिर्फ एक सेंटर, सफदरजंग हॉस्पिटल एशिया का सबसे बड़ा बर्न सेंटर है, और सिर्फ एक सेंटर में हम अप्रॉक्सीमेटली 6,000 मरीज अपनी कैजुअल्टी में अटेंड करते हैं एक साल में, और उसमें से करीब 1500 लोगों को हम भर्ती करते हैं, और जिसमें 250 से 300 लोगों की डेथ हो जाती है। तो यह एक सेंटर का हाल है, आप समझ सकते हैं कि पूरे देश भर में क्या हाल होगा। अब अगर हम बर्न को डिफाइन करना चाहते हैं तो क्या है? यह हमारी स्किन को की कॉन्टिन्यूटी में एक ब्रीच है, एक कटाव है या एक गैप है। किस कारण से? ये जलने से हो सकता है, थर्मल, जो कि आग लगने के इंसिडेंसेस हैं। बिजली से भी हो सकता है, बिजली से आप कांटेक्ट में आके भी बर्न इंजरी हो सकती है, और फ्लैश के कारण जो आग निकलती है उससे भी जल सकते हैं। केमिकल एजेंट्स से हो सकता है। वापी एक इंडस्ट्रियल एरिया है, यहाँ केमिकल इंडस्ट्रीज बहुत हैं, आप लोगों ने जरूर इस तरह की इंसिडेंसेस देखी होंगी। बहुत अधिक ठंडक से, बर्फ से, या बहुत एक्सट्रीम कोल्ड हो जाए, जैसे मैं ले जाता रहता हूँ वहाँ बर्फ नहीं पड़ती लेकिन एक्सट्रीम कोल्ड हो जाता है, -20 -30 नॉर्मल है। हम लोग गर्मी के दिनों में भी -1 डिग्री में वहाँ पे काम करते हैं। तो ऐसी कंडीशन में भी शरीर के एक्सपोजर से जलने की दुर्घटना हो सकती है। इफेक्ट क्या होगा इसका? ये बहुत थोड़ा सा बर्न हो सकता है या बहुत सीरियस हो सकता है। यह डिपेंड करता है कितना पार्ट बॉडी का, आपके शरीर का जला है और किस जगह का की इंजरी है। डिफरेंट लेयर ऑफ स्किन इन्वॉल्व हो सकती हैं, जो कि उसकी डेप्थ को बताता है, कितना अंदर तक आप जल गए। और एक बार जलने के बाद यह असर आ जाता है कि हम किस तरह से चलते हैं, दिखते हैं, या अपने ऊपर अपने आप को किस तरह से महसूस करते हैं। हमें सोसाइटी में, समाज में किस तरह का स्थान प्राप्त होता है। यह एक हमेशा लाइफ टाइम एक्सपीरियंस होता है, क्योंकि जैसा मैंने बताया, एक बार आप जल गए तो हमेशा के लिए आप मरीज रहेंगे। फैक्ट्स ये हैं कि आधे से अधिक जलने की इंसिडेंसेस घर पे होती हैं, और उसमें भी गर्म लिक्विड से, पानी है, तेल है, इन सब से ज़्यादा होती हैं। और इसमें छोटे बच्चों के अंदर इंसिडेंसेस बहुत ज़्यादा हैं। ऑफ कोर्स औरतों के बाद या महिलाएं, लड़कियों के बाद। जो आदमियों में जलने की घटनाएं हैं वो अधिकतर वर्किंग क्लास के लोगों में होती हैं। वर्किंग क्लास के लोग घर के अन्नदाता होते हैं, वो धन अर्जित करके अन्न का और रहने का प्रबंध करते हैं, और आप समझ सकते हैं कि अगर वो जल गए और वो किसी दुर्घटना के शिकार हो गए तो न केवल वो बल्कि सारा का सारा परिवार अफेक्टेड हो जाता है। अधिकतर दुर्घटनाएं घर के अलावा काम करने की जगहों पे लापरवाही या अज्ञानता के कारण होती हैं, और ये होती तो 1 सेकंड में है लेकिन इफेक्ट जिंदगी भर के लिए होता है। अगर हम देखें कि कौन सबसे ज्यादा ग्रसित होता है, तो मैंने आपको पहले ही बताया कि औरतें और बच्चे सबसे ज्यादा इन दुर्घटनाओं के शिकार होते हैं। उसके बाद हमारे जो वर्किंग क्लास के एडल्ट मेल्स होते हैं वो शिकार होते हैं। बचपन की दुर्घटनाओं में 5वीं सबसे ज़्यादा घटने वाली दुर्घटना बर्न इंजरी है। और ये मैं इसलिए बार बार बता रहा हूँ आपको कि बच्चों को शुरू से यह शिक्षा दें कि जलने से कैसे बचा जाए। मैं आगे आपको इसके थोड़ा डिटेल में और बताऊंगा। इसके बाद रीजनल और सोशियो इकोनॉमिक फैक्टर्स भी हैं, जहां पर लो सोशियो इकोनॉमिक रीजन है, जगहें हैं जहां पे इस तरह के लोग रहते हैं जो कम पढ़े लिखे हैं, कम आय वाले हैं, जिनके घर में वो कंजेशन है, एक ही कमरे में रह रहे हैं, इस तरह की जहाँ बहुत ज़्यादा घनी आबादी है, इन जगहों पे जलने की घटनाएं ज़्यादा होती हैं। वनस्पत इसके कि जो खाते पीते परिवार के लोग कहे जाते हैं हिंदी में, उनके लोगों के बीच में। रिस्क क्या है? हमारा व्यवसाय, जहाँ पे कि हम जलने की घटनाओं के लिए ज़्यादा एक्सपोज्ड होते हैं। गरीबी, भीड़ भाड़, हम अपने सामान, अपनी जगह का प्रॉपर सेफ्टी मेजर्स नहीं रखते हैं, रख रखाव पे ध्यान नहीं देते हैं। जो भी हम इक्विपमेंट, जो भी उपकरण यूज कर रहे हैं, जैसे हम घरों में गीज़र को कभी ध्यान नहीं देते कि गीज़र को किस तरह से देखा जाए और उसका मेंटेनेंस किया जाए, या हम पानी का हीटर यूज करते हैं और उसमें लापरवाही करते हैं जिससे करंट लग सकती है या जल सकते हैं। इसी तरीके से और चीज़ें हैं, हम गर्म चाय रख देते हैं टेबल पे और छोटा बच्चा आया और उसने टेबल क्लॉथ खींच लिया, या चाय को अपने ऊपर गिरा ली, या गैस को जला दिया जमीन पर रखी हुई है। इस तरह की चीज़ें, ये सब रिस्क हैं। अल्कोहल और स्मोकिंग रिलेटेड हैं बर्न इंजरीज से। केमिकल्स सभी को मिल जाता है, असॉल्ट में भी यूज हो जाता है। इसके लिए गवर्नमेंट ने बहुत सी रूल्स, रेगुलेशंस एज पर सुप्रीम कोर्ट ऑर्डर बनाए हैं और काफ़ी कुछ हद तक इस पर सफलता पाई गई है कि इस तरह से बिक न सके कोई केमिकल अनकंट्रोल्ड वे में, या एसिड, सबसे ज़्यादा घटनाएं एसिड थ्रो की होती हैं। तो कुछ हद तक हमने सफलता पाई है, लेकिन अभी भी पूरी तरीके से हम इसमें सफल नहीं हुए हैं। इसी तरीके से केरोसिन का यूज़ या नॉन इलेक्ट्रिकल अप्लायंसेस, गैस, एलपीजी या पाइप्ड गैसेस, इन सब के इस्तेमाल में भी अपेक्षित सावधानी जरूरी है। हमारी जो भी हम उपकरण, जो भी इक्विपमेंट, इंस्ट्रूमेंट यूज करते हैं अपने घर में या बाहर या काम करने की जगह पे, उनकी गुणवत्ता और उनके रख रखाव पे भी हमें ध्यान देना बहुत ज़रूरी है अगर हम जलने की इंसिडेंस से अपने को बचाना चाहते हैं। अब अगर हम देखें कि मैनेजमेंट बर्न का क्या होना चाहिए, तो कुछ तो जलने की घटनाएं बहुत छोटी सी होती हैं, एक ड्रॉप ऑयल गिर गया या जरा सा उंगली में चोट लग गई, यह सब तो आप घर पर ट्रीट कर सकते हैं, जरा सा कोई ऑइंटमेंट, कोई चीज़ें। और हमारे भारत में तो हर आदमी डॉक्टर है, तो आप सोच सकते हैं कि हर आदमी इलाज के लिए 100 तरीके बता देगा, तो उन पे ध्यान न दें। जो डॉक्टर ने कहे हुए हैं या जो आपको किसी ऑथेंटिक सोर्स से पता है वही करें। कोई भी 5% से ज़्यादा जला हुआ व्यक्ति डॉक्टर को या अस्पताल में उसका इलाज होना चाहिए। इसके बाद अगर किसी के फेस पे, नेक पे या हाथ पे या जेनाइटल रीजन पे, प्राइवेट पार्ट्स पे जला है, तो उसको अवश्य किसी रिकॉग्नाइज्ड डॉक्टर को दिखाकर अस्पताल में इलाज लेना चाहिए। इसी तरीके से अगर कोई शरीर का मेजर जॉइंट इन्वॉल्व्ड है या साथ में कोई और इंजरी भी है बर्न के, या कोई और भी बीमारी साथ में है, डायबिटीज़ है, हाइपरटेंशन है, ट्यूबरकुलोसिस है, जो कि सबसे कॉमन चीज़ें हैं यहाँ पर, या किसी भी तरीके की और कोई बीमारी है किसी को और उसके साथ उसे बर्न हो गया, तो उसे कभी भी अपने से या इधर उधर इलाज न करके अस्पताल में डॉक्टर की सलाह जरूर लेनी चाहिए। इसी तरीके से प्रेग्नेंट विमेन हैं, बहुत यंग बच्चे हैं, 1-2 साल के, 4 साल के, 10 साल के, या 60 साल 70 साल से ऊपर के बुजुर्ग हैं, उनको भी अस्पताल में सलाह जरूर ले लेनी चाहिए। कभी भी प्रेशराइज्ड स्टीम या केमिकल या एसिड बर्न या इलेक्ट्रिकल बर्न को इस तरह से नहीं लेना चाहिए कि ये एक बहुत छोटा सा बर्न इंजरी है, क्योंकि इनमें दिखता कम है लेकिन एक्सटेंट ऑफ इंजरी बहुत ज़्यादा होती है। इसलिए हमेशा एक बर्न को ट्रीट करने वाले डॉक्टर से अस्पताल में सलाह जरूर लें और उचित इलाज करें। अब हम आते हैं कि बर्न मैनेजमेंट कब से शुरू होता है। बर्न मैनेजमेंट राइट ऑन साइट, मतलब जिस जगह पर इंजरी हुई है वहीं से शुरू हो जाता है, फर्स्ट एड के फॉर्म में। सबसे पहले आपको यह देखना है कि जलता हुआ व्यक्ति या जिसको भी जलने की इंजरी हुई है वह आदमी उस सोर्स से दूर किया जाए। उस सोर्स से दूर करने में अपनी भी सेफ्टी जरूरी है। अगर खास तौर से इलेक्ट्रिकल इंजरी है किसी को, ऐसा नहीं है कि आप जाके उसको पकड़ के वहां से हटा दें। किसी सूखी लकड़ी या किसी नॉन कंडक्टर से हटाएं। अगर इलेक्ट्रिकल इंजरी है किसी को, आग से अगर इंजरी हुई है तो सबसे पहले आग का सोर्स बंद कर सकें, बहुत अच्छा है। नहीं कर सकते, उस व्यक्ति को वहां से दूर कर दीजिए और उसकी आग को बुझाने का प्रयास करें। कोई कंबल या कोई चीज डाल के नहीं, बल्कि जमीन पर रोल करके वो आदमी आग को बुझाए, वो सबसे बढ़िया है। अगर आप कंबल या कोई मोटा कपड़ा डालेंगे, आग तो हो सकता है बुझ जाए, लेकिन गर्मी अंदर रह जाएगी और इंजरी और डीप हो जाएगी। उसके बाद आपको तुरंत उस व्यक्ति को अस्पताल में या ऐसी सुविधा पे ले आना जरूरी है जहां पर ट्रेन्ड डॉक्टर अवेलेबल है। वहां वह उसका यह देखेगा और असेस करेगा, जिसके लिए डिफरेंट फार्मूले हैं, मैं उनको यहाँ नहीं बता रहा हूं। उसके हिसाब से वो ये देखेगा कि कितना जला है। जलने में हम शरीर का कितना भाग, स्किन का कितना भाग डिफरेंट फार्मूलों से कैलकुलेट करते हैं और उसमें हम डेप्थ को इन्वॉल्व नहीं करते हैं। यह एक्सटेंट हमें यह बताती है कि उस मरीज को कितना फ्लूइड की जरूरत है, कितने तरल पदार्थ की जरूरत है जो कि उसके शरीर से निकल चुका है। और शॉक को मैनेज करने के लिए इस फ्लूइड और इस कैलकुलेशन की जरूरत पड़ती है। इसी के साथ ही हमें जो वूंड है बर्न के कारण हुआ है, उसका इलाज लोकल एप्लीकेशन के साथ किसी भी दवा के, जैसे सिल्वर सल्फाडाइजीन है या कुछ और क्रीम्स आती हैं, ऑइंटमेंट्स आते हैं, उनके साथ करने की ज़रूरत पड़ती है। इन सब चीज़ों के साथ साथ हमें मरीज की जनरल कंडीशन और उसके साथ की कोई भी अगर उसे बीमारी है उनको भी ट्रीट करने की आवश्यकता होती है। मरीज के खान पान को देखना होता है और सबसे बड़ी चीज़ यह है कि जो बर्न इंजरी होती है उसको हम जितनी जल्दी हो सके उसे कवर कर दें, उसके ऊपर स्किन लगा दें, जो कि उसी व्यक्ति की स्किन परमानेंटली शरीर एक्सेप्ट करेगा। लेकिन अगर ऐसा नहीं है, उस व्यक्ति के शरीर पे इतनी जगह नहीं बची हुई कि जहाँ से हम उसकी त्वचा को ले सकें, तो हमें आर्टिफिशियल स्किन या दूसरे व्यक्ति की स्किन की ज़रूरत पड़ती है, जिसके लिए अब हमारे देश में कुछ कुछ जगहों पर स्किन बैंक अवेलेबल हैं। अभी हमें इस क्षेत्र में बहुत कुछ काम करना बाकी है। कायदे से हमारे देश के हर कोने में स्किन बैंक होने चाहिए, जिससे जितनी जल्दी हो सके हम बर्न पेशेंट को कवर कर सकें, उसके वुंड्स को। थैंक यू। इसके बाद हमें ध्यान देने की ज़रूरत होती है कि एक बार वह मरीज ठीक हो गया, उसके घाव भर गए, तो हम उसको समाज में फिर से कैसे वापस ला सकें। क्योंकि जला हुआ मरीज न सिर्फ शारीरिक रूप से बल्कि मानसिक रूप से भी काफ़ी परेशान हो जाता है। उसकी नौकरी चली गई या उसको समाज से बहिष्कृत कर दिया गया, बहुत सी चीज़ें ऐसी हैं। उसको खुद को लगता है कि मेरी गलती क्या थी और मैं इस तरह से जल गया, दुनिया में मैं ही एक आदमी हूँ जो इस तरह से जल गया। तो ये सारी चीज़ों का भी ध्यान रखना पड़ता है और इसके लिए हमारे साइकोलॉजिस्ट, मनोचिकित्सक काम में आते हैं, उनकी भी सहायता लेनी पड़ती है। फिर बर्न से जो भी डिफॉर्मिटी हुई हैं, जो भी डिफेक्ट हुए हैं, उनको इस तरह से ट्रीट करना आवश्यक है कि मरीज सबसे पहले तो काम के लायक हो, जो कुछ भी जितना भी हो सके नॉर्मल साधारण अपना काम, अपनी कार्य क्षमता में वह स्वतंत्र हो सके। और उसके बाद हमें ये देखना होता है कि जो भी उसको देखने के कारण, लोगों के देखने में त्रुटि है या शक्ल अच्छी नहीं है, उसके लिए फिर हम प्रयास करें। पहले हमें उसके काम करने के लायक बनाना है, उसके बाद उसकी शक्ल सूरत को ठीक करने के बारे में ध्यान देना है, बट वो भी इम्पॉर्टेंट है। अब हमारे देश में इस वक्त किस किस चीज पर ज्यादा ध्यान देने की जरूरत है बर्न मैनेजमेंट में? एक तो हमें एग्जैक्ट एक्सटेंट कितने बर्न इंजरीज हमारे देश में होती हैं और कितना भयावह यह बीमारी हो सकती है, जैसे कि हमारे पास मलेरिया है, ट्यूबरकुलोसिस है, इन सब के हमारे पास डाटा उपलब्ध है कि देश में कितना हो रहा है पर ईयर और कितना हमें ध्यान देने की ज़रूरत है। लेकिन बर्न के लिए ऐसा नहीं है। हम सभी इस बात पे प्रयासरत हैं कि हमें बर्न रजिस्ट्री करने दी जाए। जहाँ भी कहीं कोई बर्न इंसिडेंस होती है उस जगह पे हम उसे नोटिफाइबल बनाएं और इस तरह से हमारे पास सारे रिकॉर्ड, सारी चीज़ें उपलब्ध हों जिससे हम ये बता सकें कि हाँ, हमारे यहाँ बर्न इंसिडेंस ये है और हमें यह करने की ज़रूरत है। फिर हमें पब्लिक अवेयरनेस, जागरूकता फैलाने की ज़रूरत है पब्लिक में कि हम किस तरह से बर्न के इंसिडेंसेस से अपने को बचा कर रखें। यह हम सबका कर्तव्य है कि हम अपने को भी बचाएं और दूसरों को भी बताएं कि यह किस तरह से बचा जा सकता है, क्योंकि बर्न इंजरी एक ऐसी इंजरी है जो अधिकतर प्रिवेंटेबल है, लेकिन उसके बाद भी बर्न इंजरी हो सकती है, एक्सीडेंट्स हो सकते हैं। उसके लिए हमें प्रॉपर रेफरल सिस्टम क्या होना चाहिए, कौन कहाँ तक इलाज कर सकता है, कितनी इंजरी तक, यह सारी चीज़ें भारत सरकार की तरफ से बनाया भी गया है और इसको डिस्ट्रीब्यूट किया जा रहा है कि आप किस किस जगह पे रेफ़र कर सकते हैं और कहाँ कहाँ कितना एक्सटेंट तक इलाज हो सकता है। हमें और भी बर्न केयर सेंटर्स खोलने की ज़रूरत है। अभी हमारे पास बहुत कम बर्न केयर सेंटर्स हैं देश भर में, तो उस पर भी कार्य करने की ज़रूरत है। ऑफकोर्स डॉक्टर सुनील केशवानी ने बहुत एफर्ट किए हैं स्किन बैंक के लिए और वो बहुत कुछ सक्सेसफुल रहा है, और इनके प्रयास से और भी जगहों पर देश में स्किन बैंक्स खुल रहे हैं जो अर्ली क्लोजर ऑफ बर्न वुंड में बहुत सहायक हैं। लेकिन हमें और ज़रूरत है कि और ज़्यादा से ज़्यादा स्किन बैंक खुलें। इसके लिए भी हमें दोनों स्तर पर प्रयास करना पड़ेगा। एक तो हमें स्किन बैंक्स बनाना है और दूसरा पब्लिक को अवेयर करना पड़ेगा कि वो स्किन डोनेट करें। अगर पब्लिक स्किन डोनेट नहीं करेगी तो स्किन बैंक का कोई फ़ायदा नहीं है। और जैसा मैंने बताया, साइकोलॉजिकल सपोर्ट और रिहेबिलिटेशन बर्न पेशेंट का तो उतना ही आवश्यक है जितना उसका इलाज आवश्यक है। इसके लिए एक प्रिवेंशन के ऊपर एक नेशनल प्रोग्राम ऑफ प्रिवेंशन, मैनेजमेंट एंड रिहेबिलिटेशन ऑफ बर्न इंजरीज का गवर्नमेंट ऑफ इंडिया ने मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर की तरफ से ये चल रहा है प्रोग्राम। इसमें हम जगह जगह पर बर्न सेंटर खोलने के लिए सरकार आर्थिक सहायता भी देती है और वहाँ के सर्जन्स को और प्लास्टिक सर्जन्स को भी ट्रेन करते हैं और फिर उन्हें अपनी जगह पे, अपने स्टेट में, अपने शहर में और लोगों को ट्रेन करने के लिए प्रोत्साहित करते हैं। अब बर्न प्रिवेंटिव अवेयरनेस, मैं प्रिवेंशन पे थोड़ा सा बोलना चाहूँगा। हम किस किस लेवल पे हमें ज़रूरत है। हमें घरों में बताने की ज़रूरत है, स्कूल्स में बताने की ज़रूरत है, कॉलेजेस में, पब्लिक प्लेसेस पे, लोकल कम्युनिटी लेवल पे, इंडस्ट्रीज़ में जहाँ पे कि जलने की इंसिडेंसेस बहुत होती हैं और कभी कभी मास कैजुअल्टीज़ होती हैं, इतना बड़ा इंसिडेंस हो जाता है। इलेक्ट्रिकल प्लांट्स में, ट्रांसमिशन प्लेसेस पे लोग क्या करते हैं कि ट्रांसमिशन लाइन ऑफ की, लाइनमैन काम करने गया और ड्यूटी बदल गई और दूसरे आदमी ने आके स्विच ऑन कर दिया। इस तरह की चीज़ें जो लापरवाही है, जो अज्ञानता है, इसके लिए और इन सब चीज़ों को करने के लिए हम NGOs को अपने साथ उनकी सहायता ले सकते हैं, क्योंकि उनकी रीच समाज में बहुत ज़्यादा होती है। बच्चों में बहुत ज़रूरी है, क्योंकि अगर आप ध्यान दें तो आपने 6th 7th 8th में जो चीज़ें पढ़ी होंगी या जो चीज़ें समझी होंगी वह आप ज़िंदगी में सबसे ज़्यादा याद रखते हैं। 9th 10th 11th में या 5th के पहले जो चीज़ें आपके साथ हुई हैं उसमें बहुत सी चीज़ें आप नहीं याद रख पाते, क्योंकि उसके पहले ब्रेन डेवलपमेंट ज़्यादा नहीं है, और 9th 10th स्टैंडर्ड से आपके डिस्ट्रैक्शंस बहुत ज़्यादा होते हैं, बहुत सी और चीज़ें इंपॉर्टेंस रखती हैं। लेकिन 6th 7th 8th के बच्चे को अगर हम यह हैमर करें, उसके दिमाग में बार बार यह बात डालें कि इस तरह से सावधानी रखने से हम बर्न इंजरी से बच सकते हैं, तो उसके लिए सबसे ज़्यादा फायदेमंद होगा। और न सिर्फ वो बच्चा बल्कि उसके घर के लोग, उसके टीचर्स, स्कूल में काम करने वाले, और इस तरह से कम्युनिटी लेवल पे भी यह बातें फैलेंगी, और धीरे धीरे जब वो बच्चा बड़ा होगा तो वो अपने बच्चों को सिखाएगा। इस तरह से हम 1-2 जनरेशन में सारी अवेयरनेस को फैला सकते हैं अगर हम इस पर कायदे से काम करें। अब एजुकेशन कैसे हम दे सकते हैं इन बच्चों को? इनको ये जो बर्न प्रिवेंशन प्रोग्राम है उससे अवेयरनेस से जुड़ी हुई बातें हैं, इनको स्कूल के करिकुलम में ले आएं। बच्चे को पढ़ाने के उसमें पाठ्यक्रम में कम से कम एक चैप्टर रख दें। बीच बीच में इंटरैक्टिव सेशंस और अवेयरनेस प्रोग्राम्स स्कूल में रखें। बुकलेट्स, पैम्पलेट्स, पोस्टर्स उनको लगाएं भी और उन्हें डिस्ट्रीब्यूट करें बच्चों को। बच्चा खुद तो पढ़ेगा ही, जो नहीं पढ़ेगा, जो नहीं समझ में आएगा उसे वो घर में ले जाके घर के मेंबर्स से डिस्कस करेगा, और इस तरह से हम उस प्रिवेंटिव प्रोग्राम को आगे बढ़ा सकते हैं, बच्चे में अवेयरनेस ला सकते हैं। इस तरह से आग बहुत अच्छी है और बहुत यूजफुल भी है। सारे काम हमारे बगैर आग के नहीं हो पाते हैं। हम पूजा भी करते हैं तो आग जलाते हैं, लेकिन यह तभी तक हमारे इस्तेमाल के लिए ठीक है जब तक कि वह हमारे कंट्रोल में रहे। थैंक यू।
थैंक यू सर। सर ने बहुत ही खूबी और बारीकी से बर्न्स के बारे में हमें बताया है। Sir has included the burn injury facts, the regional and socio-economic factors, and he has explained the management pretty well. The highlight of the session was prevention, that is, teach them young. Sir has also included how we can include awareness activities at the community level. Sir, I thank you for this informative session. So please wait.
I request Madam Sebin Bisho to felicitate Sir. Sir, this way. I invite Madam Rohini to felicitate our moderator, Madam Sebin Bicho.
Thank you, Sheetal ma'am. For the next panel discussion, I would like to invite our chairperson for the conference, Dr. Akansha Wage. Ma'am has completed her PhD in child health nursing from SNDT Women's University. She has completed Masters in Nursing in Child Health Nursing. She has also completed PG Diploma in Education Management from SNDT University. Ma'am is a dynamic teacher and she has a vast experience of 27 years. I welcome ma'am to introduce the speakers.
आपका पैनल 1 है ना? आपको कौन सा चाहिए? हाँ।
Good afternoon, one and all. Today, we are starting with the first panel discussion on first aid saver for burns. We are starting it right at 12 noon, right the sun on our heads. And definitely, I would like to invite the panelists. I would start introducing them. By then, they are arranging the dais for them. The moderator for this session is Mrs. Prajakta Samir Hindlekar. She is the Director, Nursing Chief Experience Officer of Breach Candy Hospital Trust. She has been a nurse for more than 29 years in various roles, both in India as well as USA. Currently, she is working in Breach Candy Trust Hospital as a Director Nursing and Chief Experience Officer. Previously, she has worked with Global Hospitals Group as Chief of Nursing, Deputy Chief of Nursing and Nursing Supervisor. She has also been as an Assistant Lecturer in LT College of Nursing SNDT. She has worked in Shady Grove Adventist Hospital, Maryland, USA, and a charge nurse, preceptor, and RN. She has been a preceptor for Johns Hopkins University, Baltimore, USA, and Maryland College of Nursing, USA. Worked as a sister tutor at Bombay Hospital and MRC, has been an organizer and faculty for various international and national workshops, webinars, and conferences. She has contributed to books and journals. She has a very good hobby of classical dancing, and she's also the General Secretary of Critical Care Nurses Society, member of TNAI, SOMI, and ANEI. I welcome Ma'am Prajakta on the dais. Thank you. Now I welcome the speakers for the panel discussion. First, Mr. Samuel Fernandez. He is the professor cum principal of SSR College of Nursing, Vapi. He has completed his master's in cardiovascular thoracic nursing from RGUHS Bangalore. He has done his post-basic nursing from Shivaji University, Kolhapur. Worked as a staff nurse, lecturer, associate professor at College of Nursing, Vanlis Hospital, Meerut. He has also worked as an associate professor cum vice principal at Siagat College of Nursing, Pune, and SSPM's College of Nursing, Barshi. He has a teaching experience of 15 years and clinical experience of 6 years. I would like to invite you, sir, on the dais. He has also been in an editorial board of Siagat e-Journal and Red Flower. He has presented papers at various national and international conferences. He has been a resource person. He is member of Staff Selection Committee and Local Inquiry Committee at MUHS. He is a member of Internal Quality Assurance Cell at Bharatiya Vidyapith Deemed University College of Nursing, Sangli. And he is also a member at the Curriculum Development Committee at Shivaji University, Kolhapur. The next person I would like to invite is Mrs. Pratiksha Ramteke. She is the Deputy Nursing Superintendent of Haria LG Rotely Hospital, Vapi. She has done a post-basic nursing. She has worked in Bombay Hospital Medical Research Center, Mumbai, a staff nurse in renal transplant recovery, urology department, and medical and surgical department for 8 years. She had worked as an acting in charge operations at Global Hospital Mumbai for 2 years, as a manager in patient care services operations in Sir H.N. Reliance Foundation Hospital. Currently, she is also in charge of infection control of HRLG Roya Hospital, Vapi. Madam, please come on the dais. The next speaker for a panel discussion is Mrs. Mayuri Patel. She is the Assistant Professor of SSRC in Vapi. She has done a Master's in Nursing in Obstetrics and Gynecological Nursing. Her key achievements are she has sports achievement at university level, NSS achievements at state level competition in BSc Nursing, has been persuaded approval of Assistant Professor and Postgraduate Teacher for VNSGU Surat. Her work experience is of total 9 years, teaching at Sri Pukraj Nagaraj Ranka Hospital of Nursing, Pune, and Sandra Shroff ROFEL College of Nursing, Vapi. She is the member of Society of Midwives India. She is a reviewer of manuscripts in International Journal of Nursing Education and Research. She has been a resource person at various conferences and workshops at both state and national level. Ma'am, I invite you on the dais. Now I would like to hand over the session to Madam Prajakta Hinrekar.
A very good afternoon to one and all. We have a very short panel, and I'm sure the earlier session was very simple, and I think it is very informative. And we will try to speak in Hindi in between our panel. तो जो भी यहाँ पे nurses है, students है, I'm sure in our first year of nursing we learn first aid, isn't it? Yes or no? Do you remember? Yes. So इसके लिए ये हमारा यकीन है कि फर्स्ट एड बहुत ज़रूरी है. इसके लिए पहले ही पैनल में हम फर्स्ट एड सेवर फॉर बर्न्स आज प्लान किए हैं. तो क्यों हम ये सेशन रखे हैं? क्योंकि वी बिलीव दैट सेफ्टी एंड सिक्योरिटी कम्स इफ यू नो दैट आई नो व्हाट टू डू व्हेन देयर इज बर्न्स. एंड आई रिमेंबर एज अ स्टूडेंट our community health nurse teacher who taught us first aid, she has told us that you will be forever community health nurse. तो एक जिम्मेदारी बनती है कि हम लर्नेड हो. जैसे सर ने कहा, जो चीज़ ही करनी है वही हमको अच्छी तरह से पता होनी चाहिए, है या नहीं? Yes. So knowing first aid in various kinds of burn will help you know not only save lives, but also it will help you relieve pain in that first 20 crucial minutes. Also, it will help you prevent worsening of situation, which can be done in that first 20-30 minutes. Also, reassurance. I think very importantly, sir, first slide only he said, once a burns patient, it's a forever burns patient. So that first reassurance, tender loving care, touch, is very important as a first aider. Sometimes the panic and anxiety is more dangerous and harming, isn't it? So therefore, in today's panel discussion, we are going to learn first aid for various kinds of burns, and then we will take just 2 questions if the time permits. So I have esteemed panel with me, Professor Samuel. First question is to you. Can you tell us how do we give first aid when there is any thermal or electrical burn?
Good morning. I'm happy to be here before you all. And it's my pleasure to talk on the topic which is given to me and which is very essential to know about, because the percentage of this electrical and the thermal burn tells us that it is a minor, but it is a serious as well. As the sir has explained about the electrical and thermal burns, you may see that injury is not from outside, but from within. It is a serious injury. So if you see electric injury, we understand that actually something which is open circuit, if we touch that circuit, then we face consequences in the form of electricity which runs through our body. And then what happens after that? Damages our vital organs, which is lethal for the person's life. Some of the causes that we need to know about is the lightning, stun guns. Stun guns is something which actually we are not very familiar with. Stun gun, which is used to stop the attackers. If suppose somebody is attacking you, you can use that stun gun and you can actually make person still stand at the place wherever he is, and you can stop his attack. And rest of the causes which are already described by the sir, so I'm not going to touch that. This is the diagram which we see of the person who experiences burn injury. We see person lying down on the floor. Very, very important symptom that we see in a person who has electric shock. The twitching of the muscles is a very important symptom that we see, and person sometimes becomes unconscious. So this is very important symptom that we see in person. Burns, if you take this along with you, you'll understand what is a burns. Back away means to be safe from the scene. Uncover, rinse, enclose, and seek. These first letters stands for burns. So if you know only this much, you'll understand how you can actually protect from the burns. Since actually we have to touch only the aspect called first aid, so here something I have before you. Look at the affected person, but do not touch them, as electricity can pass on to you. So what is very important here in this case, if you see a victim having electric shock, you should not go and touch the patient and try to actually take out the person from the area, but see to it. Next thing is that actually you need to call for the help. And in India, this is not the number of India for the burns, but the number of India for India is actually 112 for the burns. So you can call on that to get help. Turn off the electricity source. Turn off the electricity source and before touching to the patient, which is very essential. Otherwise, you will become victim yourself. Once it is confirmed that actually you have turned off the electricity source, what is very important then, as I said, a person may develop, person may actually go into the cardiac arrest. So what is very important is actually we need to go for assessment of the signs and symptoms of cardiac arrest. And if that is the case, then we have to provide a CPR to the patient if it requires. Victim if slightly, actually, if victim is on the floor, what is very important, one more thing that we have to do is, we have to take patient's foot end at the upper end so that actually patient's head will be down and circulation will be maintained by way. So if at all any wound, you can see on the patient's entry and exit source of the electricity, you can very well find out. This is the picture that we can see how we can protect ourselves from not getting involved with the electric current. Now the thermal burn. As we know that actually some of the sources like hot object, boiling water is the commonest source for getting involved with the burns, thermal burn. What are the common causes that we see in the thermal burn? Primary cause, as we said, that dry and wet sources. If you come in contact with the dry and wet sources, there is a chance to get a thermal burn. Burns from wet sources, also called as the scalds. Dry sources of heat are the fire flame, hot metals, glass, and the other objects. Scald can be caused by hot water, oil, and the other liquids. Hot steam is the commonest cause for these scald burns. You can burn your airway if you breathe smoke or the steam, and that is how actually you need to be very careful about wherever there is a burn situation exists. Thermal burn, as I said, actually, we can categorize into category 1, 2, maybe it is also called as actually first degree, second degree, and third degree. So here in this case, first degree involves only dermis, second degree, dermis, epidermis, and third degree, or which is also called as a full thickness burn, which involves all the adjacent structures like veins, arteries, and the nerves. Symptoms like pain is very prominent, blisters, swelling, red, white, and charts like a skin. Skin looks like a peeling. How do we manage this thermal burn? Very simple and very essential thing that we need to do. We need to pour the water, not too cold, but actually cool water. So here, if we pour the cool water, more than 10 minutes, up to 20 minutes, we can pour the water on this kind of a burn, then person's injury will be minimized. Remove clothing, jewelry from the affected area of the person. Don't apply lotion, oils, or break the blisters. A reason is that person will develop infection. If it is available at the hand jelly or the aloe vera, then you can apply it on the skin, but make sure that the area is clean. Loosely bandage the burn area wherever you have seen the burn on the victim's face or maybe on the body. Take over the counter that the pain relief, if available, because we're talking about the first aid, it may not be available, but if it is available, you can give it to the patient. As we said, pain is severe in this case. This is something which we can remember. As I said, actually, more than 10 minutes, cool water need to be poured on the burn area, but we should not actually apply any sort of jelly, gel, ointment, so which will actually give rise to the development of infection. And things will become more worse for the patient, and in fact, for the doctors to treat the patient. As we said, actually 73% of the burn injuries happens at home, so home things actually need to be corrected. Don't leave your kitchen unattended while cooking. Use the back burners of your stove and keep handles turned away from the edges. Always have pads readily available when cooking, or can you use
Professor
aprons?
Samuel, can I request you to be brief, please?
Yes, ma'am.
We have paucity of time, so sorry.
Yeah. So here actually we have learned about how we can take care of the electric as well as thermal burns. This is something which is related to the first aid management. Thank you so much for tolerating me.
Thank you, Samuel. I think next we'll call Pratiksha to tell us about first aid management in chemical and inhalation burns.
Good afternoon, one and all. Thank you very much for giving me an opportunity to participate this conference. I think Dr. Keshwani, Professor Samuel, and Prajakta ma'am have already discussed in details on the burn, so I'm not going to take you much time. Just I wanted to elaborate the what will be the immediate action when the chemical burns. First, we'll have to remove the clothes or the jewelry, which and rinse the chemical off for at least 20 minutes. But while doing this action, we have to just keep that mind कि वहाँ जहाँ पे chemicals गिरा हुआ है तो just rinse करते वक्त और कोई body parts उसमें involve ना हो, and make sure कि जो भी आप water rinse कर रहे हो वो strong या फिर warm ना हो. Once you flush the chemical injury or the chemical flash, then you have to remove the jewelry or the clothing and make sure it not stuck in the body parts. Or else the wound is deep or the thickening, you have to wrap with a sterile dressing, or you can use a sterile or a clean cloth and just give the loose dressing. Now we'll see the inhalation. When the person goes in an inhalation burn, just keep open windows, put on the fans and remove the person from that area, or else the smoke, whichever the part is with the smoke, just keep away the person from the smoke area. Check the vitals, check the circulation part, check the breathing, whether the patient is breathing properly, vitals pulse is properly. And the person, if the person goes unconscious, just check the response with the pulse, respiration, and if it is patient is unconscious and he is not giving or she is not giving any response, then start the CPR. Or else till the emergency or the ambulance comes, or we will take minutes for the ambulance call or the till we reach to hospital. Till that you have to give the CPR. So we can prevent the patient to goes in cardiac arrest. Okay, ma'am. Thank you very much.
Thank you, Pratiksha, for keeping up with time. We have a last panelist who is going to enlighten us on prevention and treatment of minor burns at home.
Good afternoon, everyone. Thank you so much to giving me this opportunity to speak here and being a part of the panel discussion. So my thing is prevention and treatment of minor burn at home. So in a first session only, I know very nicely Dr. Srivastav had dealt with prevention. So as we know that 50% of or more than that will be the child will get burns, and then women's. Fine. So I will go with the do's and don'ts. So first, cool burn with the water till the patient is comfortable. So maximum 20 minutes. Apply a clean dry cloth to the burn area after it is cooled. Then remove the jewelry and other items and see the doctor or health practitioner. And what you should not do is use very cold water or ice on a burn, because it will more irritate the wound. Then apply ointments, jellies, spray, first aid, cream or butter, because many folk tales are there, like coconut oil is very useful for every injuries and all. So this should not be used because it will again worse the wound. Remove burn clothing that is stuck to the body and break open small blister. Don't do that, because it is very tempting when blister is there, we want to break it. So you should not do it. So very shortly we can see, like, we have to prevent first, so take action to prevent burns, like children should be away from the kitchen area, or lighters and the matchboxes should be keep away to reach the children. Then if you are a smoker, then if you are smoking, so you should not smoke when you are using oxygen, home oxygen, and the overhead wires and all should be kept properly. It should not be overhead at the at home. Then there should not be any underpass wire under the carpet and all, because that will also again we have to be very cautious. It will get again electric burn. So that those are the things. And at every home there will be fire extinguisher, and people or a home family member should know how to use it. Okay? And then remove, as I already told, remove yourself from danger and remove any clothing or jewelry unless stuck to the skin. So if it is stuck, so you should not remove. Place the burn under cool water and for 20 minutes. Cover the burn with a clean dressing, and if you feel it is not a first degree burn, then definitely you should go to the doctor. Thank you so much, ma'am.
I'm very thankful to Mayuri for making it simple and very short. So we respect time, and so we can have our other sessions on time. So just to add, I think as nurses, it's a must-have competency, isn't it? All of us are learning competencies. So first aid saver, knowing what is first aid for each type of burn is a must-have competency for all of us. Also, I would like to say that as a nurse, we should be brand ambassador in creating public awareness, not only for preventing burns, but also how to render correct first aid. So take home message, I would request panelists to give us in 30 seconds if they can quickly.
Thank you, ma'am. Take home message is that actually, why do we need to understand why we have to learn the burns. There's a simple reason is that whatever we have learned, we have to teach it, give it to the others, those who are unaware about the things. We make them aware so that prevention will be better than cure. Thank you.
It can be a flash with a small splash. अगर कुछ छोटा सा splash आ जाता है, भले चाहे वो burns का मतलब fire का हो, chemical का हो या और किसी चीज़ का, which the things is hot, तो वो एक lifelong या फिर forever movement के लिए वो flash रह जाता है body ऊपर. तो be safe whenever means अगर कहीं पे भी अगर safety rules है तो please follow that rules to prevent the burn. Thank you.
Always be preventive, because preventive is better than cure.
Thank you, ma'am.
I thank all my panelists for adding and contributing as well as refreshing whatever we have learned in first aid. And I'm sure whatever is shared in this panel will be very useful. To add my few cents, I would put it as 3 C's. First C is, any guesses? First C, Cool, yes. And please remember, no ice water, just simple tap water. And other C is calling for help. Very, very important. I think in an organization, all of us know when there is a fire, everybody has very well established code red, right? So being a part and knowing what we do, even if in organization the fire emergency happens, very important, where to call and what to do. And third C, any guesses? Any guesses from this session or the previous session? Cover, very important. If you cover it, you are going to prevent life-threatening injuries, sepsis. I think two doctors and they will all agree, very important, covering it so that till we get the medical care, the burns wound is protected. So with this, we end our panel, I hope. Because of the paucity of time, we can't take questions, but if you have any questions, you can reach out to us. Thank you, everybody.
Thank you for the wonderful session. I request Dr. Akansha Wage to felicitate the moderator, Ms. Prajakta Hindlekar. I again request Dr. Akansha Wage to felicitate the speakers for the day, Professor Mr. Samuel, Ms. Pratiksha, and Ms. Mayuri Patel. Thank you, ma'am. I request Ms. Prajakta Hindlekar to felicitate the chairperson, Dr. Akansha Wage. So without wasting time, we would begin with the next session. I once again thank the moderator, the chairperson, and the speakers for the last session. Thank you so much. Our next session is beautifying the burns under the scalpel. To introduce our speaker, I request Ms. Rohini Khadke, who is presently working as a faculty in LT College of Nursing, SNDT Women's University, Mumbai. She has completed her master's in obstetrical nursing, and Ms. Rohini is also a PhD scholar. She will be the moderator for the next session. Over to Ms. Rohini.
તમે સૌને શુભ બપોર. Good afternoon to one and all. Our next session is going to be informative. Topic itself, it is beautifying the burns under the scalpel. Actually, sir requires no introduction. Words would fall short if I start speaking. I'm really glad to introduce to you all our dear sir, the dynamic, renowned personality, Dr. Sunil Keswani. Sir is a medical director and head of Department of Plastic Surgery, National Burn Center, Mumbai. Past president of Indian Medical Association, district officer of Rotary District 3141, ex-regional representative for Southeast Asia for the International Society for Burns Injury for 6 years. Dr. Sunil Keswani commissioned the National Burn Center in Navi Mumbai, first dedicated state-of-the-art burn care center in India. He has been instrumental in setting up the skin bank at National Burn Center in Navi Mumbai and 8 other skin banks in rest of the India. He has been the recipient of several orations, some of which are Dr. Bhimandas Bilwani oration conferred by National Academy of Burns India, Safdarjung Hospital oration conferred by National Academy of Burns India, Bansali oration conferred by Indian Association of Occupational Health Doctors, Menda Salaskar oration conferred by Bombay Medical Congress, Trinity oration of the Sion Hospital LTMG Medical College. He is crusader for burns prevention and has been running a burns prevention program in the city of Mumbai for last 30 years. He has contributed many chapters on burns in several textbooks and several publications in various national and international journals. We are glad to have you, sir. Over to you. Yes.
I think we have made a wonderful start with a beautiful, scintillating, all-encompassing lecture by none other than Dr. R.K. Srivastava, who's a favorite of mine, wonderful speaker, great human being, and a surgeon par excellence. Thank you, Dr. Srivastava. The panel discussion was very educational and covered all the aspects. Difficult to cover all the aspects, all different types of burns in the 20-25 minutes, but fairly well covered the good take-home messages. We're talking now about the surgical management in burns, and we'll just cover a few things in about the next 15 minutes. Can it be connected? Right here? Yeah, okay, should be all right. Yeah. Now, essentially, the surgical management of burns can be categorized into two sets. One, जब freshly burns होता है, जैसे acute burns कहते हैं, immediately burns के बाद कौन सी surgeries की जाती हैं. And secondly will be the management of post burn sequelae, कि burns heal होने के बाद क्या क्या problems आते हैं, deformities आती हैं, contractures आते हैं, white marks आते हैं, dark hyperpigmentation आता है. So essentially we will talk about it very quickly. Now, timing of surgery. In acute burn, the timing of surgery can be either early, delayed or late. आजकल कहा जाता है कि burn wound को जल्द से जल्द resurface करना है, dead tissue को जल्द से जल्द निकाल के फेंक देना है. Because of the dead tissue, the patient gets into bacteremia. Bacteremia से septicemia होता है, और septicemia से multiple organ failure होने की वजह से patient अपनी जान खो बैठता है. So I think it's extremely important today. The buzzword is, the standard treatment is early excision and grafting. वो जो grafting होता है, patient का खुद का skin नहीं निकाला जाता है आजकल early excision में. You have to take the skin from someone else. जाके skin bank की skin, जिसको allograft कहते हैं, वो लगाया जाता है. तो तब तक वो burn wound कवर किया जाता है, पेशेंट का पेन कम हो जाता है, पेशेंट के बैक्टीरिया अंदर नहीं जा सकते बाहर से बॉडी के अंदर, बिकॉज स्किन वुंड कवर हो गया है. पेशेंट का प्लाज्मा लीकेज तुरंत बंद हो जाता है बिकॉज ऑफ द कवरेज. सो दैट इज वेरी वेरी इंपॉर्टेंट. नाउ व्हाट आर द वेरियस टाइप्स ऑफ एक्सेशन? वन इज टेंजेंशियल एक्सेशन. टेंजेंशियल एक्सेशन वो है जो हम्बीज नाइफ को लेके थिन लेयर्स ऑफ डेड टिश्यू काटते जाओ जब तक ब्लीडिंग शुरू हो. एक बार ब्लीडिंग शुरू हुई मतलब आप लिविंग टिश्यू में पहुंच गए हो, और लिविंग टिश्यू के ऊपर यू कैन पुट योर एलोग्राफ्ट. Fascial excision कब किया जाता है? Fascial excision means excision of all the skin up to the fascia. Skin and subcutaneous tissue is excised. ये generally either very deep third degree burns या badly infected burns में किया जाता है, जहाँ skin and subcutaneous tissue is removed right up to the fascia, above the fascia. I think the battery is down. The other thing is, in electrical burns, many a times the whole limb becomes gangrene. पूरा हाथ गैंग्रीन हो जाता है, या करंट अगर पैर से भी चला गया तो पैर भी गैंग्रीनस हो जाता है. तो उसकी वजह से वो जो गैंग्रीनस पार्ट है वो ड्राई गैंग्रीन में जाता है बिकॉज लैक ऑफ ब्लड सप्लाई, एंड वो डेड टिश्यू को जल्द से जल्द निकालना पड़ता है. नॉर्मली वी वेट फॉर अबाउट 4 to 6 days for demarcation to occur, and then we remove that particular part. So I think it's extremely important that you should be able to understand the extent of damage in electrical burns, because उसको कहते हैं कि the burn that you see, you just see a wound of entry एक नज़र आता है जहाँ से current अंदर गया, और एक wound of exit नज़र आता है. Wound of exit is normally bigger than the wound of entry. But along the path of the current, a wound of entry or wound of exit के बीच में, it will damage your vessels, blood vessels, it will damage your nerves, it may damage your bones also many a time. So you have to assess the extent of the damage in the first 4 to 6 days and then decide कि किस level पे amputation करना चाहिए. नहीं तो जल्दबाजी में if you do an amputation, you may have to keep on revising the amputation repeatedly, which can be very traumatic to the patient and the relatives. Okay, ठीक है, right. So change with this one. Yeah. Now, what are the wounds which benefit from the early excision and grafting? Generally, these are wounds which are second degree burns, where you second degree deep or third degree burns. Many a times, if you're confused कि second degree superficial है या second degree deep है, better not to excise. Never excise the living tissue. So benefit of doubt देके just treat it like a second degree superficial burn if you're confused. And then only when you're sure it's second degree deep or third degree should early excision be done. These are the two categories of early excision. One is the early total excision, where you remove all of the dead tissue. When the burn wound is less than 20, 25, 30%, you can remove all 25% at one shot. But whereas the burn is more than 25%, is 60% or 80%, in which case not more than 20, 25% is excised one time. In a sequential phase, every 2 days you go on excising 20, 20, 20. So by the end of 8 to 10 days, all 60% has been excised. Now, when you excise a wound, the wound has to be resurfaced. कभी भी skin dead tissue आप निकालते हैं patient के body से, तो उसको resurface या cover करना बहुत ज़रूरी है. Because otherwise the scar will reform. Now, coverage के लिए you can either use the allograft, that is skin from the skin bank. You can use autograft, patient की खुद की skin, अगर उसके पास enough donor area है, percentage of burns is less. Or there are various dermal substitutes available like Transcyte, BioBrain, Alloderm, Integra, or cultured epidermal autografts. Now, this is the example of a patient with early excision. एक deep burns था, you excised. By the third day, put allografts. ये allografts लगाए गए हैं वहाँ पे. ये excision दिखा रहे हैं. Excision to fascia. Fasciotomy. Now, this is fasciotomy. जबकि पेशेंट को इलेक्ट्रिकल बर्न्स किया होता है, तब पेशेंट का कंपार्टमेंटल प्रेशर्स, व्हाट इज नोन एज फेशियल कंपार्टमेंटल प्रेशर बढ़ जाते हैं. वो अगर रिलीव नहीं किया गया तो गैंग्रीन काफ़ी हद तक फैल सकता है. सो विद इन द फर्स्ट 4 to 6 hours, the fasciotomy has to be done. That means you cut the skin, the subcutaneous tissue, and the fascia till the edematous muscles can pop out. So that's the level of fasciotomy, in spite of which there will be some amount of dead tissue or gangrene, but you have limited the amount of dead tissue that is formed. These are the preferred site for the escharotomy incisions. Most of these are mid-axial lines. The mid-axial line of the upper extremity medial and lateral lines of the lower extremities. और ये बताया जाता है, ये स्लाइड बताती है कि अर्ली एक्सेशन क्यों करना चाहिए. जैसे मैंने कहा कि इफ यू लीव द डेड टिश्यू बिहाइंड, there will be colonization by the bacteria, there will be bacteremia, there will be septicemia, and multiple organ failure and death. So to prevent this sequence, to prevent the patient from dying, you have to remove the patient's dead tissue within the first 48 to 96 hours. ये अर्ली एक्सेशन के और भी फायदे हैं. एक, इन्फेक्शन प्रिवेंट करता है. दूसरा, वुंड को कवर किया गया है तो पेन नहीं होता पेशेंट को. पेशेंट जल्दी मोबिलाइज कर सकते हैं बिकॉज उसका वुंड कवर हो गया, पेन नहीं है. There's a better functional recovery because patients start doing physiotherapy earlier, and early exercise किया गया है तो antibiotics कम लगते हैं. Patient जल्द से जल्द घर भी जा सकता है क्योंकि wound heals a little faster. As I said, not more than 20% at a time, allograft or autograft. अगर more than 60-80% burns है तो कौन से sequence में जाना चाहिए? Normally trunk, thighs and legs को पहले exercise करते हैं, फिर joints and neck, and for hands and face every 2 days. This we mentioned earlier. Normally, there are various techniques to reduce blood loss, but the most important thing is there have to be at least 2 teams for a major burn. That means we require 2 anesthetists, at least 2 major senior surgeons with 2 assistant surgeons, and at least 2 nurses to assist and 1 circulating nurse. इतने लोगों का होना जरूरी है ताकि excision procedure should not take more than 2.5 hours. More than 2.5 hours, the patient will not be able to sustain the surgical trauma. Now, how is the method of infiltration? Normally, before you do the excision, एक saline adrenaline का solution बनाते हैं जिसमें 2 ampules of adrenaline in 1 liter of saline डालते हैं, and this is to be infiltrated both at the donor site and the recipient site. वो donor site पे it is subcuticular, and in the subcutaneous area in the recipient site. Almost 2 liters of saline adrenaline have to be infiltrated for 20% excision. और बहुत important है कि after you infiltrate the saline adrenaline solution, you must wait for a period of 20 minutes for full vasoconstriction ताकि bleeding कम से कम हो. उसमें नहीं आया है. Yeah. So this is the infiltration of the recipient areas, as you can see, जहाँ से चमड़ी निकाली जाती है. It's not changing there. You'll change from there. Okay. So this is the infiltration of recipient areas. Next. This is the excision. With the Humvee's knife, you get a better control. We normally don't use dermatome here. Next. As I said, for resurfacing, cover करने के लिए, you either use autograft or allograft from the skin bank, or if you don't have skin banks, we can use pig skin xenograft. And before we had skin banks, relatives of the patient would also donate their skin while they were living for their near and dear ones. Next. This is the dermatome blade. So which you can excise, remove the skin more uniformly without wastage. Otherwise, there are serrations when you use it with a Humvee's knife. Next. A very thin layer of skin is taken, medium thickness graft, 0.012 to 0.018 of an inch. Next. The dermatome can be used for harvesting skin from various sites, from the scalp, from the back. Next, which are difficult to harvest with a Humvee's knife. Next. Deep burns. Next. Excise grafted. Next. Day 12, well stuck allografts. Next. Small areas didn't heal, which were covered with autograft later on. Next. By day 24, patient was completely all right. Small unhealed areas, small patchy autografts were done. Next. Day 27, patient was already Next. Next. Yeah, this is the excision. Allograft or homograft applied. Next. Yes. Next. Then the allograft, once it got rejected, it was removed. The wound had not healed, so then autograft was applied, by which time the wound was ready to accept an autograft. Next. Shows the healing in different stages. Next. On discharge. So even an elderly lady was salvaged because of a good early removal of dead tissue and allografting first, followed by autografting. Next. Another technique is meek micrografting. When a patient has जिसको पास major burns है, some to 60 or 70% burns, that means only 30 or 40% body area उसके पास donor area है. उसमें से face के graft नहीं ले सकते. So almost 7-8% निकल जाता है. So I think it's very, very important that you have a technique. This technique say you can get expansion up to 9 times. जबकि we take expansion up to 4 times. And the results are very good. It's an expensive instrument, but it's a life-saving instrument. So you should be aware कि एक meek micrografting करके भी एक technique है जो patient की जान बचा सकता है. Normally we use a mesher, skin को mesh करते हैं और expand करते हैं. But अगर major burns है, donor area बहुत कम है, then you use meek micrografting. Next. This is how the meek micrograft is used. The skin is put on a cloth there, which is provided by the manufacturer. It's expanded, and multiple small stamp grafts are created. Next. So that is as far as surgery goes. Now, surgery में बहुत important है कि these patients are critically ill. उनका monitoring during the surgical procedure is very, very important because major burns, their physiology is hyperdynamic. You have to see that you are monitoring their ECG, the respiratory rate, with pulse oximeter, monitor the oxygenation. The temperature has to be controlled. So in an operation theater for burns and ICU for burns, the temperature has to be between 28 and 29 degrees centigrade. You can't have cold temperatures, otherwise patient will lose heat and land up with hypothermia, especially the elderly and the small children. A large bore peripheral intravenous catheter or a large bore central line should be there. And an arterial line if the patient is on ionotropes. Next. As I said, the thermoregulation is important, so maintaining a temperature of 28 to 29 degrees inside the theater is very important, which is uncomfortable for the staff who is operating, the doctors and nurses. They are sweating, but the patient does better physiologically. Next. Again, to prevent bleeding, as I said, saline adrenaline infiltration has to be done. But the gauzes also which are used to stop the bleeding, after you exercise, you put a saline adrenaline soaked gauze. You have to put about 40 ampules of adrenaline in 1 liter of saline. This is as advised by the American Burn Association. There are no systemic side effects and the bleeding stops immediately. What doesn't stop with the saline adrenaline gauze, usko cauterize karna padta hai. You use cautery. Next. Now, as I said, there are essentially 3 post-burn sequelae. One, deformity जो हो जाती है जिसको contracture कहते हैं. एक, white patches, hypopigmentation and hyperpigmentation. Next. Now, there are various methods of covering a deformity across a joint. Either you do a Z-plasty, you do multiple Z, so you get an expansion, or you release the contracture, recreate the defect, and put a graft there, split thickness graft in the peripheries, or in the face, you put a full thickness graft or a thick split thickness graft. Sometimes you have to put a flap. In case you don't want to avoid a flap, आजकल dermal templates available हैं. There is Integra, there is Matriderm, and there is BTM. And then other technique is you can also have tissue expansion where you put a balloon inside, silicone balloon in the normal area of the skin adjoining the burn scar, and you can expand the skin and use it to cover the scarred area or the contracture area. Next. 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 Again, it's extremely important that once you have done the grafting, by the 6th day, you are sure that the graft has stuck. Immediately, early mobilization and physiotherapy has to be done because otherwise stiffness will happen. And patients are given splintage and mobilized under supervision of a physiotherapist. Initially, it's active mobilization, then it's passive assisted, and then ultimately it's active and passive with more weights to regain the power of the hand, especially the hands which are affected. Next. Next. Again, it's extremely important where you put the grafts on the recipient side, you either staple the grafts or you suture it. What is important, you take quilting sutures, right, and the depth of the graft so that the graft gets firmly opposed to the recipient area, or graft can take and get stuck properly. Next. This is a Z-plasty, as I mentioned, which is a simple technique for linear contractures. Next. This is how the thing looks after the release of the contracture by a simple Z-plasty. No grafts are required here. Next. This is an axillary contracture treated by a Z-plasty. You look at the contracture, and with a Z, you easily can release the contracture. Patient gets full movement. Next. Again, another Z-plasty. Next. Sometimes you use dorsolateral flaps for flame burns, which are very good for releasing the post-burn flexion contracture of the fingers. Next. Now, in electrical burns, many times the scalp ke saath your calvarium bone also gets involved. So you sometimes do a craniotomy for EDH, done somewhere else, and then this is how it looks. Next. A flap done, anterolateral thigh flap. Next. This is a pectoralis major myocutaneous flap for a raw area on the shoulder. Next. This is a deltopectoral flap for a neck defect. Next. These are the various anti-deformity positions that you have. Most of the time, patient goes into a position of comfort and lack of pain, and the patient suddenly gets a flexion of the fingers, flexion of the wrists, the elbows get flexed, the arms get adducted, and the jaw, the chin goes down. You get a neck contracture. To avoid all this, anti-deformity splints have to be given from day 2, day 3. Next. All in all, friends, in acute burns, we find the burn management follows the protocol and SOPs. Today, burns management has become very simplified. If you have a good infrastructure, well-trained doctors, nurses, physiotherapists, clinical psychologists, you have a good intensivist, chest physician, burns management is fairly simple. You have a fairly straightforward approach. Today, you can diagnose the extent of the burn, you can assess the various problems which happen, and today with better intensive care, you are able to save major burns. All in all, friends, most of the deformities, also contractures that we talk about, can be prevented by early resurfacing and splintage. And today, things are much better than what they were earlier. Following me, there's a talk on pain management. It's extremely important that we as doctors and physicians relieve the pain of the burn patient. Otherwise, normally you see burn patients screaming and shouting. Not anymore. Today, with proper pain management, patients are comfortable during a dressing, and now no longer are they afraid of the dressing. Thank you so much.
Thank you, sir, for this informative session. यहाँ पे बैठे-बैठे आप हमको OT टूर करने के लिए लेके गए. Thank you so much, sir, for simplifying this topic.
Now I request Ms. Rohini Anekar to felicitate Dr. Sunil Keswani. Thank you, sir. I would request Sheetal Kotare ma'am to felicitate Ms. Rohini. Thank you, ma'am. Our next session is on the topic burns minus pain. The moderator for this session is Ms. Sheetal Kotare. Ma'am has 16 years of experience in teaching. She has completed her master's in nursing in child health and is currently a PhD scholar. I welcome Sheetal Kotare ma'am to introduce the speaker.
It's my pleasure to introduce our next speaker, who will be talking about burns minus pain, Ms. Rubina Ansari, faculty from D.Y. Patil College of Nursing, Mumbai. She was been awarded with gold medal in her Masters in Nursing with specialization of medical surgical nursing. She has varied experience as in teaching and in clinical side. She has published her articles in Journal of Pharmaceutical and Research International. She has also been an organizing committee member for Nobicon in 2020. I welcome her to take over the session.
I will change, you can change here. This one.
A very good afternoon, everyone. Thank you so much, ma'am, for the beautiful introduction. So as everybody was discussing from morning about burns, how we are gonna manage it. So while giving that management, somewhere we are gonna give pain to the patient. So I would like to deal with the concept that pain, how we are gonna reduce it. So according to the various studies, we want to understand first what is pain. An unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. As we all know, not only in burns, I think we all might have undergone at some or the other type of pain in our life. So just imagine if we are having a small cut in our skin, how much pain we are having. When it comes to burns, imagine if the patient is having burns in his or her whole body, what amount of pain patient will be having. Types of pain in burn: acute pain just after the burn, what the patient is having, which is acute pain. With every dressing, whenever we are doing dressing of the patient is getting pain. After SSG, which is plain skin graft, so whenever we are doing grafting or any kind of procedure to the patient is still getting the pain. Chronic, any pain lasting more than 3 months, as we all know, so that will be chronic pain. In burns, we also have subacute pain after daily dressing. So as a sir has also beautifully said, that we do dressing or we do various procedure to the patient. In all that terms, patient will be suffering from pain. Everyday acute or subacute pains, constant itch from healing burns, and neuropathic pains. Causes of pain in burns, as we have already dealt with. Wound, what patient is having, what patient has already dealt with, that pain. Dressing, if we are doing dressing, then patient will be having pain. Procedures like debridement, grafting, then patient will be having pain. The most painful stage to be the removal of innermost layer of gauze, which usually adheres to some degree to the wound bed. जैसे हम लोगों को अभी सर ने बताया that we will be doing dressing to the patient. So सबसे ज़्यादा पेन तब होता है जब ड्रेसिंग हम गॉज की करते हैं, जब लास्ट लेयर जो गॉज की होती है वो लिटरली स्टिक हो जाती है स्किन पे. सो वो टाइम पे वो निकालते वक्त बहुत ज़्यादा पेन होता है. सो दैट्स वाई वी गिव पेन किलर्स देयर टू, सो दैट वी विल बी डीलिंग विथ. The different types of burn pain include background, breakthrough, and procedure related to pain. So we will just quickly run through pathophysiology as we have short of time. So the immediate pain that follows a burn injury is due to the stimulation of skin nociceptors, pain sensing nerve. The simply what we have to understand in terms of pathophysiology for right now is that whatever the nerves which are getting sensation to the pain, as we all have learned in our nursing, सबने एक example दिया होगा, classical example, कि तवे पे आपने हाथ रखा तो आपको वो touch feel होता है, तो आप फटाक से हाथ निकालते हो. How you feel that? There is some kind of sensation going to your brain, that message is going to your brain that there is pain, please remove your hand. So that is the same thing we want to learn. If there is some problem in your body, in your skin, there will be some sensation going to your brain and telling, please remove your hand, there is a problem. So that is the feeling which we want to relieve. Primary hyperalgesia. A burn injury will immediately prompt an intense inflammatory response. Simply, if I would say, primary, the immediately if you are getting burned, that time what pain you will be feeling, that will be your primary hyperalgesia. Secondary hyperalgesia, continuously, repeatedly, you will be getting pain due to when you are getting injury, there will be some kind of receptors will get released there. Because of that, you will be feeling that pain. So if it is continuous process, that will be your secondary hyperalgesia. Burns pain management issues and solution. Now we want to understand where what kind of pain we are having. So pain is continuous. We want to understand that pain is continuous when it comes to burns. While treating also, we are somewhere giving pain to the patient. So relief also has to be very much continuous. Intermittent BD and TDS dosing insufficient and ineffective. We want to also understand that usually अगर आपको कोई disease हुआ, आपने TDS medicine ले ली, आपको fever आया, आपने TDS paracetamol खाया and you feel better. But in terms of burns, there is a continuous painkiller you require because the continuous pain you are feeling. Constant infusion is necessary to prevent peaks and valleys of pharmacological action on a 24/7 basis with an increase of dosing for physiotherapy and dressing. So as we all know, while doing physiotherapy and dressing also, we will be doing the movement for the patient. So again, with that time, we will be giving more extra painkillers so that patient will get little relief. Requirement for success, the simple regimen, regimen has to be very, very simple so that it should be easily understandable and it will not create any problem. It will be very much easily remembered so that we can manage it very well. NBC regimen, a combination of oral analgesics and neuromodulators like histamine or analgesics like acetaminophen that we give as a combination. Topical anesthetics, soaking the dressing with 500 ml saline with 20 ml of 2% lignocaine plus 20 ml of 0.5% bupivacaine in adults and 0.25% bupivacaine in children above 2 years. This makes the removal of adherent dressing easier and less painful. As I said, when we will be going to remove the dressing, that time the last layer of gauze piece stuck into your skin and that becomes very painful. So that time we use this anesthetic, topical anesthetic. This is the combination that makes it easy and less painful. IV analgesia with KTM. I think it is something very magical in terms of reducing the pain in burns, which is ketamine, tramadol, and midazolam. What is midazolam? Is anxiolytic, mild sedative. Tramadol, mild opioid with 5-HT and noradrenaline reuptake inhibition. Ketamine, an MDA antagonist, the most potent analgesic known but non-opioid, so no effect on respiration or gut motility. Most important, it is a cardiostable. So you all understand that beautifully these three drugs are given. So simultaneously you are decreasing the pain, little bit you are sedating the patient so that patient will be feeling less pain. We use very low doses, 1 mg per kg hour per infusion, 1 mg over a minute in 60 kg patient during dressing. Higher doses, 3 to 5 mg per kg IV stat over 5 seconds. Anesthetics as well as hallucinogenic, but not in low doses up to 1.5 kg per kg stat. Ketamine improves survival in burn injury followed by sepsis in rats. Basically, ketamine, how it is useful that we are talking about. Ketamine given within 1 hour but not 24 hours later reduces cytokine production after burns. Ketamine therapy improves survival injury follows by sepsis. So basically, if you give this, you will also reduce the chances of sepsis in the injury. This beneficial effect is probably achieved through interference with the inflammatory cascade as evidenced by attenuation of the pro-inflammatory marker. what is the solution we are basically using, this KTM solution. So that will be 50 ml normal saline, 100 mg ketamine, 10 mg midazolam, and 100 mg tramadol. So easy to remember, KTM 100, 100 and 10. Okay, so that you use for adults, infusion at 2 ml per hour. Patient gets 4 mg per hour, so 4 into patient, we will be dividing that with patient's weight in kg. That will be 0.66 mg per kg stat dose we can give. Negligible doses, certainly not even sedative dose, but formals, excellent analgesic dose. Same goes with children also, just make it half, so it will be 50, 50 and 5. So that we will be doing for children. We can also do femoral nerve block. Basically, how we understood that pain is going due to the nerves. The nerves are taking that sensation and reaching to the brain and telling us that there is a pain. So we will try and stop that process only. So we are basically blocking the nerves to take that sensation. The issue with burn pain management in India is issue universally applicable anywhere, but issue specifically in India. What is so different about India? Financial restraints that lead to compromises at every level, nurse-patient ratio, availability of drugs and equipment. These are the obvious problems which everyone knows, but there are worse problems that get glossed over. As we have seen many surgical instruments also that becomes little expensive, so that is also many of the patients are not getting, not affording, so that becomes a problem in terms of treatment. Pain management in burns, not common. As a result, most staff has never seen pain management. The concept seems outlandish, new-fledged and largely unnecessary. Pain management techniques increase the workload. Staff has to be exercise restrained not to quick remove the dressing and get to the next patient. As we all understand that there is so much of pain while even treating the patient, so nurse has to be very gentle while even removing the dressing. We cannot be so much in hurry and just remove the dressing, as we all know that it get injected in your skin. So we have to be very much gentle in terms of giving care to the burn patient. More important issues stem from an attitude level. A process of desensitization to pain becomes necessary for the staff to avoid emotional burnout, as I said. So the painful screams of the patients have been an integral part of the dressing. So you cannot say that, patient is screaming so much, chalo hum dressing nahi nikalte hain. We cannot do that, right? So we have to also understand that there will be very much screaming where patients' emotional quotients will be very high, but you have to simultaneously make patient comfortable, talk to the patient, and simultaneously continue your procedure. For effective pain management program, the staff from doctors downwards have to be desensitized. So much attention lavished when patient comes in. When, in emergency, when patient comes, we give so much of importance, that patient ko oxygen mil gaya, patient ko hum hamesha bolte hain, emergency mein what we have to follow is CAB. Otherwise, maybe ABC you might have heard. So we have to check airway, breathing, circulation. Of course, we have to check because that is something which is a life-saving thing for the patient. But we are always ignoring pain. Why not for pain the same thing? So we have to also simultaneously think that pain is also very important to think of. Mother's presence, the best painkiller, you always say. Now also, when mother is around, you feel little better. So you should also think there is some kind of emotional support patient feels. So that's why we can also use this method. Thoughts of a 10-year-old. These are some of the live examples. The 10-year-old is saying, look, doctor, whatever you do is useless without my mother. The 10-year-old does not know what we are doing, what procedures we are doing, what medications we are giving to the patient, but they only understand that my mother should be around me and my pain will go. So we have to also make sure that some or the other way we are not emotionally hurting the patient. I have two minds, one good one and one bad. I am trying to keep away the bad mind which makes me scream. My capacity for pain is limited. What shall I do? What amazing capacity my friends have for dealing with pain. So these are all the things we have, we are seeing the patient is dealing with. one who gave up her infusion pump for a child. So can you see patient are understanding, the other patient is also learning from the different patient how they are dealing with the patient. One who called me to say, ma'am, I have no pain, I am comfortable, please go and look after these children. Pain is more terrible lord of mankind than ever death itself. Please understand that death एक बारी आती है, but pain आपको suffer करते हैं. Okay, so more than 90% of burn patient unlikely to survive. We must all die, but that I can save him from days of torture. That I feel is my great and ever new privilege. Don't you think this quote gives us very much motivation toward dealing with pain? That you will save the patient from the suffering. Thank you so much.
Thank you, madam, for taking such a beautiful session. And she has actually simplified, yes, how we can help our patients to minimize the painful experience which they are going through. As we all are aware, all burn injuries will cause pain, and to an extent that it will add into the stress for the patient for the recovery, which may be for months, years, not only physical, but even she included that the psychological impact that the patient may have. So pain, to understand, is really very important if we are caring for patients who are suffering from burn injury. So thank you, madam, for simplifying. And one more important point which she highlighted is that not only burn injury will cause pain, but even our every interventions which we are carrying out during the treatment course also may contribute to the pain. So it is in our hand that how consciously we can put our efforts to minimize that pain during the course of treatment also. So thank you, madam, for that, for taking such a wonderful session.
I request Ms. Sheetal Kothare to felicitate Ms. Rubina Ansari. I request Ms. Rohini Anekar to felicitate Ms. Sheetal Kothare. Thank you, ma'am. We'll be breaking for lunch. The lunch break will be till 2:10. There are some surprises for the delegates. So it has been informed to me that there will be a ramp walk kind of a competition, and the title of the competition is Mr. and Miss Icon. It can be Mrs. also. So if anybody is interested to walk the ramp, please give your names at the registration counter. The details will be given to the participants later on. So hope to see you all after lunch at 2:10. Thank you.
Treasurer of Tarangan Alumni Association of LT College of Nursing. She is a member of Society of Midwives of India, Critical Care Nurses Society, Association of Nurses Executive India, Nursing Research Society of India, etc. When we are seeing about the activities and achievements of our speaker, she has been a resource person at various conferences and workshops at state and national level. She organized workshops and state-level conference on organ transplant and medical emergency. She has presented and published scientific paper at state-level conference, and she has been examiner on MUHS and MGM panel. She honed her skills in completing the specialized courses like biomedical research, ICT tools, blended learning, research methodology, and SPS. I'm very delighted to welcome Mrs. Deepa at Sadakar to informate us on healthy diet. The session all over to you, ma'am. Please welcome. I am welcoming you.
A very good afternoon to one and all over here, and thank you, madam, for the warm welcome and the introduction that was given. Without much delay, let me start with my session. It's a big challenge at this hour to take this session because especially everyone is having a full stomach. All have had a good nutrition, right? So I expect that the feedback or the interaction which I'm expecting will be loud and clear after the lunch. Yes? I can't hear anything. More louder? That's great. I think you can be louder than that also. Okay, let's go ahead. So we start with nutrition in a burns client. First of all, let us see in brief what are the effects that a burn injury causes on the body. It initiates an inflammatory response, first of all, which is quite a major one, and it depends on the it depends on the severity of the burn injury. There is a rapid fluid shift. The fluid shifts from the intravascular compartment to the interstitium. There is a hypermetabolic state. Then there is muscle protein catabolism. That means your muscle proteins, they break down to generate energy, which is excessively increased and required. There is cardiac output is decreased because of the marked reduction in the intravascular volume. There is increased capillary permeability and vasodilatory effects. That means the blood vessels get dilated and they're not able to accommodate that much amount of circulating blood volume. There is heat loss. There is increase in the blood glucose levels. And many of the times, the patient goes into hypovolemic shock. These are, in short, in brief, the effects of burn injury on a body. Now, we have to keep these effects, especially the metabolic response, when we plan and, when we provide nutrition to a client who's having a burns injury. Now, it is a state of hypermetabolism. There is increased protein catabolism, I told you, and excessive weight loss. Because more and more energy is required, the protein stores are broken down so as to release the energy, and as a result, the patient develops a lean body mass. Now, this hypermetabolic state after the burns injury, it starts anywhere from 24 to 72 hours, and it may be prolonged for even 2 years after the burn injury is caused. Again, I'm telling it depends on the severity of the burn injury that is resulting. Now, during this course, the nutrition of the client is very, very important. It is our major responsibility as nurses to encourage the client to eat well. Usually, क्या होता है कि
we welcome you, ma'am.
Yes.
Thank you so much for introducing me and this wonderful management here. So today my topic of presentation is phases of psychological burn care, de-stressing the psyche. From today we learned a lot about burns. We got to know about the overview of burns, the statistics of burns. We got to know about the primary management that is essential for burns. We also understood the treatment that the patient goes through, the surgical treatment, also the nutrition part, and also how much pain does the patient go through, right? Now, also of course, I'm not missing out the nutrition part also. So looking entirely, we need to also focus on the psychological aspect of burns, because we are very well aware that the patient go through a lot of physical impact, but it also has some or the other psychological impact on burns as well, right? So you just imagine, just imagine holding a cup of tea for a hot cup of tea, very hot cup of tea for 5 or 1 minute, right? It is something like our reflex response would be just throwing it off, right? Just imagining going through the pain, going through the incident, how traumatic that incident would be for an individual, right? Yeah. So now my content would be about how to assess psychologically the patient and also the phases of psychological burn care. The requirement of emotional needs is different at each stage of the treatment that the patient goes through. Okay, since this is for the nurses, we will also look after the relevance of psychology in nursing. We will also look about the intervention strategies for psychological assistance. We will also look about the nurse burnout, which is also very important topic for you guys to acknowledge. Okay, so now, when patient comes to the hospital, there is the normal assessment done. Okay, there we need to, the nurses also need to ask about the psychological morbidity of the patient. They need to understand basics about burn injury, that is date of burn, TBSA percent, type of burn, intent of burn, history of psychological illnesses. If the patient has gone through any history, if he has a history of depression or anxiety or any other illnesses, history of any substance abuse, because it may have an impact on the treatment course that he or she will be going through. Family history is also essential to understand how hereditary and all will work, the coping pattern works and everything. Recent life change, loss of job or loss of any near or dear ones. Basically, we are looking for stressors here. Yeah, social history, how the patient is coping social life stressors or how he is dealing with people around them. And mental status examination, where we look upon the appearance, we look upon the mood, affect, orientation, consciousness. The basic mental status examination need to be addressed. Okay, so now we will look upon phases of psychological burn care. As I mentioned earlier, each stage of treatment requires its own emotional assistance. Right? So before beginning, we need to know that a situation may be traumatic or may be traumatic for one individual, but may not be as traumatic for another. Yeah, so the standard of distress is different in each individual. So psychological distress is a state of emotional suffering associated with stressors and demands that are difficult to cope with in daily life. Here there's a simple quote. Now we will talk about burn injury. So unlike simple stress, trauma changes your view of life and yourself. It shatters your most basic assumption about yourself and the world. That life is good, I am safe, people are kind, I can trust others, the future is likely to be good. That replaces them with feelings like the world is dangerous, I can't win, I can't trust with other people, or there is no hope. So the thought patterns are changing entirely when the patient is going through a stress or anything, right? So it is very important that we need to see those thoughts and we need to help the patient recognize those. So now, physiological recovery of burn patients is seen as a continuous process divided into 3 stages. We saw the critical stage, acute stage, and the long-term rehabilitation. Right? So again, as I mentioned, each stage psychological needs of the burn patients differ. Now the first one is critical stage, where the patient is admitted in the ICU. Now in the ICU, there is the minimal interaction of the patient, right? So when you hold something for a long period of time, it will definitely hurt. So that is the same thing. When you hold something, your emotions, your thoughts with yourself, it will hurt. So that manifests differently for various people. So this stage includes stressors related to ICU. Delirium is one of the most common cases seen in the ICU setup. So lying in the beds for weeks. So these are some of the triggering factors that can cause delirium or any ICU kind of psychosis or anything. So lying in bed for weeks, infections, metabolic complications, high doses of drug. If the patient has a history of any alcohol use, then withdrawal. Intubation when the patient is intubated, there is, of course, no communication. So that may also have an impact on patient's psychological health. Yeah. Again, now here we need to talk about intervention. How can nurse, what can nurse do here is, they can constantly reorient the patient. So the patient is not aware about the day or what is going outside the world of that particular, from that particular room, right? So the reorientation is very, very essential because the patient is in a state of confusion, right? So reorientation and minimal interaction is also fruitful because patient is looking for people to share with or someone. So minimal interaction, if not long interaction, it would be great. So again, psychological intervention is of minimal value, but here we can focus on immediate concerns such as sleep and pain control. So breathing exercises, relaxation technique, these can be effective at this stage, right? And pharmacological intervention can also be made, which is done by a psychiatrist. Okay, now once the patient has been in the hospital for a few days and has been adjusted well, there are times where patients go through these physical and psychological impact, where there are sleep disturbances again, depression, pain, anxiety, phobias, acute stress disorder, and post-traumatic stress disorder. I am sure you all must have heard about these illnesses. However, when there is a stress, we need to know that each person has its own kind of manifesting the stress. So, for example, if I am having a stress, I may manifest it unhealthily. I may manifest it into depression, and some other person with the same stress, he may manifest it as anxiety. So the manifestations are totally different. So it depends on patient to patient. Yeah. Now here in this intervention, psychoeducation is important, where the patient needs to know that whatever he is going through is just a matter of days. It will eventually reduce. The patient needs to know that whatever thoughts, whatever feelings they are getting are valid, right? And this will go down in few days or maybe after few interventions that are done to them. Okay, so therapeutic intervention, cognitive behavioral therapy, rational emotive behavioral therapy. These are few of the therapies which can be done to the patients, wherein we focus on the emotional aspect, we focus on the thought aspect of the patient, where the irrational beliefs about the situation can be recognized, can be, patient is made aware of the irrational beliefs, and then substituting it to a more rational ones, right? Then again, relaxation techniques, because patient goes through a lot of pain, anxiety, so making patient relax, that will help each patient subside pain and anxiety. And pharmacological intervention as well. Now when the patient is discharged from the hospital, there are other things where he is moved out from the hospital, where he is trying to live his normal life again. There are other challenges that the patient may face. First is physical. Again, physical may be itching, limited endurance, difficulty in functioning, social changing roles, resume to work. The patient needs to get back to work now. So there are related problems or challenges that the patient face, and body image concerns. And psychological issues, most common psychological issues seen are anxiety, depression, PTSD, and again, body image concerns, right? Now here, what all interventions can be done? Social skills training, where the patient is actually trained to how to deal with a social environment, or how to interact, and eventually how they learn. Then support groups, where they feel that they are not alone. The burn survivors are all made to sit together, and then they discuss their own stories, which made them feel that they are not alone. There are other people who go through the same things. Peer counseling and vocational counseling is also essential. Now, whatever we discussed about the psychological trauma or psychological illnesses or that the patient go through, what are the triggering factors which we can be seen in the hospitals? First is psychological health before the injury. Again, at the start, I had mentioned about the how patients should be assessed about psychological health of psychiatric history of any illnesses or what. So we need to understand psychological health before the injury. So another triggering factor is thinking about the event itself. The patient tries and ruminate about the event, how he could have, controlled the situation or anything. Long hospitalization. These burn takes months, right, to heal. So long hospitalization, concerns about finances and the impact the injury has had on the family members, physical discomfort, all the dressings and everything. Pain while the wound is still healing, especially during the repeated dressing changes, and pain that continues for months afterwards. And itching, again, this is the most common triggering factor where the patient is just frustrated, right? Difficulty adhering to range of motion and physical therapy exercises. This also associates with the pain that they go through during physiotherapy. Limitations in physical ability, changes in appearance because of scars and contractures, because of amputation maybe. So loss of independence, the patient is, like earlier he or she used to do everything on their own, but now he has to be dependent on other. That has also an impact on a patient's health. Difficulty in returning to school or work, loss of property, residence, pets, interruption of daily lives, activities and control, and worries about the future. These are some of the very common triggering factors which we see, which leads to psychological illness of the patient. Now, what if we not address these issues? It has an impact on patient's health and recovery. As we all know, body and mind are related in some or the other way. So if your body is healed, okay, but if your mind is not healed, then it has a negative impact on your body as well. So making pain and itching feel more worse because your thoughts and everything are only focused on the pain or whatever currently they are going through. Reducing their effort and persistent in participating in rehabilitation therapies and wound care. So people deny going to physiotherapy or they deny any exercises that would actually require, right? So making communications with burn team members difficult. They stop interaction. Reducing interest and pleasure in daily activities. Earlier they used to enjoy a few things, now they don't. Disrupting sleep, causing tension in interpersonal relationships. Now this is a small case study where this is the case of a 26-year-old female who got injury through a stove blast at home. There were 3 people in the incident, mother, father and herself, with burn percentage of 50%, 47% and 19% respectively. She has one elder and a younger sister. Few days in the ICU, she further got shifted to normal wards, while both of her parents were still in the ICU. Her father passed away, and then within 3 to 4 days, her mother passed away. She was known about the same. So now how did this incident impacted her? So trauma is there. Also there is loss of the most important individuals in their life. There is grief, right? So patients reported of having nightmares as she closes her eyes, flashbacks of the incident and picture of her mother and father is seen to her. This disturbs her to the extent that she avoids darkness. Also, closing her eyes leading to sleeplessness, because if she closes her eyes, there is darkness and she fears darkness. So she avoids sleeping. So everything is linked for her that way. Patient started having fear of darkness and being alone. She also experienced startling up responses, screaming in the night if she falls asleep. She would not stay alone in the room as well. So these are the symptoms of acute stress disorder. If these symptoms are not handled or not managed properly for maybe for a month or longer, then it can turn to PTSD, that is post-traumatic stress disorder. Okay. Now, why is psychological assistance necessary? Again, I have mentioned you. Imagine giving all the best even physical ailment to the person, but not asking about how the patient is even feeling or how what is the mood of the patient the entire day, right? Not a single person asking about that. How massive traumatic incident or situation that may be for the patient to get through it. Non-resolution of these problems in the acute phase may cause them to progress to chronic psychiatric morbidities. Resolving the psychological problems that affect burn injury patients leads to greater enhancement of their quality of life and well-being. And of course, when these psychological help is given, it helps patient to return to society as a productive individual. Yeah. Again, mental health is not a destination but a process, right? It is not that I'm having good mental health now. No, it is a process. It's about how you drive, not where you are going, right? It very much depends on how you drive, how you see, deal with your stressors, deal with everything that life gives to you, right? Okay, now what is the relevance of psychology in nursing? So there are n number of patients coming to you, having their own mindset and interacting with you. Now at this point of time, it becomes very important for nurses to have these professional values where you have to be considerate towards your patient, you have to be non-judgmental, you have to be caring, sensitive, and like that. And also in excluding everything such as inequality or discrimination or social exclusion when it comes to access to care. And communication and interpersonal skills, because doctors, like for that matter, even us, okay, even a psychologist, we come, talk to the patient and go. But again, nurses are the one who are who spend much amount of time with the patient. So here communication becomes very important, how you communicate with the patient, how you understand the patient and show empathy towards the patient, right? Again, now for nurses, right? Nurse burnout. Okay, so nursing is a profession where you give where you deal with a lot of physical, emotional exertion, right? Where you deal with pain, like you see your patient going through pain, you see your patient going through physical or emotional exertion, right? When this job causes you stress, it is then called nurse burnout. So nurse burnout is a state of mental, physical, and emotional exhaustion caused by sustained work-related stressors such as long hours, the pressure of quick decision-making, and the strain of caring for patients who may have poor outcomes. Okay, now these are few of the causes of nurse burnout. When you have more than, like the researchers have shown that nurses who have more than 4 patients experience higher rates of burnout. When they have more than 12 hours of shift, or minimum 9 hours of shift is okay, like more than 12 hours of shift, or any stressful specialties like emergency department or any critical care specialties, because they see they witness their patients progressing or deteriorating. So yeah, so we need to understand how we are going through burnout or what. So these are few of the symptoms: constant tiredness, compassion fatigue, feeling unappreciated, emotional detachment, constant anxiety related to work, finding no enjoyment in the job, unexplained sickness. So these are few of the signs that you need to know, that if you're experiencing any of these, you can take help or you need to take break. So these are the statistics where few studies have shown that out of the 100 staff nurses that they had studied upon, majority, like 83% of nurses had high level of burnout, 3% had a very high level of burnout, and 14 had moderate level of burnout. So this is something which actually we need to look upon, and we need to start, like nurses need to start taking care of themselves, and they need to know that when they need help, right? So how can nurses prevent burnout, right? First is improve schedules. You need to do your working hours, but also taking time so that you spend your time with your loved ones or something that you actually like to do, right? Improving schedules. Second is taking breaks. We are not machines. We cannot work 24 hours, 24/7. Definitely, we need to take break. So take break, go to a vacation, yeah? And that will help you vent out all your frustration and everything. Seek out support. So maybe your colleagues or someone. We need to share everything that you have gone through regarding patient or anything that you feel you can actually share. And this will help out when venting out again frustration and everything. You need to learn coping methods, which is best known by your own self for your own self. So Some may like to do breathing exercises, some may like to listen to music, some may like to go for a walk. So one need to understand how they cope well and actually practice those things when they feel stressed, right? Protect your passion. Like, remember why you wanted to be here where you are. Remember why you chose this field, right? So doing this exercise for yourself, you will get to know it will help you at least feel better, or it will help you at least think rationally. That's it. Thank you. So there is no true physical health without a good mental health. Yes. Thank you.
Thank you, ma'am, for discussing de-stressing the psyche. She has not only involved the patient's aspects, but also the nurse's aspects. So she has discussed about the mental trauma that a burns patient undergoes, and also about the various psychological assessments which are crucial for the recovery of a burns patient. Ma'am has also discussed about the different phases of psychological burns care and the various problems which a patient would have, like sleep disturbance, depression, anxiety, and most commonly, post-traumatic stress disorder. So we thank you for presenting the topic pretty well. Thank you, ma'am.
Now I request Ms. Sabine Bijo to felicitate Madam Dwani.
Conferences. We welcome you, ma'am.
A very good afternoon to one and all. I have a small request before I introduce the next speaker. We have such a lovely audience here. I would like each one of you all to appreciate oneself by giving a loud round of applause. Still louder. Thank you. That's very kind and nice of you all. And I hope that we keep up the spirit of this conference in the similar manner till tomorrow 6 p.m. if I'm not mistaken. Yes? Okay, so that's a promise. And I'm sure that you all having I would say a vast range of academic treat, especially in burns. And I would like to congratulate SS College of Nursing, LT College of Nursing, and our great inspirator, Dr. Keswani, and the NBSC for thinking of such a platform for all of us to come together and deliberate on burns nursing and finding out what more we can do in a better manner for our patients. So we have been, throughout the day, we have been looking at how we are managing the patients, how critical our patients are, and such a vulnerable group of patients we have, those who come with burns. So we have seen what could be the surgical management. We have also seen what should be the nutritional aspect, how we can manage them, how we can manage their pain, how we would be also meeting up with their psychological needs. That's wonderful. We are looking at 360-degree angle for our patients, how we can be making them more comfortable at most of this uncomfortable phase which they go through. Now, I would like you all to think for a minute that when they are going through this phase, where are they placed? From the moment they enters the hospital, that's the acute phase. Let's take it from 24 to 48 hours. Then comes the emergent phase, which is from around 48 to 72 hours. During this critical phase, where are these patients? These patients are placed in the critical care unit. So whatever we are doing for our patients, everything is absolutely bang on. But yes, the critical unit where they would be placed, we have a very special team who is taking care of this patient. That's our critical care unit team. So I have an eminent speaker with us today. That's Chitra Naik. Well, she's just gone off screen. Never mind. As we are all running with time crunch, She is been a postgraduate from LT College of Nursing. CVTS is her specialty. She has been a major contributor in nursing education. She is working as a vice principal with KDS Hospital Nursing College. And also she is being pioneered in doing the quality initiatives at the hospital end. She has been to her, well, the screen is up. She has been been an auditor with the INCs, and she has been a resource person at various workshops and conferences. And I'm sure she also has a greater attitude towards research and evidence-based practice. I welcome you, Chitra, for the criticality of the critical session. So everybody will be applauding each one of you all again, right?
No problem, ma'am. It's already open.
डेस्कटॉप पे भी है ये, इस डेस्कटॉप पे भी है।
वो मैं पीछे से ऑपरेट कर रही हूँ, ये आपके लिए सिर्फ देखने के लिए। आप जैसे चेंज करोगे ना वैसे मैं उधर से ऑपरेट करूँगी। यही है ना?
Good evening, one and all. Today, we are going to discuss something, means we have been discussing management of burns patients since morning. And lot of aspects of critical care nursing are been touched upon already. So I'm going to basically focus on the aspects which are not been touched upon. Okay, so let's begin. The aim of the session is going to be at the end of the seminar, students will be able to gain comprehensive knowledge about the critical care management of burns and will be able to apply it in clinical area of practice. The major objectives are students should be able to define burns, explain emergency management of burns, including airway management and fluid resuscitation, enlist American Burn Association practice guidelines for burn shock resuscitation, then describe the acute phase management, discuss the pharmacological management in acute phase, explain about mechanical ventilation strategies, and describe the inotropes used in clinically ill burns patient. So definition, we already know the definition. Burns is a tissue injury caused by contact with heat flame, chemicals, electricity, and radiation. And the effects of burn injury are not only limited to the local area, but it also causes serious systemic effects depending upon the extent and depth of the injury. So first, as we begin our nursing process with assessment, here also we're going to start with advanced trauma life support assessment of burns. So for every assessment, we follow a particular mnemonic, especially ABC, you must be aware about, right? What is ABC? A stands for B, C. Now this has D and E. D stands for disability and E stands for exposure. Okay, so we are going to see it as A, B, C, D, E. So first is airway with C spine protection, because what happened at the site we are not aware about. So we consider that patient might be having a spinal cord injury, and that's why we always do airway with C spine protection. So removing any burning agent, including chemicals, then inspecting for singed nasal, facial, and eyebrow hairs, looking for burns and edema around the head and neck, because this decides what is going to be the maintenance of airway. Then suspect inhalation injury if the patient has respiratory distress, that is dyspnea, stridor, and wheezing, voice changes, signs of upper airway edema, deep facial burns, and sooty sputum. So this is how the edema usually looks around head and neck. Next is breathing. Assessment of breathing includes monitoring the rate, depth, and work of breathing, monitoring for dyspnea and stridor, then auscultating the breath sounds, and then administering 100% FiO2. Establish baseline ABGs and saturation. The goal is to maintain saturation above 95%. Next comes C, that's circulation. So monitor circulation and cardiac status with hemorrhage control. Then appropriate vascular access and use a device to monitor heart rate and blood pressure. Cannulate 2 veins, preferably with large caliber intravenous catheters, and initiate the warm fluid installation. Then avoid burn areas when possible in large burn surface areas where the IV has been placed through burn skin and the IVs need to be sutured. Then insert intravenous catheters to initiate intraosseous infusions when you are not able to access intravenously. Then assess perfusion status by following techniques. One is you have to check the pulse, preferably peripheral pulses, because that gives you that's a common indication of a peripheral perfusion. Then capillary refill and urinary output. Now this ABC was very common, so I just rushed through about. Now the fourth thing that we're going to discuss is disability. Now in disability, what is very important is first you have to assess the level of consciousness. So you can use GCS for that. Then assess the pain score. As Rubina has already mentioned in the morning session, that pain is the fourth vital parameter. So assess the pain score. Administer IV opiate analgesia according to the patient's needs. Next is exposure. Understanding the exposure in burns patient is very vital because total exposure of patients can help us in treating the patient in emergency phase. So remove any burning agent including chemicals. Work toward maintaining a normal temperature by removing wet dressings and covering them with dry and sterile dressings. Then begin rewarming the patient with blankets and warm fluids. Ambient temperature should be maintained between 28 degrees Celsius to 32 degrees Celsius, that is 82 to 90 degrees Fahrenheit. The patient's core body temperature must be kept at least above 34 degrees Celsius. Increase the room temperature if necessary and remove all the jewelry because in order to avoid problems related to perfusion which are going to happen because of third spacing of the fluid. Next is determination of total body surface area, because this is going to help us in deciding the amount of fluid resuscitation required for the patient. So the severity of the burn injury is determined by total body surface area burn and the depth of the burn, and it is determined using Lund and Broda's formula or rule of 9, which is very, very common. I'm sure all of you all must have learned this. Okay, so Lund and Broda chart is already available in emergency units of some of the institutes who follow this particular technique, or the rule of 9, which is very popular for assessment of burns. Next, we move on to emergency management of burns. Now, the airway management, which is very crucial. So, initial priorities in the ED remains airway, breathing, and circulation. So, for mild pulmonary injury, 100% humidified oxygen needs to be administered, and the patient is encouraged to cough so that secretions can be brought out. Then, and even you can help the patient with the help of suction. For more severe situations, it is necessary to remove secretions by bronchial suctioning and to administer bronchodilators and mucolytic agents. Now, in edema of airway, if it has developed, so endotracheal intubation becomes very, very difficult, but it is important. If laryngeal edema is present, ET becomes very difficult, then we go for another approach that is called as tracheostomy. Now, continuous positive airway pressure and mechanical ventilation may be required to achieve adequate oxygenation. If the burns exceeds more than 20 to 25% of total body surface area, a nasogastric tube is inserted and connected to low intermittent suction. Now this suctioning or decompressing the stomach is very, very important, because patients with large burns become nauseated, and as a result of GI effects of the burn injuries, they develop paralytic ileus, and the effects of medications such as opioids also can cause, add to the effect of paralytic ileus, and hence the decompression of the stomach is very important. All patients who are intubated should have nasogastric tube inserted to decompress the stomach and prevent aspiration. Next, fluid resuscitation. The goal of fluid management in the major burn injury is to maintain tissue perfusion in the early phase of burn shock, in which the hypovolemia finally occurs due to steady fluid extravasation from intravascular space to interstitial space. Now, current recommendations are to initiate formal intravascular fluid resuscitation when the surface area is more than 20%. In other words, for patients with major burns, the formal intravascular route is preferred choice, and except in mass casualty situations. Formula for fluid resuscitation very commonly used is Parkland formula, where we use 4 ml of ringalactate into body weight into total body surface area burn. So this will give you total crystalloid requirement for the patient for 24 hours. Now, the key aspect in this that you have to remember is this 24 hours that you're going to calculate is from the time of the burns that has taken place, not from the time when the patient has reached emergency department. Okay? So, once you have decided how much fluid to be administered within first 24 hours, you have to remember that first half of the total requirement has to be administered within first 8 hours, and then remaining within next 16 hours. Then the following 24 hours, that is 24 to 48 hours period, the colloids are given. Usually colloids are not recommended within first 24 hours is because of inflammatory response, there is increased capillary permeability, because of which already the fluid has shifted to interstitial space. Along with that, even proteins have a tendency to move into the interstitial space. And if we administer colloids during this particular period, it will pull more fluid from intravascular to interstitial space. So recommended is colloids are usually given as 20 to 60% of the calculated plasma volume, and no crystalloids are administered in the next 24 hours. In the Brooks formula, in initial 24 hours, RL solution 1.5 ml per kg per percent of body surface area burn, and colloids of 0.5 ml per kg per percent body surface area burn, plus 2000 ml of glucose in water is administered. And in next 24 hours, RL 0.5 ml per kg per percent of body surface area, and colloids 0.25 ml per kg per body surface area burn, and the same amount of glucose in water as in the first 24 hours has to be administered. Now, how will you decide whether whatever fluid calculation has been done by you or doctor or whatever is adequate for the patient or not? So to assess that, large bore IV catheters and indwelling urinary catheters are inserted. The total volume and the rate of the IV fluid replacement are gauged by patient's response and guided by the resuscitation formula. The adequacy of the fluid resuscitation is determined by monitoring basically urine output, and which is an index of renal perfusion. So urine output total of 0.5 to 1 ml per kg per hour for adults have been used as a resuscitation goal. Additional gauges of fluid requirements and response to fluid resuscitation includes hematocrit and hemoglobin and serum sodium levels, which we usually monitor very frequently in initial 24 hours. Now, within the first 24 hours after injury, if the hematocrit and hemoglobin levels decreases, or if the urinary output exceeds 50 ml per hour, the rate of IV fluid administration can be decreased. In patients with severe burns, an arterial catheter is preferred for blood pressure monitoring and even for collecting blood samples. Peripheral pulses of burn patient extremities are little difficult to find, as we all know that intravascular volume is very, very low. So you can use sound Doppler to assess the peripheral pulses. Another thing which is utmost important is the color of the urine during this period. If the patient has burgundy colored urine, it suggests the presence of hemochromogen and myoglobin resulting from muscle damage. Now, if it is present, we have to give a lot of fluid to the patient, because if this is formed in more amount or excessive amount, it may block renal tubules and can cause damage to the kidneys. So this part is very, very important. Now we are going to have some look on American Burn Association practice guidelines for burn shock resuscitation. Adults and children with burns greater than 20% total body surface area should undergo formal fluid resuscitation using estimates based on body size and surface area burn, which we usually do. Next, common formulas used to initiate resuscitation is crystalloids need is for 2 to 4 ml per kg body weight per % total body surface area burn during the first 24 hours. Fluid resuscitation, regardless of solution type or estimated needs, should be titrated to maintain urine output of approximately 0.5 to 1 ml per hour per kg per hour in adults, and in children it is 1 to 1.5 ml per kg per hour. Next is maintenance fluid should be administered to children in addition to their calculated fluid requirements caused by the injury. Increased volume requirements can be anticipated in patients with full thickness injuries and inhalation injuries and delay in resuscitation. Oral resuscitation should be considered in awake and alert patients. Then next is plasma sodium concentration should be closely monitored to avoid excessive hypernatremia. Administration of high dose of ascorbic acid usually decreases the overall fluid requirements. Next, we move on to nursing management in emergent phase, which is for initial 48 hours. So, nursing assessment, assess the circumstances surrounding the injury, the time of injury, the mechanism of burns. Monitor the vital signs very frequently, that is, monitor respiratory status closely and evaluate apical, carotid, and femoral pulses. Monitor intake, that is IV fluids, and output, that is your urine output, and measure it hourly. Note the amount of urine obtained when the catheter is inserted. Assess body temperature, body weight, history of pre-burn weight, allergies, tetanus immunization status, past medical surgical problems, current illness, and use of medications. Arrange for patients with facial burns to be assessed for corneal injuries. Then continue to assess the extent of burn, assess the depth of the wound, and identify areas of full and partial thickness burns. Assess neurological status, that is consciousness, psychological status, pain, anxiety level, and behavior. Then assess breath sounds, respiratory rate, rhythm, depth, and symmetry, and monitor for hypoxia. Then observe for signs of inhalation injury, that is blistering of lips or buccal mucosa, singed nostrils, then burns of face, neck, and chest, increasing hoarseness, or soot in sputum, or respiratory secretions. Report if there is any labored respiration. Now this is a very important part, because nurses are supposed to know two things. What is abnormal than normal? Means you should be able to differentiate between normal and abnormal, and if you identify anything abnormal, it has to be reported immediately. If you know what it implies, It's icing on the cake. Okay? So report labored respiration, decreased depth of respiration, or signs of hypoxia to the physician immediately. Prepare to assist with intubation and escharotomies. Then monitor mechanically ventilated patients very closely, that we are going to see in detail a bit. Then monitor serum electrolyte levels, assess patient and family for understanding of burn injury and coping strategies, and family dynamics and anxiety levels. Provide individualized responses to support patient and family coping, and explain all procedures to the relatives very clearly. So next we move on to nursing diagnosis. That is the first utmost important is impaired gas exchange related to carbon monoxide poisoning, smoke inhalation, and upper airway obstruction. Second we are going to discuss is ineffective airway clearance related to edema and effects of smoke inhalation. And third one is fluid volume deficit related to increased capillary permeability and evaporative losses. So how are we going to improve the gas exchange? So for this, you have to provide humidified oxygen to the patient, assess breath sounds, respiratory rate, rhythm, depth, and symmetry. Monitor the patient for signs of hypoxia. Observe the following, that is erythema or blistering around the lips, that as I told, basically you have to assess for inhalation injury and whatever signs and symptoms I spoke about related to that. Monitor ABG, pulse oximetry readings, and carboxyhemoglobin levels. You all know carboxyhemoglobin is very dangerous. It basically talks about carbon monoxide poisoning. Then report labored respirations, decreased depth of respiration, and signs of hypoxia to the physician immediately. Prepare, assist with intubation and escharotomies, and monitor mechanically ventilated patients very closely. Next is airway clearance. Now, remember one thing, gas exchange and airway clearance. These are two different problems. Many of our students usually use it interchangeably, okay? But you cannot do so. Airway clearance is different, the interventions are different. So first, breathing must be assessed and patient airway established immediately during the initial minutes of emergency care. Immediate therapy is directed towards establishing an airway and administering humidified 100% oxygen. कुछ भी करके patient को 100% oxygen देना है. If such a high concentration of oxygen is not available, अगर 100% oxygen का source आपके पास नहीं है, तो आप क्या करोगे? So in that case, you have to administer oxygen by mask or nasal cannula, whatever is available. Assess for the need of endotracheal intubation. No food or fluid should be given. Patient को मुंह से कुछ भी नहीं देना है. Okay, and the patient is placed in a position that will prevent aspiration. So usually patient's position should be above the chest level. Then institute aggressive pulmonary care measures such as turning, coughing, deep breathing, periodic forceful inspiration using spirometry, and tracheal suctioning. Maintain proper positioning to promote removal of secretions and patent airway, and to promote optimal chest expansion, and use artificial airway as needed. So this is the recommended position where the patient is placed above the chest level. Next, maintaining fluid volume. So observe vital signs, urine output, and be alert for signs of hypovolemia or fluid overload. Monitor urine output at least hourly and weigh the patient daily. Maintain IV lines and regulate fluids at appropriate rates as prescribed. Observe for symptoms of deficiency or excess of serum sodium, potassium, calcium, phosphorus, and bicarbonate. Then elevate the head of the patient's bed and elevate the burned extremities. Notify the physician immediately of decreased urine output, blood pressure, central venous pressure, pulmonary artery pressure, or pulmonary capillary wedge pressure, or increased pulse rate. Next, we move on to acute phase management, which acute phase usually begins after 48 hours. okay, when emergency phase is over. So the acute or intermediate phase of burn care follows the emergent or resuscitative phase and begins 48 to 72 hours after the burn injury. It begins from diuresis to near completion of wound closure. Now, during this phase, attention is directed towards continued assessment and maintenance of respiratory and circulatory status, fluid and electrolyte balance, and GI function, and infection prevention and burn wound care. Airway obstruction caused by upper airway edema can take as long as 48 hours to resolve. So changes detected by X-ray, arterial ABG analysis, these has to be monitored, and accordingly the treatment has to be given. Then bronchial washing or bronchoalveolar lavage can assist in diagnosis and treatment of pneumonia. Ideally, the best practice is to remove endotracheal tube as soon as possible so that the route of pathogens is not accessible to the lungs and we can prevent pneumonias in this patient. Now, many patients who are admitted to intensive care unit, out of that 30 patients go on mechanical ventilation, and many of them develop is because of complication of pneumonia and ARDS. The arterial blood gas values and other parameters determine the need for intubation. As capillaries regain integrity, 48 or more hours after the burns, fluid moves from interstitial space to intravascular space and diuresis begins. So if patients are already elderly or having cardiac compromises, there are chances that they can go into cardiac failure. So you have to monitor these patients for complication of cardiac failure as well. Fever is very, very common, and this can occur, the core body temperature can increase in burn patients even in the late phase. Next, very important is complications. So the first one is acute respiratory failure. So assess for increasing dyspnea, stridor, and changes. You have to maintain the patient's oxygenation well. You have to monitor the chest X-ray and assess for signs and symptoms of respiratory compromise. Report deteriorating respiratory status and prepare and assist with intubation and escharotomies. Next complication is distributive shock. How we have to manage and what we have to do, we have already seen. Then next is acute renal failure. So monitor urine output. This also we have seen, and monitor for hemoglobin and myoglobin means presence of these in urine, and administer increased amount of fluid as prescribed. Next, very important, as Dr. Keswani had mentioned in the morning, is about compartment syndrome. So you have to monitor for compartment syndrome and try and prevent that. Next is paralytic ileus. So maintain the NG tube in place, do suctioning adequately, and maintain gastric decompression throughout this period. Curling ulcers is one of the complications again, which is because of decreased intravascular volume, which provides very less perfusion to the mucosa of the GI and can cause curling ulcer. So you have to prevent that, and you have to aspirate decompress the stomach. You have to assess the pH of the aspirin, then assess the stools for occult blood, and administer histamine blockers and antacids to your patient regularly. Next, pharmacological management for pain. Usually, as she has mentioned, tramadol, ketamine, morphine, fentanyl, these are given very commonly. Then as a prophylaxis, we give tetanus toxoid immunization. Then another is gastrointestinal. For that, Rantac, nystatin, and antacids are given. Now, I just want to take 5 minutes extra and talk about mechanical ventilation, because there are different strategies used. And as I said before also, management of critically ill burn patients in intensive care unit is complex, but about 33% of burn patients admitted to ICU will require mechanical ventilation. So the indications for endotracheal intubation are stridor, respiratory distress, PO2 less than 60, PSCO2 more than 50 mmHg, deep facial or neck burn resulting in massive facial edema, then upper airway edema, then presence of airway injury, oropharyngeal edema, erythema, hoarseness of voice, and severe chemical burns causing bronchoconstriction, bronchoria, and acute lung injury. Now, indications for mechanical ventilation are smoke inhalation, severe burns, respiratory depression. This we have already discussed. This is an algorithm for initial ventilator settings in the patient with burns and inhalation injury. Most of these patients are usually ventilated on CMV mode, that is continuous mandatory ventilation. If this is the mode used, then the set rate is usually 20 to 25 breaths per minute. Tidal volume is 6 to 8 ml per kg practiced. The plateau pressure is usually maintained less than or equal to 30 centimeter of water, and tidal volume is maintained 4 to 8 ml per kg if ARDS is present. PEEP is used 5 centimeter of water or 10 to 15 centimeter of water if the patient has ARDS, and FiO2 usually given is 100%. Now, another technique which is very important, which is new, is high frequency percussive ventilation. Now, in high frequency percussive ventilation, this is, as it suggests, it uses high frequency. That is 400 to 600 breaths per minute, and is superimposed throughout the respiratory cycle on low frequency rate, that is 0 to 30 breaths per minute. Then it is percussive. Now, these percussions which are given during this in this ventilation usually helps to remove secretions, okay, because the counter current of air helps to expel secretions out of alveoli. So these are the two different features of this particular ventilation. It is usually time cycle, so the timing is controlled by the ventilator, but there are different strategies which allows patient and ventilator synchrony. Another mode which I found this time very newly is airway pressure release ventilation technique. This is in trial. I have gone through many studies, but this is still under trial. So airway pressure release ventilation is a option for burns patient. In this, basically continuous positive airway pressure is used with intermittent release of pressure, and this technique usually helps the patient to improve oxygenation. Then another modes are non-invasive modes of ventilation, which you all know is CPAP. CPAP is administered, is an administration of positive airway pressure during both inspiration and expiration, spontaneously, means in spontaneously breathing patients, because this is a spontaneous mode. The purpose of positive airway pressure is to improve FRC, that is functional residual capacity, and that helps to improve gas exchange. Next is BiPAP. You all already must be knowing BiPAP. BiPAP is a pressure support mode of ventilation with PEEP in spontaneously breathing patients without an artificial airway. The patient-triggered inspiratory efforts result in a set amount of pressure supplied by the ventilator. And last is hemodynamic monitoring. If patient is not able to maintain adequate pressure, which is going to hamper perfusion pressure of the patient, so that for that we have to maintain the patients on inotropic agents. So inotropic agents usually used are adrenaline, noradrenaline, dopamine. So adrenaline usually we use, it's given via central venous line, and 0.1 to 0.3 microgram per kg per minute is the dose recommended. Then next is dopamine. It is the dose is 2 to 20 mics per kg per minute by continuous infusion, and generally starts with 5 mics per kg per minute. Then noradrenaline, the dose is via a central line, only 20 to 100 nanograms per kg per minute. And morphine, the loading dose 50 mics per kg as a slow bolus maintenance dose, and 5 to 25 mics per kg per hour as a continuous infusion is recommended. So these are the various references that I have used to get a lot of information about new techniques and the drugs related information. So if you want, you can go through all this. And with this, I would like to say the crux of critical care in burns patient basically focuses on three things. One is circulatory management. First is airway management, second is airway breathing management, second is circulatory management, and third important thing is prevention of infection. If you take care of these three things, this triad, patients usually are able to come out of ICU successfully. Okay, thank you. Any questions?
Thank you, Chitra. So I'm sure that we have concluded that our critical patients, they are at a very critical phase for, we have to be navigating these patients from the acute phase to the emergent phase and up to the rehabilitative phase so that they are successfully weaning out of the hospital, and then we would be having extended care to these patients. So the mantra which we as nurses, which we should focus on is the hemodynamic monitoring, promptly monitoring the patients and promptly reporting the variations, having a close watch on HAIs, that is hospital acquired infections, so that we can save our patients from septicemia, and with all other phases what we have discussed today. So I'm sure that you would be able to take a step forward in enhancing the critical management of our burns patients. Thank you.
I will request Madam Sija to felicitate our speaker, Ms. Chitra Naik. Thank you, ma'am. I would like to invite Ms. Rohini to felicitate Madam Sija. Thank you, ma'am.
Now I call upon Madam Sheetal Kuthare for the next session.
We'll have our next panel discussion on converting sepsis to asepsis. I would like to introduce the speaker on the panelist. We have Ms. Sandra Day, Professor from Sandra Shroff ROFEL College of Nursing, Vapi. Madam has completed her graduation from Armed Forces Medical College, Pune. She has been awarded with PhD degree in nursing. She was end-of-life nurse educator consultant from CIPLA, Palliative Care Institute in 2017. There are many more things to tell about Madam, but because of time constraint, I have just highlighted few of them. To her credit, she has many awards, publication. She's a very eminent speaker. To introduce you our next panelist, Dr. Iravati Rao. Dr. Iravati Rao, she is principal at Government College of Nursing, Surat. She has completed her BSc, MSc in Nursing and PhD in Nursing. Currently, she is working as principal at Government College of Nursing, Surat, and has organized state and national level conferences, workshops, seminars, symposium, and various curriculum and co-curriculum activities at institutional level and state level. We have our next panelist, Ms. Saili Jadhav. Ms. Saili Jadhav is working as infection control nurse in TMC. She has completed her GNM at JJ Hospital. She has done her PG diploma in hospital administration from local self-government of India. She has done her MBA in hospital administration from Jaipur University. Our next panelist, Ms. Ratna.
Hello.
At present, she is working as infection control nurse in TMC. She has done her GNM from Dr. R.N. Cooper Hospital and has completed her PBBSc nursing from MGM Hospital and Health Sciences, Kamote. She has specialized in infection control and oncology nursing from TMH. So once again, I welcome all the panelists to enlighten us on converting sepsis to asepsis. The first question to Madam Santa Day is to enlighten us and to simplify on what are the factors or the circumstances that can cause sepsis in burn injuries.
Good evening to all. It's very nice for the organizers to give me an opportunity to speak in this forum. Thank you all. Coming to my topic, the factors that contributes to infection in the burns wound. As we know that infection is most frequent complication in the severe burns wound because it has a propensity to progress into the sepsis and then progresses to septic shock and ultimately gives rise to multiple organ dysfunction syndrome. Now there is destruction of skin barrier which is associated with altered cellular and humoral immune responses. And there are various key factors that contributes to the infectious complications in the patients with such severe burns because there is immediately after the thermal burn, the burned wound surfaces are sterile, but gradually they progresses to infections because the microorganisms invade them. And the extent of the injury is because of the amount of organisms they get settled into it, they colonize and they invade the wound. Because the infected wound is having a very protein-rich environment and it has an avascular necrotic tissues and that provides a favorable environment for the microorganisms to grow and therefore and thereafter these organisms, they first colonize themselves and proliferate and gives rise to such severe infections. Now, once the infection starts and most of among these burn victims, those who are at higher risk of developing severe infections or sepsis they are like extremes of ages. There are like both the extremes of ages, senior citizens as well as small children are vulnerable for infections. Then there are people who have burn victims with comorbidities. Then immunosuppression is another factor that gives rise to severe infection and sepsis. Then these burns patients have various invasive devices like catheters, intravenous tubings, urinary catheters that gives rise to infection. Then the extent of burns, like full thickness burn is also another one factor for giving rise to infection. Any infection that is the burns wound that is more than 30% of total body surface area, the people are more vulnerable for developing sepsis. Also, if there is a skin graft which has failed, that gives rise to prolonged open wound, burn wound, and of course, improper early burn care. These are some of the causative factors that give rise to burns wound infection. Again, other factors include like nosocomial transmission of microorganisms, which passes on to through the hands of healthcare professional while giving care, then through the contaminated surface like contaminated surfaces like the patient's mattress, patient's bed linens, fomites, then of course contamination of shower hand grips, then other things like a showering stretcher, then a sink, etc. They give rise to infections, and these infections commonly they occur in the first weeks of hospitalization. The nosocomial infections in burns are basically due to the break in the first lines of defense, that is skin break, the injury, because of the injury where the large amount of skin gets destroyed. There is presence of devitalized and avascular tissues. They get necrosed and they give a very good bed for the microorganisms to grow and give rise to infection. There is alteration of various immune system, specific and non-specific components of immune system. These burns patients, they have extended hospitalization. They have multiple invasive diagnostic and therapeutic. They undergo various therapeutic and diagnostic procedures which are invasive, that gives rise to infection. And these patients also undergo prolonged courses of antibiotics, and that result in multi-drug resistant nosocomial strains that again gives rise to infection. And out of these organisms, like most common organisms are Staphylococcus aureus, we have Pseudomonas aeruginosa and Acinetobacter baumannii. These are the organisms, they give rise frequently to various infections, and out of them Staphylococcus aureus is the important, and this is the organism which is most common. This pathogen is most common pathogen which gives rise to infection. And this is an early colonizer. The another thing about Staphylococcus aureus is it survives the thermal insult, and it stays very close to the hair follicles, at the root of hair follicles and sweat glands, and as there is an injury, an open passage for it, it just causes infection from there only. Then other organisms gradually creep in, and then they give rise to like Pseudomonas aeruginosa, Acinetobacter baumannii. They all come later on. Like once the infection gets settled around, it is said that around they take about 7 to 10 days to develop the infection, or 1 to 2 weeks after admission in the hospitalization. Gradually, these wounds that get colonized with other microbes, and then other gram-positive and gram-negative bacteria they start giving rise to the infections, and the patient's normal flora of gastrointestinal and respiratory flora also, the infections come in, they get settled, and they progresses the patient towards sepsis. Various healthcare professionals' hands also, while working also, they just start spreading into the patients. So there are various types of burns wound infection, like American Burns Association has described these 4 types of burns wound infection as wound colonization, where the organisms are superficially settled, and they're in low concentration of bacteria, and they invade only the local area, and they do not go into the system, they do not show any systemic signs and symptoms. The next category is wound infection, which is associated with higher concentration of bacteria within the wound or wound eschar, and it is deeply invasive, causes deeply invasive infection. The third category is cellulitis, where there is inflammation being seen, redness, warmth, tenderness, and another type is necrotizing infection or fasciitis that involves aggressive infection and invasive infection with the involvement of structures of the wound just below the skin. That's all are varieties of factors that contributes to infection and types of infection, ma'am.
Thank you, ma'am. Thank you, ma'am, for simplifying and making us understand what are the possible causes which can result into the sepsis. My next question is to Dr. Indravati Rao. Like, what are the investigations or diagnostic evaluations in case of sepsis in burns patient?
You can handle from the here, next, or the next from the where we will do. This is the next.
Good afternoon, everyone. First of all, I would like to say thanks to the Sandra Shroff College of Nursing and the LT College of Nursing, Mumbai, for giving me this opportunity to being the part of this informative and wonderful conference. And welcome to all the Mumbai person in our Gujarat. Welcome you all. So, as the today topic is given to me, is the diagnosis of sepsis in the burn patient. So, if you say the diagnosis of the sepsis in the burn patient itself, it is very challenging. It is dynamic and the complex task, because if you see about the burn injury, in the burn injury is having the events of the pathophysiological changes which leads to hypermetabolic status, systematic infection, and also immunocompression. As we know, that sepsis, if you say the sepsis is not something normal, it is the abnormal condition. So it is the common and more severe complication of the severe burn condition. We all are knowing that the burn is the highly lethality condition. So due to that condition, it's a must, the person has to know what is the specific definition of the sepsis and how to diagnose the sepsis. So now here we are going to discuss regarding the sepsis and how to do the diagnosis of the sepsis. Dear all, when the word came in the mind, sepsis, it means what we will think in the simple way. We think that sepsis means it is the infection, it is the overwhelming of the infection, but it's not the exact definition of the sepsis. If we say sepsis, sepsis means it is the life-threatening organ dysfunction. This is due to the causes of dysregulated host response to the infection. It means our body at the time of the sepsis, it's showing the abnormal response to infection and inflammation. Due to that, the dysfunction of the organ is occur, that is known as sepsis. Now here we will see what are the criteria, how to do the diagnosis of the sepsis. So there are some criteria I have shown here, that is the systematic inflammatory response syndrome, which is known as SIRS, that is the SOFA, Q-SOFA, burn wound assessment, and there are some biological markers which is indicated infection is present in our body. Then the sepsis SIRS, how to identify that the SIRS is present in the body. There are the total 4 criteria are there. By that, we can identify that SIRS is present. That is the temperature. So temperature, maybe the patient is having hypothermia and the hyperthermia. So both the condition can be present, maybe hyper and maybe hypo. Heart rate, the patient is having the tachycardia. The heart rate is more than 90 beats per minute. Trachepnea is present. White blood cell count is increased. So here is also having the 2 parameters are there. It may be leukocytosis or leukocytopenia. Both the condition will be present. In the new, after 2016, it came that the 2 parameters are also included in the SIRS. That is the alteration in the mental status, and next is the hyperglycemia without pre-existing diabetes. Because we all knew that when the pathophysiological changes occur, our body itself is response to the pro-inflammatory condition and anti-inflammatory condition, which leads to insulin resistance, and due to that there is chances that the blood glucose level is increased. Then how we will say that whether the SIRS is positive and negative? If the SIRS is having more than 2 or equal to 2 parameters are positive, it means it shows that the SIRS is positive. But after 2016, the SOFA came. After that SOFA, we are not using these SIRS criteria to diagnose the sepsis. Now this is the SOFA. So SOFA, mainly we revealed the impairment of the organ function. We will see that whether all the organs is working properly or not. So for that, here is having the total 6 systems we are identifying, that is central nervous system, CVS, respiratory system, GI system, renal system, and coagulation in terms of platelets count. So here you see that the total is having the 0 to 4 score. The maximum scores are 24. And here in the SOFA also, if out of this score more than 2 or equal, 2 is having the positive, it means if the 2 parameters are positive, it means it shows that the SOFA is positive. So here we will see that how it is in the CNS, what we are seeing. In the CNS, we are observing the level of the consciousness. So to observe the level of the consciousness, we are doing the GCS or is having the AVPC parameters are there. By that we can identify. So you see, if it is coming 13 to 14, we give the score 1. If it is coming 10 to 12, we give the 2, 6 to 9 is the 3, and the less than 6 is the 4. Similarly, in the CVS, we have to see the hypotension. So hypotension, how we identify hypotension? Based on the mean arterial pressure. The normal mean arterial pressure is considering is normal from the 70 to 100. So here, if the mean arterial pressure MAP is less than 70, giving the 1 score. Second condition, if MAP, normally we are not able to maintain, and we are maintaining with the based on the vasopressive medicine, that is the dopamine, and we are giving the dopamine less than 5 microgram per minute per kg. With based on that, if the MAP is coming 70 or maintaining 70, so we have to give the 2 marks. Similarly, with the dopamine, 3 marks. With the dopamine and non-adrenaline, if you are maintaining, we have to give the 4 marks. Similarly, respiratory system, in the respiratory system, we have to see the partial pressure of oxygen and the FiO2. So both the ratio we have to see it. If the 0 is more than 400, if it is 1 score, 300 to 400, 2 is the 200 to 300, 3 is the 100 to 200, and 4 is less than 100. Liver, in liver, we have to see the bilirubin level. So bilirubin level, we identify if it is 1.2 to 1.9, 1, 2 to 5.9 is 2, 6 and 11.9 is 3, and 4 is more than 12. So this is the SOFA score. It is given by that we can identify whether in our body these organs are working normally or abnormally. Next is the cube SOFA score. So in the cube SOFA score also, if the SOFA score is not possible to identify, we have to using the cube SOFA score. In the cube SOFA score, here he is having the three parameters, that is altered mental status, trachepnea and hypotension. Here is also having the same. If it is more than 2 or equal to 2 is having the positive, it means the cube SOFA score is positive. Now this is very small and the simple type of the algorithm which will be helpful to diagnose the sepsis in case of burn. So what we will do? See, suppose if you see any patient is coming with you and the patient is suspected of the sepsis, it means any sign and symptom is showing the sepsis. First of all, what we will do? We have to measure the cube SOFA score. If the cube SOFA score is having the positive, then we have to identify the evidence of the organ failure. Evidence of the organ failure, how we identify? We identify based on the assessment of the organ failure. Then we go the detailed SOFA score. In the detailed SOFA score, if it is coming more than 2 positive and the detailed SOFA score is positive, then it's confirmed that the patient is having sepsis. In that sepsis also we have to identify the refractory hypotension. Now, what is refractory hypotension? Refractory hypotension is the condition where if we are giving the adequate amount of fluid, electrolyte or fluid resuscitation to the patient, despite of that, the patient is having hypotension. This is a condition which is known as refractory hypotension. So if the patient, we have given fluid resuscitation to the patient, and now we are saying now the patient is having the hypotension. So that is the one condition. The another is it's required to maintain the MAP to give the vasopressive. And the third condition, if the serum lactate level is more than 2, it means this all shows that now the patient is in septic shock condition. So this is very small and the sweet algorithm which is showing that how we can do the diagnosis of patient. The next thing is the wound biopsy. So wound biopsy is also very much important to do the diagnosis of the sepsis in case of the burn. So what we will do? We have to see the color of the wound, the extent of the wound, depth of the wound, order of the wound, and by that we have to obtain the biopsy, and these biopsy we have to send for the histopathological examination and also for the culture, and we will see the invasion of the microorganism in the wound. The next is the blood culture. So in the blood culture, or when we will be doing the biopsy of the tissue, and in that if it is shows that the presence of the bacteria is more than 10⁵ in the viable bacteria per gram tissue, it's a suggestive that invasive infection is present, increase the risk of sepsis. And in the blood culture, mainly blood culture, we are doing identification of the microorganism, and the more important thing is the RT-PCR. Nowadays, already all the people are much aware regarding the RT-PCR due to COVID-19. So RT-PCR is the one test by that we can identify the specific type of the bacteria which is present and which is causing the invasion of the microorganism, which is more reliable in case of the sepsis. Now the last thing is the biological marker. So biological marker is also play important role for the identification of the sepsis. In that is the one important is the C-reactive protein. We knew that. The C-reactive protein is, if the person is healthy, the C-reactive protein is normal. If the person is having any type of the infection, in that condition, the C-reactive protein is increased. So in the case of the burn, the C-reactive protein is more than 500. And if the patient is having sepsis, it will be increasing and it will be more than 500 in case of burn also. But some researchers said that CRP alone itself, we cannot identify that sepsis is present in the patient. Next is the procalcitonin. So procalcitonin is also very popular indicator which identify infection and inflammation which is present in the case of burn. So CRP and the prolactin together, it is helpful to identify the invasion of the microorganism and also to identify the infection in case of burn. Along with these, there are some cytokines, that is interleukin 6, interleukins 8, 10, and TNF alpha. A part of that, the H1, proadium, so PAR, presapsin. These all are the cytokines which will be helpful to identify the presence of infection in burn injury. At last, in the battle to solve sepsis, every moment is count. Thank you very much.
Thank you, madam, for your wonderful presentation. Now I would like to ask Ms. Saili Jadhav, what are the modalities, treatment modalities available in case if patient is having sepsis?
Good evening, one and all. Treatment for burn sepsis. Since morning, we are looking same topic and different subtopics are there. Today, I will take treatment for burn sepsis. This way out. Switch off this. Yeah, I don't know. Depending upon the wound sepsis, wound category, treatment of burn wound infection or sepsis consists of combination of wound cleansing, topical or systemic antimicrobial therapy, and burn wound debridement or excision. Then test, Madam Indravati already explained what test we are doing for this to detect the sepsis. What 6 essential interventions to treat sepsis? What are the essential interventions for that? Can anyone from student? What interventions we will look for sepsis? First is from student, anyone? No? What treatment we are giving in ICU? If we find any sepsis patient, septic shock patient, okay. First, background deliver high flow oxygen, okay. Then take blood culture prior to antibiotic, but do not delay the treatment. Administer empirical intravenous antibiotic, measure serum lactate, start intravenous fluid resuscitation with crystalloid, commence urine output monitoring. What is important? Most important first step in sepsis treatment, most important sepsis aspects of care are early diagnosis. Early diagnosis is the first step, and then rapid fluid resuscitation and antimicrobial therapy. Treatment for sepsis. The recommended first-line agent for septic shock is norepinephrine, preferably administered through a central line catheter. Norepinephrine has predominant alpha receptor against effect and result in potent peripheral arterial vasoconstriction without significantly increasing heart rate or cardiac output. Which antibiotic is given first for sepsis? When all the sign point of sepsis, a doctor will typically start the patient on a combination of broad spectrum antibiotic that may include vancomycin, ceftriaxone, piperacillin, tobactam.
Cefepime, tobramycin, imipenem, ciliastine, and gentamicin. Antibiotic is based for burn infection. Which is the antibiotic for based for burn infection? In the event of localized MRSA, burn infection, furosemide acid and gentamicin sulfate can be used as a topical treatment. Topical vancomycin is also available and has demonstrated to be more effective than a systemic formulation with lower adverse side effect. What IV fluids we will give for sepsis patient? IV fluids are 0.9% sodium chloride and lactate, ringer lactate. Yes or not? We are giving ना, दे रहे हैं ना हम लोग ICU में 0.9% sodium chloride and ringer lactate we are giving. Which is the best medicine for sepsis? कौन से लगाते हैं ऑइंटमेंट हम लोग? कोई बोल सकते हैं? ऑइंटमेंट क्या लगाते हैं बर्न पेशेंट के लिए? सिल्वर? Yes. Good. And IV antibiotic is sufficient for treatment for sepsis patient? It is enough for IV antibiotic? No. IV antibiotic alone won't treat sepsis patient. Also need fluid to body, need the extra fluid to help keep the body pressure from dropping dangerously low. How quickly should sepsis be treated? I will answer from here. Patient should get antibiotic within 1 hour of arriving at the hospital. If sepsis is not treated early, it can turn into septic shock and cause patient's organ to fail. इसके लिए within 1 hour we have to give the antibiotic to the patient. Thank you. Thank you very much.
Thank you, ma'am. Question to the next panelist, Madam Ratnaprabha. What are the challenges about in prevention of this sepsis?
Good afternoon, one and all. Before going to challenges, I just want to tell you that prevention of infection in burn sepsis when you all are working in the burn unit. As a nursing, once the patient admitted in the hospital with the burn, the initial treatment is that excision of the wound and draping of that wound, and the hydrotherapy is the most important thing once the patient's admitted in the hospital. Once patient gets in the ward, then if there is a need of indwelling catheters, then only it has to be put. Otherwise, if there is no need of indwelling catheters, avoid to put the indwelling catheters. If you are putting a Foley's catheter and you require more than 1 month, it should be a silicone catheter, not your latex catheter. Then your central line, if you want that requirement of central line, then only it has to be put. Otherwise, your peripheral line is okay for the this treatment. Then second thing, if there is an environmental cleaning is most important when the patient is getting admitted and after the discharge. As a burn unit, you require a double strength of cleaning in each and every during the environmental cleaning. Like if you are using the hypochlorite solution, it should be 1:4. Like 1% of hypochlorite solution and 4 parts of water. That should be clean. That should be used for the environmental cleaning. Then there will be a standard precautions. When there is an isolation precautions, when the patient is having MRSA or VRE positive,
that is totally hospital acquired infection. It should be isolated from the clean patient to the another room. It should be isolated, and there should be a board on that room, that is contact precaution should be taken. Avoid patient shifted from one department to another to do the any investigation. This is the basic principles what we are doing to prevent the infection from one patient to another patient, and patient from the healthcare to the patient. Whenever you are taking care, the standard precaution should be used. You have to wear the gloves, gown, cap and mask whenever you are taking care of the patient. During the IV fluid administration or during doing any procedure, you have to wear the sterile gloves. The hand hygiene is most important. In hospital, the hands are the most important things which spread the infection from one person to another person. The WHO has given the 5 movements of hand hygiene. Do you know the 5 movements of hand hygiene? Yes? Before touching patient, before doing any aseptic procedure, after touching patient, after any blood and body fluids, and after leaving the patient's surroundings. If you all are doing all these things, you will prevent the infection. The many times patient dies in the hospital because of the infection, not because of the burns or any other diseases. So it's our responsibility how you take care of the patient. Mainly when your administration of the IV fluids and the injection, when you are giving the bolus injection, it should be use a sterile technique like sterile tray, sterile syringe, one patient, one needle, one syringe. Always remember that not to use the syringe to dilute the injection for every patient. So you have to use one patient, one syringe, one needle. This is the WHO guidelines. Then steps of hand hygiene. There are steps of hand hygiene whenever you are taking care of patient. Before going to patient's room, you will wash your hands and you will take a hand rub before doing the any procedure. There are 7 steps for the hand rub. Do you know? We'll do little bit of exercise of hand rub. Yes? Palm to palm. Right palm on left dorsum. Left on right. Then interlacing of the fingers. Then interlocking of the fingers. With that you will clean your back of the fingers. Then rotation manner of the thumb. Then tip of the fingers clockwise and anti-clockwise. This is the basic principle of hand rub. Before you are doing any procedure, you have to use this. This is what prevention of infection when you are working with the hospital and clinical areas. Now the challenges. There should be a availability of the resources. If there is no availability of resources, of course you cannot do all these things. Second thing comes under what? The economical condition of the patient. If you are treating the patient, one patient, they will remain prolonged in the hospital, and once the patient remain prolonged in the hospital, they mostly get the hospital acquired infection. Once they are getting the hospital acquired infection, they require higher antibiotics. So that is challenge, that patient should not get infection. Then psychological aspect of the patient, then economical condition, all these things comes when you are treating the patient in the hospital area. Thank you very much. Any queries?
Thank you, ma'am. Now, after having this understanding of like why sepsis may result into the burn injury, what kind of diagnostic evaluation, what kind of assessment that we also can do for this patient to have an early identification of sepsis, the treatment modalities and the prevention of sepsis and burn injuries. My one of the question to all the panelists is like still there are cases, there are incidents wherein patient land up with the sepsis and burn injuries, yet the incidence rate is very high. So what kind of gap in the nursing care which you identify, which you would like to address, that yes, we can work on to for the prevention of sepsis or at least to reduce the incidence rate of sepsis?
Here I have something to say is that sepsis due to burn, caring for a patient with sepsis due to burn is absolutely, like there's a lot of difference in caring for a patient with sepsis other than burn cases. Like I mean that in case there are two cases of sepsis where the etiology is one of it is burn wound and for another one is anything else, the care for both of them are absolutely different. But to treat a patient with sepsis where the patient has developed burn, it needs constant supervision, monitoring, and updation, and then the treatment modality changes accordingly. Therefore, all of us, like the nurses who are caring for the patients with burns, they need to be sincere and dedicated in their work. Like for example, as just now Madam has said that simple steps like hand washing, then caring for patient with catheter, and all these, they need to be, we should give meticulous care to the patient, and that is what is lacking, I feel, Madam, in many institutions. And also we need to upgrade ourselves with the newer modalities of treatment. In many of the burn centers, where like even if there are not many, but in one or two, when I have seen that there are yet people practices that giving birth to the patient in the common tray, which again transmits infection. So these are, I found that there are few gaps now.
One more thing I will add. This is not related only in burn. If we found any symptomatic patient or any confirmed positive patient, if we don't have any isolation facility, we have to take patient in aside the ward or cohort the patient or transfer to the isolation ward and give to the proper treatment to the patient to prevent the infection, spread of infections.
I'm sure we all will agree that yes, a little bit of awareness on your side can actually help the patient to get rid of sepsis or either to keep the patient protected from having any kind of infection. So I take this opportunity to thank all our eminent panelists for having such a beautiful discussion. Thank you. I'm sure you also must be having some of the other questions, but due to time constraint, we will not be able to take it right now. But you're most welcome during the break time. We'll try to clarify with that. Thank you.
Now I request Madam Sheetal Kothare to felicitate our dear panelists. Now I request Dr. Akanksha to felicitate Madam Sheetal.
Good evening. I request everyone to be kindly seated. We'll be starting with inauguration in a while. Since it is taking some time, I request Sheetal Kothare ma'am. They are there? Okay. We've been informed that the dignitaries are there. Okay, till they walk in, we'll finish something soon for you. Calling upon Ms. Sheetal Kothare.
Yeah.
Good evening. Good evening to all the dignitaries. Now we'll be starting with the inauguration ceremony of the National Level Burns Conference on Making a Difference, Skin Deep. We call upon the students of Sandra, Shroff, ROFEL College of Nursing to present the welcome dance, which is dedicated to invoke the blessings of Lord Shiva and Lord Ganesha.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
हर हर शम्भो शम्भो शिव महादेव शम्भो शम्भो शिव महादेव हर शम्भो शम्भो शिव महादेव शम्भो शम्भो शिव महादेव कर्पूरगौरं करुणावतारं संसारसारं भुजगेन्द्रहारं
कर्पूरगौरं करुणावतारं संसारसारं भुजगेन्द्रहारं
सदा वसन्तं हृदयारविन्दे भवं भवानी सहितं नमामि
सदा वसन्तं हृदयारविन्दे भवं भवानी सहितं नमामि
हर हर शम्भो शम्भो शिव महादेव शम्भो शम्भो शिव महादेव हर शम्भो शम्भो शिव महादेव शम्भो शम्भो शिव महादेव
This was indeed a great performance by the students, which has invoked the blessings of the Lord Shiva and Lord Ganesha. Now I request the dignitaries to light the lamp. Fire is the element of nature and it signifies energy and life. It illuminates the lamp with the wick of a candle to represent knowledge. But if the wick touches a fabric of flesh, it shows its destructive form. Let us invoke, by lighting the lamp, spread and disseminate knowledge, as this fire which represents energy and life will bless us and heal us. Chairs down.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दिव्यादिव्यारे दीपत्कार काने कुण्डलमोतिहार दिव्याला पाहून नमस्कार तिळाचे तेल कापसाची वात दिवा तेवे देवा पाशी उजेड पडे विष्णू पाशी माझा नमस्कार सर्व देव देवतांपाशी ये ग लक्ष्मी बैस ग बाजे माझ घर तुला साजे घरातली इडापिडा बाहेर जाऊ दे बाहेरची लक्ष्मी घरात येऊ दे घरच्या सर्वांना उदंड आयुष्य सुख समाधान शांती लाभू दे
Thank you, and requesting all the honorable dignitaries to please come on the dais. Requesting all the dignitaries to please be seated on the dais. Requesting all the honorable dignitaries to please come over the stage and kindly be seated. It's my pleasure to welcome Dr. Nancy Fernandez, Principal of Leelabai Thakase College of Nursing, for the welcome address and opening of the conference theme.
Good evening. To our distinguished guests, experts, delegates, a warm welcome to this much awaited first National Burns Nursing Conference hosted by Sandra Shroff ROFEL College of Nursing in collaboration with Leelabai Thakase College of Nursing, SNDT Women's University, and the National Burns Center. I'm glad on behalf of the organizing team to welcome you all to such a beautiful place to exchange knowledge and the nuance of excellent nursing management of burns. It's up to us to make a difference. Before I start, let me express my gratitude to all those who have contributed to make this conference possible. Burns is and has never been a pleasant experience for a patient, relative, and the healthcare team. Ouch! That's what we hear when a drop of oil splashes on our hand, or as we pour a cup of tea, it splashes on our hand. Think of the intensity of pain, discomfort, fear, and anguish that crosses the mind of the patient, the relatives, and the caregivers. We as caregivers always have a desire for a positive recovery of the patient in what each of us in the team keep on wishing every time we see a patient walking our door. Putting hope into the patient, a victim of burns, the journey began with late Dr. Manohar Keshwani, who set the ball rolling by establishing the Indian Research Burn Society and subsequently the National Burn Center, giving hope to a patient that you can recover and still look back beautiful. We have begun this journey today morning reviewing holistic nursing management of burns. We have recapped the causes, the immediate management, the diet requirements, and the psychological need, and so on. Yet, the heart of the conference is polishing the skills which will be there tomorrow in the patients so that we can give the best care. There are 10 skill stations where participants will spend their time under experts. It is also an opportunity for each of us to reconnect, build new contacts, and discuss the best practices which is of mutual interest to enhance the patient care, especially of those who have burned. This conference will sensitize all our delegates as to what we can do for our patients to help us focus that we not only have to take care of the physical injury, but also that which causes anguish to the patient, that is their mind, their emotions, that is the invisible pain, which makes or may take a bit longer to heal. Hence, today's conference theme, Making a Difference Skin Deep, is an apt theme for this conference. We hope at the end of these 2 days of deliberation, our delegates will leave more confident and be able to render for burns patient an excellent nursing care so that we do not lose a single patient. And dignitaries on the dais and guests, once again, a warm welcome to you.
I request Ms. Arpana Patil, the organizing secretary of the conference and faculty of LT College of Nursing, to introduce and felicitate the guest of honor, Dr. Vilas Nandavadkar, Registrar of SNDT Women's University.
Thank you, Ms. Sebin. Thank you. Good evening to all the respected dignitaries on the dais, of the dais and delegates. I am honored to introduce Dr. Vilas Nanvadekar, Registrar of SNDT Women's University, Mumbai. To highlight academic qualification, Sir has various degrees on his credit. To name few, BSc, Masters in Computer Applications, MBA and Doctorate. Sir has a wide experience in field of higher education from visiting lecturer in Government Polytechnic College, Pune to Professor, Director and Registrar of Shivaji University, Kolhapur, Maharashtra. Sir is also worked as a member of expert team for establishing self-financed universities with Maharashtra government. Not only nationally but internationally, Sir has worked in field of education. To name few, Sir was a member at Decision Sciences Institute, USA, as a library member at the National Library Rwanda, Africa, member of editor at BioInfo Publications. Sir has also worked with Singapore National University for research and development purpose. Sir has served as a statutory authorities on Board of Studies, Academic Council, Management Council, Senate, etc. at various universities in Maharashtra. Sir also facilitated assessment and accreditation procedures at various universities. Sir has also been awarded, to name few, like Best Educationalist Award, Best Teacher Award, and many more. Sir has participated and conducted various workshops, seminars, research projects nationally and internationally. Sir, we are honored to have you amidst us. We welcome you, sir, with token of appreciation. I request Madam Sandra Shroff, Chairman and founder of SRCN and various educational institutions to welcome sir. Thank you, madam and sir.
Thank you, ma'am. It's my great privilege to welcome a dazzling personality, chemical engineer, Mr. Rahul Verma, sir. He has more than 32 years of experience in industries across the country, worked in various functional roles, and he is presently serving in manufacturing division of Reliance Industries Limited as a site president in Silvassa. I heartily welcome you, sir. I request to Major General Mrs. T.K. Bhutia, ma'am, to felicitate to sir. sir. Thank you, ma'am.
I request Dr. Vilas Nandavadekar to felicitate the dignitaries on the dais. Dr. R.K. Srivastava, Consultant Plastic Surgeon, Safdarjung Hospital, New Delhi. I request Dr. Vilas to felicitate Dr. R.K. Srivastava, sir. Requesting Dr. Vilas to felicitate Dr. Sunil Keswani, Medical Director, NBC, Navi Mumbai. I request Dr. Vilas to felicitate Srimati Sandra Shroff, Madam, Founder and Chairman of SSRCN. I request Dr. Vilas to felicitate Dr. Nancy Fernandez, Principal, Leelabai Thakase College of Nursing, SNDT Women's University, Mumbai. Thank you, sir. Thank you, sir. I would request Madam Sandra Shroff to felicitate the other dignitaries on the dais. Major General T.K. Bhutia, ma'am. I request Sandra Shroff, ma'am, to felicitate Shri Kalyan Banerjee, sir, Chairman, RCT, and HRH International Rotary President for the year 2011 to 2012. I would again request Madam Sandra Shroff to felicitate Dr. S.S. Singh, Chief Physician and Director of Medical Services, Harya LG Rotary Hospital. And finally, Ms. Arpana Patil, the organizing secretary of the conference, who is also a faculty at Leelabai Thakarse College of Nursing, SNDT Women's University, Mumbai. Thank you so much, ma'am. Requesting all the dignitaries to kindly rise with the mementos for a photograph, which will be a memory for us, which we can reminiscence. We have a group of distinguished guests on the stage. They're all coming together for a photograph which will become memory. All have excelled in their areas from different walks of life. So it's indeed a pleasure to see them on the dais. Can we have a big applause for all of them? A bit louder. Thank you so much. I call upon Dr. Vilas Nandavadikar to kindly address the gathering.
चलेगा चलेगा Be settled. Silence, please. Good evening, all of you. This is not a voice of SNDT and the nursing college of this. Good evening, all of you. That's it. Good, great. Dignitaries on the dais. Respected Chief Guest Verma sir. The other dignitaries on the dais, Mrs. Shroff, Dr. Keshwani, Dr. R.K. Srivastav, the other dignitaries present here, our own principal, Nancy Fernandez madam, then the coordinator, Aparna Patil madam, the dignitaries of the dais, director, principal, teacher, non-teaching staff, research scholar present here, the representatives from the different media, and the participant in this conference, but not last, but the least, not least, our own student who are present here. This national level Burns Nursing Conference, which I saw the first time this type of conference is organized. So I congratulate the whole team, the organizing team on this occasion. We know the issue, we know the burn, but we cannot put the attention on that. I attended a few sessions before of this inauguration and wonderful presentation done by the resource person. Thanks to them, they have really put forward the facts, what we need to take care, what we need to address. That may be a psychic treatment, psychology, stress, the actual treatment, the taking care of the patient, then the nurse behavior. That is also one of the aspects which I understood during the discussion, in the panel discussion. What medicine we need to adopt in case of that. So it's a wonderful gathering along with the knowledge sharing. This type of conference make aware to all of us what we need to do in case of burning. Being as a chief administrative officer and registrar of the university, I put forward your attention to take a prevention for the burning. That may be, if you consider the educational institute, we fix the fire exchanger, we fix fire alarm, but we can't alert to revise it, to renew it, to refill it. We ignore it. Once it installed in the offices, in the cultural hall, in the classroom, in the auditorium, very few people take care. Being an administrator, we need to consider that it is a serious issue which we need to put attention and refill it on a regular basis. Otherwise, the fire incident will take place and then your role will be start. So to avoid that type of situation, what is the most important, which I feel we, being an administrator, should note this and do a regular interval filling of this type of devices. Another thing, majority of the incident which occurs based on the data which available on the national website, which I found during the cooking. And that time what we need to do, the few things which I came across, which I noticed, we do not do regular servicing our gas station, our gas stove, our gas segdi. In a 6 month, on a regular basis, we need to remove the gas piping, which is a rubber type, but we do not care about that. And that's why we face an incident. We face the burning incident. And then the casualty happens. Then we took the further steps. So to avoid that, we need to do a regular servicing of our gas segdi. That may be a stove or other devices. Another thing which I noticed in few of the companies where the high influenceable gases they generate and they burn out. Majority of casualty accident happens over there, and number of people they died in that. In India, the data shows 1,000 per 1,000 people, 59 to 60 people died because of this cause, and we need to put the attention on that. So wherever we came across this type, solid or liquid type of gases, fuels, we need to see the precautionary measures, what it should be taken. Another incidence cause of this accident of, if you consider the old building 50-year age, more than that, the electricity which we pass on by using the old wiring system, we do not care of that. And because of that, it happens a short circuit, and that short circuit create the incident, create the accident of this type. So we need to see to that. do the regular inspection from the various regulatory authority, and if required, remove it. In our own university, we have started that. More than 100-year university. So, we need to check that and upgrade ourselves to stop this type of incident. One more practical incident which I noticed. In my car, I used a CNG. The CNG installed a kit by the company, considering the pollution. To stop the pollution, support the environment, I use that car. But I don't have a training how to use the fire exchanger which is installed inside of a car. The car owners, they haven't taught us. Even I haven't asked for us. When the casualty happened, we realized that something is there which I am unable to use it. So my urge is, my request is, we need to see the possible precaution measures to avoid this type of incident. But when the incident happens, the best solution on it, which discussed in this conference, the research scholars, they have presented, the resource person, they have shared very good way the knowledge of in this knowledge forum. And definitely this knowledge will be useful for us, for our future. Even a small break, which is useful to release our stress. So that is very important. So considering this, I wish the organizer for organizing such a wonderful conference. More than 300 participants, either in a physical mode or a online mode, they are participating in this event. That is the success of this conference. Congratulations to all the team members of this conference. Definitely, they will prepare a conference proceeding and they will distribute to you in the form of digital or in the form of print. You can use that. You can use that each and every component which shared in that proceeding. Because I just before this, I came across one case which one madam has shared, one resource person has shared. So considering that, you will get number of case studies inside of that. Please do attend it. Otherwise, I saw the conferences where the presenter is presenting and the evaluator is evaluating other side, or the resource person sharing their knowledge, but the audience is not there. You attend this 100% level. Definitely, this conference will really useful for all of us. This is a good initiative. Sir has formed the national, burning center in Mumbai, which is one of the best center. And in our discussion, I just inquire about that, like blood donation camp. They have many in a city. But suppose someone wants to donate a skin, which I came to notice that only 4 in Maharashtra. Am I correct, sir? 4 in Mumbai. Total 18. 8. Total 8 in Maharashtra. See to this. Means we need to create awareness among us. And who are responsible for this? We all. We need to spread the message about this. And try to save the other's life. With this word, I end my speech. I thank the organizer for inviting me here and giving a chance to speak in front of you all. Thank the whole team. Thank you.
Thank you so much, sir, for your motivational word. Now, I request to Mr. Rahul Verma sir to say a few words regarding today's event. Welcome you, sir.
Thank you. Good evening, everyone. Once again, good evening to dignitaries on the dais. It's a great honor to be here on this momentous occasion. I'm from a different segment. I'm representing industries. What our guest of honor has just briefed everyone. The kind of challenges our medical fraternity is facing nowadays with so many industries in and around, especially this region, Vapi region, where we have on one side we have Silvassa, then on another side we have Daman. So it's one of the biggest industrial hub in this part of India. And with rapid progress in industrialization, we are having number of cases, burn cases that are coming up. And then there was a dire need to have this kind of nursing institute here in this region. And today it was out of the word to see what kind of facilities have been built up in this nursing home in a small town like Vapi. The simulator, what Srimati Sandra Ben's Shroff, the initiative she has taken, this was absolutely mesmerizing. I had never imagined this kind of facilities you all nursing students would be having with you. So I would consider you as a privileged one. So once again, I would like to thank Srimati Sandra Ben Shroff for taking this initiative. Caring for burn patients is obviously, we all know it's complex and challenging. They need a lot of comprehensive and multidisciplinary approach. Burns is definitely a serious health issue for a country because it causes the injury is devastating, and the stigma that carries on with the time, basically it not only affects person physically, it carries with him mentally also. It is one of the most sorrowful thing that happens. So as an industry, we are doing many things nowadays, and even the government regulations are changing so that how we can prevent such kind of injuries. We are carrying out regular audits, fire audits, prevention audits through we are putting up checks and various checks and various procedures, adopting different kind of systems by which we can enhance overall safety, fire and safety management of our industry. But still there is a big gap, a lot of work has to be done. We have to be, as industry, we have to be responsible enough to make sure that no one suffers. We all want that person, the way person comes to on duty happily, the same way he should be going back. But still, there remains some gap, and once in a while such kind of unfortunate incidents takes place where a burn injury takes. And in industry, the burn injury is a complex one because mostly it is a hot chemical injury, sometimes it's a fire injury, sometimes it's a hot condensate injury, sometimes radioactive burn. So it is a different kind of burns which goes through industry. So this kind of setup, and with so many good nurses getting trained in such a sound and such a healthy environment in and around us, that will be a big boon for all industries here. The quality of care during the initial few hours after sustaining burn injury impacts the long-term recovery of the plant. In the most circumstances, the care rendered to the burn patients during initial few hours are outside the specialized burn units. That basically spoils the case, and things become very complex when it comes to hospitals for treatment. So we need to have larger number of qualified and dedicated professionals who would be imparting and updating the care of patient. There is a big gap. Still, we have a lot of gaps. The kind of statistics I have been going through, still there is a lot of things have to be done. It's a good thing that is done here, this kind of symposium. It is going to, this is Spark of the Light. Basically, it's for the first time such kind of symposium is being held. This is really incredible. This must be a beginning. There's a long journey to go ahead. But at least things have begun. So once again, thanks to all the faculties, all the management who have taken this initiative. Very senior doctors are here and the dais who have come here to take this thing up, take this thing further. We are basically at a big industrial hub where accidents and fires are very common. We need to train our nurses and hone their skills in handling burn patients. The nurses plays a leading role in supporting and promoting quality care to the patient with burn injury throughout their illness, ranging from care at the initial and acute phase of injury till rehabilitation while going back to community. Hence, this Sandra Shroff, ROFEL College of Nursing, in collaboration with National Burn Center, SNDT, Women's University, and Leelabhai Thakarse College of Nursing, has organized this first burn nursing conference. My sincere compliments once again to each and every one of you. This is a golden opportunity for the doctors, nurses, students, administrators of Gujarat and Maharashtra to understand and plan strategies to take care of patients right from accidental site to the hospital setup. This conference is a holistic approach taken by the team with the Herculean support of Mrs. Sandra Shroff, who has been creating landmarks for serving humanity and by establishing this college in 2003 and preparing graduate nurses who are the nurse ambassador of Gujarat in healthcare industry and abroad, and making us proud of them. So dear nurses, you are into a profession that requires great intelligence, motivation and determination. The Florence Nightingale, the founder of modern nursing, so rightly described nursing as the finest of the fine arts. Nursing has become one of the greatest blessings to humanity, taking place besides physicians and priests. That's why it is said, save one life, you are a hero. Save 100 life, you are a nurse. Mother Teresa so aptly said, let no one ever come to you without living better and happier. So my salute to all nurses, all healthcare workers who had fully committed themselves to their frontline duties during COVID pandemic. But challenge is still not over. Times ahead are quite uncertain. We need to remain fully prepared for any eventuality. So I'd like to thank every one of you on behalf of industrial community for choosing this incredibly noble profession, and my best wishes to all the nurses, all the nurse students in your journey ahead, where you have to be strong enough to tolerate everything and yet soft enough to understand everyone. Thank you everyone. Thank you so much.
Thank you, Shri Rahul Verma, sir, for addressing the delegates and also throwing some light on the importance of quality of care, and last but not the least, acknowledging all the healthcare workers and the nurses. Now I request Dr. R.K. Srivastava, Consultant Plastic Surgeon, Safdarjung Hospital, New Delhi, to address the delegates.
Dignitaries on the dais, dignitaries in the auditorium, the faculty members of this institute, the students and other participants, staff and other members present in the hall. Namaskar to everybody. First of all, I would like to congratulate the organizers for organizing this beautiful conference, Burn Nursing Conference, the first and unique in India. It is being organized first time in India. And I would also like to thank them for providing me the opportunity to attend this conference. I would like to congratulate Dr. Sunil Keshwani, whose great initiative has culminated into this conference. He is the instrumental in this organizing this conference. You all know that in medical profession, unlike the medical specialties which can be managed individually, the surgical specialty needs teamwork. And for burn management, the teamwork is much more important. The team includes doctors, the nursing officers, dressers, the helpers, and other supportive staff. They are just like a spoke of the wheel. If one is broken, the wheel will not move smoothly. Burn care involves much more nursing care than the gadgetry things. We don't need too much modern equipments, instruments to deal with the burn care. But a good nursing care, a good psychological support with proper treatment, of course, professional treatment, is mostly required to treat the burn patient and to take the patient come out of this calamity. Nurses play an important role because they are the persons who are mostly with the patient. Doctors come in the morning, evening, at most once or twice in a day, give advice and went away. But the nurses are there with the patient. They carry out the instructions, they carry out the dressings with the help of dressers, if available. Otherwise, they themselves do the dressings. They know each and every aspect of the patient, whether it is urine output, whether it is intake, whether it is fluid management, everything they are involved. So if nurses are trained and they are involved in interaction with others' experience that what is being done and what is the modern thing to be done, that will be much more beneficial for everybody and the patients, of course. So this type of conference, I wish that this will be organized on yearly basis, not only in this part of India, but this message will percolate in other parts of the country also, and you will form an association, and that association will be taking this nursing care in burn patients to new heights. So I thank you all and my best wishes. Thank you.
Thank you so much, sir, for your inspirational word. I take it real pride in welcoming Dr. Sunil Keswani, sir, who's really a gem of a cosmetic surgeon and also the medical director of the National Burn Center at New Mumbai. His expertise in his field is unmeasurable. Welcome you, sir.
Very good afternoon, friends. If healthcare management can be imagined as a pyramid, the nurses form the base of this pyramid. Without them, any form of critical care medicine will not work. What the mind does not know, the eye does not see. So you can't just have nurses there. They have to be knowledgeable nurses, they have to be skilled nurses, they have to be experienced nurses. And how does experience, knowledge, and skills come? By meetings such as these. My father, late Dr. Manohar Keswani, about 40 years ago, realized that if you have to improve burn care in India, you have to train the nurses. 40 years ago, he started organizing 1-month training program for burns nurses from all over the country at the SNDT College of Nursing then, where I was also a teacher when I passed out in 1990 as a plastic surgeon. It was a 1-month program. Nowhere else in the world you have 1-month program for burns even then. So I think it was his vision which just I had to follow. And we have been training nurses at the National Burn Center, theoretical training and didactic training for different periods, 2 weeks, 3 weeks, 4 weeks. And today, you'll be happy to know that 1 week or 2 weeks in burns care training at the National Burn Center or any similar center has become mandatory part of the critical care nurses diploma and degree. So friends, you will realize that burn nursing is the subset of critical care nursing. And unless you have good nurses, knowledgeable nurses, skillful nurses, and experienced nurses treating these patients will not survive. So all in all, ladies and gentlemen, this conference is a culmination of a dream of my father's, who at one time said there should be a separate association for burn nurses where they can debate at their level, and when a nurse hears it from a senior nurse of their specialty, they are more likely to follow. A nurse will more understand what exactly the junior nurse ought to be taught. They speak the same lingo. They have walked the same path hundreds of times, and they'll make the young nurses holding their finger walk that same path and train them up for good critical care nursing. I must thank Mrs. Sandra Shroff and General Bhutia and Sister Nancy Fernandez and all the other nursing college faculty who have come all the way from Surat, Bombay, Gujarat. And as Dr. Srivastava, the president of NABI, rightly said, this time we could do it with our 3 months preparation only for Maharashtra and Gujarat. Hopefully, on an annual basis, we'll extend it to up north, and Dr. Srivastava has promised me his help to get participation from up north. He's a very resourceful man and a man who understands burns. He's been treating burns. And I think this is a historic day in the medical milestones of burns in India, that a dedicated burns nursing conference was held. Thank you so much, ladies and gentlemen.
Thank you, sir. Now I request Srimati Sandra Shroff, ma'am, the founder and the chairman of SSRCN, to address the gathering.
Good evening, everyone. What can I say after what has been said? I think it is a fact, it is the truth, it is the reality that nurses play a much bigger role than we give them credit for. And that has to change. It has changed a lot in the last 20 years, 30 years, right? And nurses are being paid well, much better. They're being given the respect, and that is what is required, because they work long hours. They work unfriendly hours, and we have to really appreciate that. But I'm talking to up-and-coming nurses, and what is so wonderful is when you go to a nursing college, you find all these young ladies and few young men working really hard, really sincerely. But if you go to a management college, you'll find a completely different type of people. The nurses are special, whether they're men or they're women, and they look at life differently. They're not so mercenary. They're not so worried about what they're going to get. They're more giving. They give of themselves and look after you and spend extra time understanding your problems, understanding what is going on in your mind. And all of this is so important, and it's so much more than a job. So I endorse what everyone else has said, what Mr. Srivastava has said, what Vilas has said, what Dr. Keshwani, and when he remembers his father, what he had said and how happy he would be to see this gathering today. And I thank you for all of your participation and contribution, and the people who have worked, like Major General Bhutia, she's worked really hard. And then PM, as a new person, has worked very hard. Samuel has come in to take over, and Samuel has been dumped in at the deep end, right? But we're all getting along extremely well, and we've done an amazing job. Thank you very much, everyone.
Thank you so much, ma'am. I am glad to welcome Sri Kalyan Banerjee sir, President of International Rotary Club and Chairman of Rotary Charitable Trust. I would like to invite Sri Kalyan Banerjee sir to bless us with their motivational word. Welcome you, sir.
The very distinguished dais that we have this evening, members of the audience, ladies and gentlemen, and dear students. It's a pleasure to be here this evening, but I don't know what I am really doing in the Burns conference, because I have not really been involved in the conference as such. I know you have had a wonderful event today. But I've known Dr. Keshwani for quite some time, and I know he is really the doyen, if I may put it that way, of burns treatment in this country. Long before, I think even he started the hospital over there in Aiholi, I guess, we used to treat our burn patient in our little hospital in Vapi. And we had these nurses coming in from Ahwa, Dangs, all Adivasi girls, all of them. And I must thank really Miss Dr. Nancy Fernandez, because I don't know if you are aware, we have had a long-term association with the SNDT University over there. And for many years, we have had teachers from your college come and go to Dangs and teach those girls over there. They formed the first basis of the nursing group that we had over here. Otherwise, it was very difficult to get any nurses in Vapi, even though we started a hospital with a lot of hope and ambition and good wishes, but we could not get very many nurses. Even in those initial years, all the nurses that we got were from South India. But once we took up the nurses of Ahwa district, I think they were young, very enthusiastic, and we had one lady who was full-time stationed there. She was their teacher. I think she did a wonderful job because she produced a lot of nurses, many of whom are still, perhaps almost 30 or 40 years later, they are still working with us in our hospital and are doing a magnificent job. So we thank you for all that you did over there, and that is how the nursing process got started in Vapi. And of course, as far as burns are again concerned, I was talking to Dr. Keshwani. He and I have been not in touch for quite some time now, but I know what a dedicated man he is, and what a wonderful hospital he runs over there. And it's been we always used to try our burn patients over here. But once his hospital started going, well, everyone went from here to his hospital, and it was a great sense of relief for us. It made all the difference. Thank you for coming back over here, and it is wonderful to see you all again. Thank you, my dear friends.
Thank you, sir. You definitely inspire us. Moving on, I call upon Dr. S.S. Singh, Chief Physician and Director of Medical Services, Haria LG Rotary Hospital.
Dignitaries on the dais, good evening, all of you. Dignitaries of the dais. I first congratulate SNDT, Mrs. Bhutia, Dr. Keshwani, and all the other dignitaries who had been involved in this organizing this wonderful session, National Burns Conference. This has brought Vapi and our nursing college on the national platform by organizing this conference. Thank you, sir. As we all know that burns, I am also a medical person. We are knowing that burns was a totally neglected part of the treatment. Burns patient आते थे तो कोई जनरली डॉक्टर हाथ लगाने को तैयार नहीं होता था. Nurses were not ready to treat. ज़्यादा burns है तो कोई और भी किसी को इंटरेस्ट नहीं रहता था. Used to give lot of discredit to the doctor and the hospital. But now with the advancement in the burns has become a burning topic, and lot of people are taking interest in the burns. We all know that burns, although it was already a sidelined subject, but in past also, if you see the Shushrut Samhita, even the Shushrut had defined burns in 4 stages, what we still learn, stage 1, 2, 3 and 4 as per the depth of the burns and all this. So at that time it was quite advanced, but unfortunately that time there were not good medicines. They used to just treat with ghee and some shahad and wax of the honeycomb, all these they were applied. Even when I was a student about 40 years back, there was nothing, because that time not even good antibiotics were there. So the burns patient was just treated in an isolated place with some dressing and being given a lot of fluids and all this. But now with the advancement, it has become one of the most advanced subjects in the medical care, and lot of people are taking interest. It has become totally a specialized treatment. Still, lot of people who do super specialization in plastic surgery, hardly maybe 1% like Keshwani will be interested in taking care of the burns patient. Others are just more busy in lucrative business of the cosmetic surgery and all this, which gives lot of money, lot of credit, lot of pictures in the newspapers and lot of coverage in the media. So great credit to you, sir, for starting this burns hospital. I know that when I joined this hospital around 36 years back, this is a chemical zone. Lot of burns patients were coming to the hospital. There were no proper guidelines, there was no proper treatment. That time, Mrs. Shroff and Mr. Banerjee, they took initiative, started a burns ward in the hospital 30 years back. And whenever a burns patient used to come, Mrs. Shroff will come running and she will ask कि जल गए थे तो घर में क्या किया था. I still remember. लोगों को भी बड़ा आश्चर्य लगता था कि एक कोई अंग्रेज लेडी आ गई और वो हिंदी में और गुजराती में बात कर रही है, पूछ रही है कि क्या हुआ था घर पे, कैसे जल गए. Because that time हम लोग पहले क्या कंसेप्ट था मालूम नहीं, बाद में मिसेस श्रॉफ रिपीटेडली टोल्ड देम कि ठंडा पानी डालो, जल जाता है तो बाल्टी भर के पानी डाल दो, which was not that time so popular. To give a good guidelines, good treatment to the patient, Dr. Keshwani, your father, used to come to our hospital. I still remember he used to tell कि potato peel लगाओ, potato peel से treatment करो, because that time everything was on trial. So he used to teach us कि potato peel से उसको slices करके उससे treatment करो, it will give a good effect. But with the good taking care and the prophylaxis and prevention of the burns taking place with lot of knowledge, lot of giving knowledge to others by Mr. Shroff, I think the burns patient started decreasing in Vapi, and ultimately the patient was so less that we have to even close down the burns ward. So it was all due to your and Mr. Banerjee taking good effort, spreading a knowledge in the industry how to prevent burns because prevention is the best care, especially in burns. So this was the best thing, and now you will find hardly any burns patients are coming to the hospital. Mostly domestic burns may come, but industries are taking good care, good prevention. So burns is not only just treating after the burns happens, the most important is prevention. That prevention of the infection, prevention of contractures, prevention of complication in the lungs, the blood circulation and all this. So it is not only a just ordinary treatment, lot of advancement has taken place. Skin transplant is being done, skin banks are there, bone marrow treatment, and so many, there are pulse therapies and shock therapies advancement going on in the burns. So a lot of people are taking interest in the burns treatment nowadays, and they're saving lot of lives. By organizing this conference, I hope lot of nurses and the other doctors will start taking interest in the burns treatment, will help the community and the sufferers in a long way. My good best wishes to all of you, and best wishes for the tomorrow events also. Thank you.
Thank you, sir. Now I hand over to Ms. Silja JM, Associate Professor at SSRCN.
Good evening, all. On special note, I would like to recognize the selfless service our beloved trustee members and well-wishers dedicated towards our college. Also, at this moment, I would like to thank their valuable presence to find time to grace our occasion. Mrs. Achala Joshi, Principal, Gandham School, Dr. Shunil Chaudhary and other officers from Reliance Industry, President Rotary Vapi, Mr. Hemang Naik, Secretary Rotary Vapi, Mr. Joy Kotari, and Trustee of SSRCN Bharat Sir, Praful Sir, Rishi Patania Sir, and Dr. Indrajit Singh, CEO HRH. Once again, thank you all for our respected trustee and our well-wishers. Thank you.
I request Major General T.K. Bhutia ma'am to propose the vote of thanks.
Good evening, one and all. Dignitaries in the dais, of the dais, namaskar. Namaskar. जोर से बोलिए. Thank you, thank you. Thank you is a word, it is a prayer. It's a prayer. You cannot touch, you cannot see, but you can feel. It's a prayer. ये दिल से होता है. I'm totally indebted to you all, the dignity and the dais, and the various teachers, our trustees. मैं आपकी बहुत आभारी हूँ. It is a very, very memorable day for me. For the first Burns Nursing Conference, I'm proposing the vote of thanks in a place like Vapi. When I had come over here, I had seen what Dr. Singh says correct. I had seen a lot of cases over here, and Dr. Singh used to make one ward dedicated to the burns patient. We used to close the door, not allowed no visitor. Now the things have changed. That time I was not much knowing about Airoli. Now my students are going. I also do visit. And Dr. Keswani, what he said, he wanted to start this and he wanted to have this burns conference. And thank you, Dr. Keswani and Madam Sandra. Because of your support, we could, this type of mega event we could create. And now I'll start proposing the vote of thanks. Firstly, Sri Rahul Verma, बहुत कोटि धन्यवाद. You have already visited our college and you have seen the simulation center. सबसे पहले तो धन्यवाद for sparing your valuable time. And now once you have seen our simulation center where we have got lot of equipments, I'm sure you will not hesitate, or rather you will plan to send lot of your industry workers to undergo training in our place in the first aid, giving the injection, care of the burns, care of the CPR, and I can vouch and I can guarantee they will get excellent training, not only for your Silvassa. I can vouch even for a pan Reliance company of India will be able to train. We have got a hospital, Haryarji Rotary Hospital, and we have got the blessing of Madam Sandra. So that is, I vouch. Secondly, my heartfelt thanks goes to Mr. Vilas, Registrar. When I came here and joined in 2014, till that day, our Sandra College of Nursing was affiliated to SNDT. The day I joined, the month, the year, it changed over to Veer Narmad South Gujarat University. I can tell you, the girls who passed out from SNDT University, almost 90% of them have migrated to UK, USA. And I would say that also, they are making our college, SNDT and India very proud. They are doing a fantastic job over there. Thank you very much. Of course, my singular vote of thanks goes to our Madam Sandra. She is always there to support us, and you all know it. And Sir Kalyan Banerjee, wherever we have any problem, I just go. And rather, he came day before yesterday and he asked me, everything is going on smoothly. And I showed him this Wali painting our students have done. And like that, what else type of support you want? Vapi is not a metropolitan city. Nothing much to see. As a person like Fauji, a person like me, who lived in the metropolitan, and we had a very different life culture. But it is because the care, concern, and depth shown to us for our college. This is the one of the reason. My another vote of thanks to you all, ma'am, and all those who are in the dais. Dr. S. Singh as chief physician, who always supports us. Any problem in the college, any teaching, anything, we go and approach him. He has been very helpful to us. It's so heartening to see Dr. Srivastava, cosmetic surgeon, and our Dr. Keswani. जो हम कहते हैं ना, सरस्वती का देन है, उनके हाथ में, जो फिंगर्स में, जो सरस्वती बैठा है ना, जो वो स्काल्प चलाते हैं, छुरी चलाते हैं, छपा की जो पिक्चर आपने देखा है, जहाँ अग्रवाल को, मिसेस अग्रवाल को, what they had seen, उनके पास यह जादू की छड़ी है, उनके हाथ में ये हुनर है, I'm sure he can change Chapaki Agrawal to Deepika Padonkar. And Deepika Padonkar was the heroine of Chapaki. Well, Dr. Nancy, your team, and Airoli team, and many principal has come. ये तो बोलता है ना, पिक्चर बाकी है, मैंने तो शुरू ही किया है, एक और दिन बाकी पड़ी है, तो कहीं ना कहीं मैंने किसी को धन्यवाद बोलने के लिए भूल गया, तो कल एक और दिन है. लास्ट में vote of thanks will be very big. मेरा छोटा वाला है अभी आज. My special thanks goes to Mr. Badresh. He has given the full coverage. Why we say they are the pulsating veins of any institution or any program. हमारी जो YouTube में चला गया है, YouTube channel में everybody is watching our program. It's already gone. The link is there. Our friends and so many colleagues are watching whatever the program is going on over there. It was nice. My Sandra has come and proposed a vote of thanks to many of our Rotarians. Thank you very much. And the trustees. Lastly, मैं आप सबकी बहुत आभारी हूँ. Thank you. As I already said, ये छोटा सा thank you है, बड़ी वाली thank you कल होंगे. Thank you very much, ma'am. Thank you very much, sir.
Thank you, ma'am, for those words of gratitude. It means a lot. I request all the dignitaries and the delegates to kindly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you to all the dignitaries on the dais and off the dais for taking the time out of their busy schedule and attending the inaugural session. We will be breaking for tea very soon, and at 7 o'clock we will be back to the auditorium for the power-packed cultural programs. See you. Bye. Thank you.
होता है तो आज भी हमारा प्लान वही है क्या? हाँ हाँ, तुमने बिल्कुल सही सुना है। आज की इवेंट में डांस और म्यूजिक के अलावा और भी बहुत कुछ है। यू जस्ट वेट एंड वॉच। सो गाइस, आर यू एक्साइटेड? सो इट्स द टाइम टू शोकेस द टैलेंट. In the Natya Shastra, our ancient scholar Bharat Muni has said the importance of rasa and bhava. Our first performance is the tiny step to continue his legacy. And now I welcome Arunima and Pooja for presenting their dance performance.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
सदा चलिया प्राण जाए पर वचन न जाए. रघुवर तेरी राह निहारे, रघुवर तेरी राह निहारे, सातों जन्म से सिया घर मोरे परदेसिया. आप पधारो पिया घर मोरे परदेसिया. आप पधारो पिया. रंगीला भारो ढोलना ढोलना वे. रंगीला भारो ढोलना ढोलना वे. आरा रा रा आरा रा आया
प्यार के गीत जरा सुन ले, ओ प्यार के गीत जरा सुन ले, मैं आया रे।
हमारे आंगना दुआरे ऐसा मोहक रूप सजा रे, नीले पीले लाल गुलाबी हो गए नैन कजरा रे। अरे गारे 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 कोई दाम आया हमारे, ढोली छक्के ढोल बजा रे, ढोली छक्के ढोल बजा रे। रंगीला हमारा ढोल देना, ढोल देना हमें।
अरे वाह, व्हाट अ वंडरफुल परफॉर्मेंस। थैंक यू अरुणिमा एंड पूजा।
डांस तो हमने देख लिया, अब सिंगिंग भी होता तो और मजा आता।
डोंट वरी भूमिका, हमारे पास सिंगर्स भी है। नाउ आई वेलकम सारंग, स्टूडेंट ऑफ फर्स्ट ईयर बीएससी नर्सिंग, फॉर अ मेलोडियस सिंगिंग परफॉर्मेंस।
प्ले करना पड़ेगा।
हेलो हेलो
हंसता रहता हूँ दिल से मिलकर क्यों आजकल, बदले बदले हैं मेरे तेवर क्यों आजकल, आंखें मेरी हर जगह ढूंढे तुझे बेवजह, ये मैं हूँ या कोई और है मेरी तरह, कैसे हुआ तू इतना जरूरी, कैसे हुआ तू इतना जरूरी, कैसे हुआ। मैं बारिश की बोली समझता नहीं था, हवाओं से मैं यूं उलझता नहीं था, मैं दिल भी कहाँ थी मुझे ये खबर, कहीं पे हो रातें कहीं पे सवेरे, आवारगी रही साथ मेरे, ठहर जा ये कहती है तेरी नजर, क्या हाल हो गया है ये मेरा, आखिरी हर जगह ढूंढे तुझे बेवजह, ये मैं हूँ या कोई और है मेरी तरह, कैसे हुआ तू इतना जरूरी, कैसे हुआ तू इतना जरूरी, कैसे हुआ। हुआ कैसे हुआ तू इतना जरूरी कैसे हुआ
Thank you, everyone.
Thank you, Sarang, for this amazing performance.
सिनी, आपने बोला था कि बहुत कुछ है, तो सिंगिंग और डांसिंग तो हो गया, तो अब क्या?
तुम्हें शायद पता नहीं, लेकिन कल्चरल इवेंट इज इनकम्प्लीट विदाउट द रैम वॉक। जैसे कि आज सुबह हमने पता चला कि आज कोई मिस आइकन एंड मिस्टर आइकन बनने वाला है। चलो देखते हैं कि कौन बनेगा। So, let us raise the energy and zeal of the audience by welcoming the students for ramp walk.
रैंप वॉक तो हो गया, बट इनको कुछ ना कुछ तो पूछना पड़ेगा ना।
हाँ, इनको तो अपना नाम के साथ इंट्रो भी देना पड़ेगा. So now I request Priyanka ma'am to proceed further.
Good evening, all. Myself, Patel Urvasi, first year GNM, studying in SSRCN. My question is, do you think social media is positive or negative thing? हिंदी में बोलती हूँ. मुझे सोशल मीडिया बिल्कुल पसंद नहीं है और मैं कुछ भी नहीं चलाती. सच में नहीं चलाती. ओके, थैंक यू.
Good evening, present all and all here. My name is Prashad Dimple. I am a student of BSc Nursing first year from SSRCN Vapi. So, my question is, what do you will do if your favorite actor come and propose for marriage? ना, वैसे तो मेरा कोई एक्टर या एक्ट्रेस मेरा फेवरेट नहीं है और एक्चुअली मैं मूवी या सिंगिंग कुछ देखती नहीं, इसलिए मेरा कोई फेवरेट नहीं है. मेरे पापा सिर्फ फेवरेट है. मेरे लिए सिर्फ मेरे पापा फेवरेट है और कोई नहीं है. थैंक यू, थैंक यू, थैंक यू.
देखना मेरा क्या है, व्हाट आर द 3 आइटम्स ऑफ ऑलवेज यू हैव योर पर्पस. मतलब मेरा पर्पस क्या लाइफ में ना, सक्सेस होना और सिंगिंग करना और
हिंदी में बोलना. मेरा
सिंगिंग करना और क्या है,
बस बस.
Good evening all, respected principal ma'am and dear colleagues and faculty member. Myself Chauhan Pinky from first year GNM student. Thank you for introduce myself. What are the 3 items for always have in your purpose? मेरे लाइफ का तो पर्पस यही है कि लाइफ में सक्सेस होना, अच्छी जॉब करना और माय हॉबी इज सिंगिंग. सॉन्ग में कौन सा एनीवन कोई गैस करेगा कोई सॉन्ग? खैरियत पूछो कभी तो कैफियत पूछो, तुम्हारे बिन दीवानों का क्या हाल है। दिल मेरा देखो ना मेरी हैसियत पूछो, तेरे बिन एक दिन जैसे 100 साल है। ओ खैरियत पूछो कभी तो कैफियत पूछो, तुम्हारे बिन दीवानों का क्या हाल है। थैंक यू।
Good evening, everybody. Myself, Krupali Prajapati, student of first year BSc Nursing, SSR CN Vapi. My question is, tell us about a time you had to handle a difficult patient. मैं ट्राई करूंगी पेशेंट को अच्छे से अच्छी केयर दे सकूं। थैंक यू।
Good evening, respected to principal sir and all teachers. Myself Satya Yadav, first year GNM students. If you were God for, अगर मैं एक दिन के लिए भगवान बनूंगी तो मैं फ्यूचर में क्या करूंगी? बस मैं तो कुछ करना नहीं चाहती हूँ, बस अगर मेरे से कोई गलती हुई हो तो अपने माँ बाप से माफ़ी मांग लूंगी बस। थैंक यू।
Good evening, all. Myself, Harijan Hetal. I am from Silvas. I am first year GNM student for SSR CN Vapi. How would you introduce yourself if were a guest speaker in today's conference? मैं क्या खुद को इंट्रोड्यूस करूंगी अगर मैं आज स्पीकर होती तो? मैं अपने आप को इंट्रोड्यूस करूंगी। मैं खुद को इंट्रोड्यूस करूंगी और जो मेरा टॉपिक रहेगा उसको इंट्रोड्यूस करूंगी और कुछ नहीं।
Good evening, everyone present over here. My name is Patel Dia. I am from BSc, and today's my question is: which celebrity would you invite to a dinner party and why? No celebrity can invite me for dinner. It's okay. Thank you. 7.
Myself Parmar Priti, I am coaching class student, and my question: what is your philosophy of life and what do you value most in life? My life most value my mom, dad. Thank you.
Good evening, teachers and everyone. My name is Nandini Yadav. I am GNM coaching class student. My question is, what is your biggest fear? My fear is water. Thank you.
It was such a visual treat to look at the ramp walk and to listen to the interesting answers. I hope everyone enjoyed too.
और अगर कोई भी बिलिंग है रैंप वॉक के लिए, दे कैन कॉन्टैक्ट एंड कम टू द बैक स्टेज, क्योंकि सेकेंड राउंड रैंप वॉक का बाकी है और वो कहते हैं ना पिक्चर अभी बाकी है मेरे दोस्त।
Dance has no barriers, and it is something that everyone can feel, understand, and definitely something that everyone will enjoy. So now I request upcoming aspirants Jia and their group for the dance performance.
आया हूँ आज मैं लेके जाऊंगा दिल तेरा, रोके कोई मुझे, टोके कोई मुझे, दूंगा उसे जहाँ से मिटा। मुकाबला, मुकाबला, लैला, ओहो लैला, मुकाबला, सुभान अल्लाह, लैला, ओहो लैला। रहना है इत्थे दिल चोर मुंडियो, तू कर ले जिन्नी बिनती, होनी ना तेरी गिनती, ऐ टब्बर है जी तुझे ठेकेदार दा। ओ मुंडा कुकड़ कमाल दा, मुंडा कुकड़ कमाल दा। देखो देखो है शाम बड़ी दीवानी, धीरे धीरे बन जाए ना कोई कहानी। देखो देखो है शाम बड़ी दीवानी, धीरे धीरे बन जाए ना कोई कहानी। दिल पर है दिलकश है, दिलदार नजारे हैं, आज जमीन पर उतरे कितने सितारे हैं। अगलो होश नमी दानम, हम है दिल है और जानम, बस दीवानगी 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 है, ना कोई रहसन ना रहबर, ये इल्जाम लगे किस पर, बस दीवानगी 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 है। All the hot girls put your hands up and say Om Shanti Om. All the cool boys come on, make some noise and say Om Shanti
रहा ना पहले से शाय, समझ में कुछ न आए, बोलो ना क्या किया जाए, आंखों से नींद है गायब, खुश हूँ मैं इतना क्यों, तुझको तो फिक्रों में क्यों, जाने क्या हुआ मुझे, तेरे प्यार में चमकू जैसे जुगनू।
ఎక్కినట్టుందిరా సామే, నీ పక్క పక్కన కూసుంటే పరమేశ్వరుడే దక్కినట్టుందిరా సామే, నువ్వు ఎల్లే దారి సుత్తా ఉంటే ఎర్రే ఎండినట్టుందిరా సామే, నా సామే నా సామే, రరా సామే, బంగారు సామే, మీసల సామే, రోషల సామే, నా సామే, రరా సామే, బంగారు సామే, మీసల సామే, రోషల సామే.
ताज से ताज मिला हो, ताज से ताज मिला, ताज से।
थैंक यू स्टूडेंट्स फॉर दिस ऑसम परफॉर्मेंस। भूमिका, तुझे पता है जब मैं सापुतारा ट्रिप में गई थी, उधर एक बहुत अच्छा सा डांगी डांस देखी थी।
Then, Sydney, I have a good news for you because our nation's way of culture and ethnicity is something that we are known for, and Dangi dance is one of them. And now I request Ankit and group to perform the much awaited Dangi dance. Thank you, Ankit and group, for showing us this enthusiastic glimpse of our tradition. Every walk is unique and special in its own way. Now I request other students for the second round of ramp walk. So are you guys excited?
Good evening, ma'am. Good evening, sir. I am Arunima Mishra from first year of BSc Nursing. So my question is, what is the greatest lesson that this pandemic has brought to humanity? Shall I repeat my question? What is the greatest lesson that this pandemic brought to humanity? So according to me, that pandemic, so we usually like to we get to spend time with our family, and I in at my experience, what I have seen that people are helping each other, they are helping each other. So this is the greatest humanity that I have seen that people brought during the pandemic. Thank you.
A very warm good evening to all the wonderful people present here. I would be glad to introduce myself. My name is Sonal Sanjay, and I am a student of first year BSc Nursing of Sandra, Shroff, ROFEL College Nursing. And my question is, which is your 3 most favorite cartoon and why? So, my favorite one is Doraemon, and the most famous Shinchan, and Chota Bheem. Thank you. Bye.
Good evening, everyone. I am happy to introduce myself. My name is Yadav Sarang, and I am a student of first year BSc Nursing. And my question is, you came in nursing profession by chance or by a choice? It's my choice because I served to Indian Army to help. Because जैसे कि हमारे इंडियन आर्मी सबकी देश की रक्षा करते हैं, तो उनकी भी रक्षा करने के लिए भी मुझे बचपन से मेरे दादा ने सिखाया है, क्योंकि उन्हें भी मदद की ज़रूरत है, क्योंकि वो भी इंसान है. जैसे कि सियाचिन में -40 डिग्री सेल्सियस में रहने वाले इंडियन आर्मी, बहुत गर्व की बात है, और मैं इसलिए सियाचिन में जाना चाहता हूँ BSc नर्सिंग करके, और कुछ नहीं. थैंक यू एवरीवन.
Good evening all. Myself Patel Gracie, and I am student of first year GNM. My question is, what one thing are you not allowed to do that you would really like to do and why? तो मम्मी मुझे बार बार मना करती है कि बाहर का नहीं खाना चाहिए. मैं बार का खाना खाती हूँ क्योंकि मुझे पसंद है, इसलिए मैं खाती हूँ. थैंक यू.
Beauty begins when to decide to be yourself. Myself, Damini Patel, and I'm pursuing my post-graduation in Masters of Science in Nursing from Sandra Shroff ROFEL College of Nursing, and I belong to a wonderful city called Chikli. And also I am compassionate to do dancing, listening music, and exploring new things which will help me to check my own potential. So today's my question is, what are the 3 most important things in the kitchen and why? So I believe that first one will be the stove. Without stove, we cannot prepare the food. Second one, all the groceries which will require to preparing food. And last one, the cook who will preparing the food. Thank you.
Good evening, ma'am. Good evening, sir. Good evening, my dear student. My dear friend. Today, myself, Patel Divyangi. Today, my question is, you're about to die. What do you have as your last meal? मैंने कल रात को रोटी सब्जी और खिचड़ी खाया था.
Good evening, respected dignitaries and everyone present over here. I am Bhumika, student of 4th year BSc Nursing from Sandra Shroff ROFEL College of Nursing. And my question is, according to Global Citizen, 95% of the world's countries are led by male head for state. How would the world be different if more women were in charge? I believe that men and women are equal. The difference lies in their thought process. The thing is, we need to empower women so that they can discover their ability. Thank you.
Good evening to one and all present here. Myself, Mishra Jia, from the upcoming first year BSc Nursing student. My question is, do you think technology is hurting personal relationship? I don't think so that it hurt if we use in correct manner. Thank you.
Good evening to all. Myself Shilpi Sharma and I am currently pursuing coaching students and my topic is, if you could perform in a circus, what would your act be and why? And to be honest, I don't know, but I can't do this because circus, मैं entertainment नहीं कर सकती किसी को. Thank you.
Greetings, everyone. I'm Akshara from Knowledge Institute of Nursing, Vidyanagar. So my question is, what is your number one priority? Health, wealth, or love? I think it goes without saying that love should be your first priority, but let me add something to that. I believe that love is directly proportional to optimism, and we all know that optimism is a great contributor of health. Right. Aren't we actually, in nursing profession, I believe that we all encourage others to be happy and optimistic and positive. Right. It contributes to our health. So when we give into love, everything follows, health as well as wealth. Let me add something to that as well. Since I am a businesswoman, I treat each of my clients with love. And I have been seeing a great response to that as well. So love is the first priority of my life. Thank you.
Good evening to one and all present over here. I, Gaikwad Jonathan from 4th year BSc Nursing, a student of Sandra Shroff College of Nursing. So as my question is, what do you think is the advantage of having a pandemic? Like according to me, having an advantage regarding this pandemic, I think that it has created a lot of awareness into the nation of being for maintaining the environmental hygiene and our personal hygiene. This is the large environment that each single, even small child can say that to sanitize your hand and to wash your hands. This is what I want to say regarding the advantages of pandemic. Thank you.
Thank you everyone for participating in this ramp walk. Hey guys, a big surprise for you all. Now I invite Miss Sheetal Kotare ma'am from SNDT on stage for our performance.
Okay. Good evening to one and all present over here. Don't worry, I'm not going to take any lecture and make you bored, but I'll try my best to entertain you. It is during the course of caring for my patient. My specialization is child health nursing. So while interacting with certain children, I got to know about certain incidences. So out of that, one I'll try to narrate it for you. वो भी उसकी शैली में, किसकी शैली में? जिस बच्ची से मैंने ये सुना था. I can never reach to that level, but still I'll try my best to put it for you. हुआ ऐसे, मैंने पूछा, नेहा, क्या सोच रही है इतना? कुछ हुआ है घर पे? जैसे आंटी, एक्चुअली मैं कुछ समझ नहीं पा रही हूँ. बोले बेटा, बच्चा क्या नहीं समझ पा रही है तू? जैसे कल ना घर पे रामायण हुआ. रामायण हुआ? अच्छा, मतलब रामायण सीरियल चल रही थी. अरे आंटी, रामायण सीरियल नहीं चल रही थी. अच्छा नेहा, काम डाउन, बच्चे काम डाउन. तो हुआ क्या? मम्मी पापा का झगड़ा हुआ? अरे नहीं आंटी, क्या हर बार मम्मी पापा का झगड़ा ही होता है क्या? अरे नेहा, काम डाउन. ओके आंटी, स्ट्रेट पॉइंट पे आते हैं. ओके नेहा, प्लीज स्टार्ट. And then the whole time I was just quite enjoying Neha's expression. So here we begin. Auntie, कल ना मैच था. इंडिया वर्सेस मैच था. I understood. Against whom? Yes. Interesting for me also. हाँ, right, मैच था. पापा देख रहे थे. छुट्टी लेके ऑफिस से देख रहे थे. Obviously, मम्मी, ओके, हाँ. और फिर कुछ तो 5 मिनट का ना एड ब्रेक आया, तो मम्मी ने लिटरली पापा को सोफे से पुश कर दिया. पापा इज डाउन ऑन द फ्लोर. एंड ऑन टॉप ऑफ दैट आंटी, मम्मी का एक्सप्रेशन, अरे क्या गिर पड़ते हो, उठो, मेरा चैनल लगाओ. किधर गया रिमोट? किधर गया रिमोट? अरे रिमोट के साथ क्या कर रहे हो? निकलो इधर से. छुट्टी लेके बेकार घर पे पड़े. सुबह का ब्रेकफास्ट, दोपहर का खाना, शाम का चाय नाश्ता और रात का भी खाना. कितना खाते हो तुम? मेरा चैनल लगाओ. अरे 5 मिनट का एड ब्रेक तो तेरे बात करने में ही निकल गया. आज स्पेशल एपिसोड है मेरा. 5 मिनट के ब्रेक में लगाओ ना नेहा के पापा. प्यार का इतना ओवरडोज, अनडाइजेस्टेबल फॉर पापा. ओके, ठीक है, चैनल लग गया मम्मी का, और मम्मी जोर से चिल्लाई, मम्मी. आंटी, माय हार्ट वाज इन माय माउथ. बोला, क्यों, क्या हुआ? पापा ने क्या सीरियल पर से मम्मी को मारा? अरे नहीं, पापा को भी वही लगा. अरे नेहा की मम्मी, मैंने छुआ भी नहीं, तो चिल्ला क्यों रही है भाई? मम्मी उठी, दरवाजे के पास गई, ऐसा देखा नेबर वाले आंटी के घर के तरफ, और फिर से चिल्लाई, मम्मी. वहां से मेरी दादी भाग के आई। बचा कुचा जो सोफे का हैंडल था उस पे से भी पापा वापस टॉय डुप। वहां पे दादी बैठ गई। अंदर से कुछ आवाज आई, मेरे परदादी की थी शायद। कौन मुझे ले चलो, कौन मुझे ले चलो, अरे ले चलो। पापा को लगा मेरी परदादी तो निकल ली। पापा दौड़ के गए। मेरी परदादी आई बाहर और कुछ ढूंढने लगी। कोई मुझे दे दो, कोई दे दो मुझे, कोई दे दो। पापा ने मम्मी को पूछा, अरे नेहा की मम्मी ये ढूंढ क्या रही है? अरे दांत दांत नकली दांत। वैसे भी वुमेन एम्पावरमेंट भर भर के पड़ा है घर में। मुझे पकड़ के 4 औरतें और पापा और दादा, तो उनकी माइनॉरिटी हो जाती है। कोई लॉ नहीं है घर में आंटी। नेहा का इंसिडेंस, आई वॉज एंजॉइंग। आई होप यू ऑल आर ऑल्सो एंजॉइंग। इज इट? यस। आगे की स्टोरी थोड़ी और इंटरेस्टिंग करने की कोशिश करती हूँ। अभी सीरियल चालू हो गई। वहां से दादी, मुझे पता था इसी का काम है ये, मुझे पक्का पता था इसी का काम था। अरे मम्मी, उसका काम नहीं था, ये रियल लाइफ की स्टोरी है मम्मी, मेरे साथ हुई है। तो पापा को समझ में नहीं आया एक्चुअली हुआ क्या। वहां से परदादी, मैंने बोला था दाल में ज्यादा नमक शायद बहू ने ही डाला होगा। गॉड, पापा बस पागल हो जाना बाकी था आंटी। अरे ये सीरियल में किसी के घर पे दाल में किसने ज्यादा नमक डाला, उस पर से ये तीनों महादेवियां इतना इंटरेस्ट लेके देख रही थी। और लाइव मैच इंडिया वर्सेस, भूल जाए। अब इतना इंटरेस्टिंग ड्रामा हो रहा था ना घर पे कि तभी अचानक केबल ही निकल चला गया। शी, फिर क्या, जो दादी आई थी नेबर से, वो नेबर के घर पे चली गई, शायद उसके पास केबल हो। मम्मी को सूझा, अरे रात का खाना चलो बना ही लेती हूँ, महा एपिसोड तो देखने से रही, वो भी निकल गई। परदादी, आय हाय मेरा पैर दर्द करने लगा, निकल गई। और वहां से मेरे दादाजी आए भाग के, बेटा चल चल जल्दी चल। अरे पापा आप कहाँ लेके जा रहे हो, वो केबल भी गया। अरे पगले, बाहर से वायर मैंने निकाला था, चल। अपने नेबर में जो पांडे अंकल है ना, उनकी बीबी घर पे नहीं है, हम सब वहां पे मैच देख रहे थे, चल। मैंने नेहा का इंसिडेंस बहुत एंजॉय किया। फिर मैंने नेहा को पूछा, तो बेटा प्रॉब्लम क्या हुई, तू इतनी टेंशन में क्यों है? नेहा ने बोला, मुझे कार्टून देखना था, वो तो दिखा नहीं, पर तब पता चला कि मेरे खुद के घर पे कितने कार्टून कैरेक्टर्स भरे हैं। इसके लिए सोच रही हूँ मैं कोई कार्टून सीरीज ही बना लूं। थैंक यू।
Please give a huge round of applause to Ms. Sheetal ma'am. Thank you ma'am for entertaining us, and your expressions were the cherry on the cake.
Now, hold your breath for the next singing performance. I request Sonal from first year BSc Nursing for the same.
चाहे तुम कुछ ना कहो, मैंने सुन लिया कि साथी प्यार का चुन लिया, मैंने सुन लिया। पहला नशा, पहला खुमार, नया प्यार है, नया इंतजार। कर लूं मैं क्या अपना हाल, है दिले बेकरार, है दिले बेकरार, तू ही बता। पहला नशा, पहला खुमार। बातें जरूरी है, तेरा मिलना भी जरूरी। मैंने मिटा देनी ये जो तेरी मेरी दूरी। बातें जरूरी है, तेरा मिलना भी जरूरी। मैंने मिटा देनी ये जो तेरी मेरी दूरी। झूठी है वो राहें सारी दुनिया की, इश्क जहाँ न चले। तेरा होना मेरा होना क्या होना, अगर जो दोनों मिले, ये पहला पहला प्यार है मेरा। ये पहला पहला प्यार है मेरा। मैं तेरी आंखों में उदासी कभी देख सकता नहीं, तुझे खुश मैं रखूंगा सोनिया। मैं तेरे होठों पे खामोशी कभी देख सकता नहीं, सारी बातें मैं सुनूंगा सोनिया। तेरे दिल से ना कभी खेलूंगा, सारे राज अपने मैं तुझको दे दूंगा। मेरी जान तूने मुझको पागल है किया, मेरा लगता ना जिया तेरे बगैर। तू मान मेरी जान, मैं तुझे जाने ना दूंगा। मैं तुझको अपनी बाहों में छुपा के रखूंगा। तू मान मेरी जान।
Thank you.
Thank you, Sonal, for this fantastic performance.
सिनी, आपने एक स्टेट में एक जैसे लोगों को तो देखा होगा, लेकिन सारे स्टेट वालों को कभी एक साथ देखा है?
नहीं, उसके लिए तो हमें इंडिया टूर जाना पड़ेगा।
वेल, इंडिया टूर तो नहीं, बट हम सबको साथ में जरूर देख सकते हैं। एंड नाउ वी विल हैव अ डांस परफॉर्मेंस बाय कृष्णा एंड देयर टीम ऑफ सेकेंड ईयर एंड फोर्थ ईयर BSc नर्सिंग हु विल बी रिप्रेजेंटिंग डिफरेंट स्टेट्स एंड देयर रिस्पेक्टिव कल्चर।
केसरिया बालम आओ नी पधारोनी मारे देश रे पधारोनी मारे सरगम के मीठे मीठे सुर घोलो बिंद पोषणाल किन्नी लो हे आया हूँ मैं प्यार का ये नगमा सुनाने सारी दुनिया को एक सुर में सजाने सबके दिलों से नफरत को मिटाने आओ यारो मेरे संग संग बोलो माल गिरने लो हमारी रूम तुम करती आवी हमारी रूम तुम करती आवी आनंद उत्सव ने गरबानी राम जट साथे लावी हमारी रूम तुम करती आवी हमारी रूम तुम करती आवी झांझर ने झनकारे मारी सखियों साथे लावी मोती बेराना चौक में आव्या अंबेना चौक में जगमग थाय रे आव्या अंबेना
लटपट लटपट कमर दामिनी अधर रागिनी हो लटपट लटपट कमर दामिनी अधर रागिनी मेरे दर आए कैसी सजी धजी देखो मेरे पिया की सावरी जिया से बावरी मेरे अंगना में देखो आज खिला है चांद ये बाजे धुन झम झम झमाते झम तू नाची गाने झम झम झमाते झम ये बाजे धुन झम झम झमाते झम तू नाची गाने झम झम झमाते झम पिंगा गपोरी पिंगा गपोरी पिंगा गपोरी पिंगा पिंगा गपोरी पिंगा गपोरी पिंगा गपोरी पिंगा बिचा हाय रे पीपल छैया बैठी पल भर हो घर के गगरिया हाय रे हो दया रे चढ़ गयो पापी बिछुआ दया रे चढ़ गयो पापी बिछुआ हरे मर गई कोई उतारो बिछुआ हरे मर गई कोई उतारो बिछुआ
कैसो रे पापी बिछुआ बिछुआ कैसो रे पापी बिछुआ बिछुआ
তোমরা দেখো গো আসিয়া কমলা হেনে তো করে থমকিয়া থমকিয়া তোমরা দেখো গো আসিয়া কমলা হেনে তো করে থমকিয়া থমকিয়া এগো কমলা হেনে তো করে থমকিয়া থমকিয়া এগো কমলা হেনে তো করে থমকিয়া থমকিয়া রে কমলা হেনে তো করে থমকিয়া থমকিয়া তোমরা দেখো গো আসিয়া কমলা হেনে তো করে থমকিয়া থমকিয়া നാടൻ പുഞ്ചയിലെത്തിത്തേ തകതേതോ കൊച്ചുവെണ്ണെ കുയിലാളിതെത്തി താരേത് കൊട്ടു വേണം കുഴൽ വേണം കുരവ വേണം കൊട്ടു വേണം കുഴൽ വേണം കുരവ വേണം ഓ
भारत देश हमारा प्रणाम
घर घर तिरंगा हर घर तिरंगा घर घर तिरंगा हर घर तिरंगा घर घर तिरंगा रथ घर तिरंगा घरो घरी तिरंगा प्रत्येक घरी तिरंगा आसमान को पाना है आसमान से आगे जाना है नए भारत की नई कहानी अब आसमां को सुनाना है गर्व है इस तिरंगे पर सारे जहां को ये दिखाएंगे अमृत काल मनाएंगे घर घर तिरंगा लहराएंगे घर घर तिरंगा हर घर तिरंगा हर घर तिरंगा इंडिया 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 इंडिया
What an incredible performance. Thank you, Krishna and team, for this India tour.
So, are you excited to know the result of the ramp walk? Now, I request our principal, sir, for the announcement of Miss and Mr. Icon.
गुड इवनिंग। क्या लगता है आपको कौन होंगे विनर? नंबर okay, that side, any guesses? अच्छा, मेरे लिए तो सभी विनर है क्योंकि इतना अच्छा शो जो उन्होंने पुट अप किया है। डिड यू एंजॉय ऑल? Yeah, I think actually they have worked hard, they have practiced hard, and they have entertained us, right? So As I said, actually, everyone is supposed to be winner for this evening, but we have to choose only two, one from boy and one from girls. So from boys, number 12 is the winner. 12. Shall we put up our hands? 12 number. And from girls, number 19, 19. 19.
I request our respected Sandra ma'am to come ahead for giving
19.
brooch and crown to the Miss and Mr. Icon.
Thank you.
घायल परिंदा है तू, दिखला दे जिंदा है तू, बाकी है तुझ में हौसला। तेरे जुनू के आगे अंबर पनाहे मांगे।
Please give a huge round of applause to our winners.
रूठी तकदीरें तो क्या, टूटी शमशीरें तो क्या, टूटी शमशीरों से ही हो। कर हर मैदान फतेह, कर हर मैदान फतेह, कर हर मैदान फतेह रे बंदिया, हर मैदान फतेह।
कर हर मैदान फतेह, कर हर मैदान फतेह, कर हर मैदान फतेह रे बंदिया, हर मैदान फतेह।
14-day loop break. That's a world record. Welcome back.
इन गर्दिशों के बादलों पे चढ़ के वक्त का गिरेबा पकड़ के, पूछना है जीत का पता, जीत का पता।
इन मुट्ठियों में चांद तारे भर के, आसमां की हद से गुजर के, हो जा तू भीड़ से जुदा, भीड़ से जुदा, भीड़ से जुदा। कहने को सर्रा है तू, लोहे का छर्रा है तू, टूटी शमशीरों से ही हो।
कर हर मैदान फतेह, कर हर मैदान फतेह, कर हर मैदान फतेह रे बंदिया, हर मैदान फतेह।
I request all the participants to come ahead for the group photo. All the students who have participated in today's event, the dance group, singing and ramp walk, please come ahead.
Thank you everyone and all the participants for the rocking the ramp. Congratulations to all the winners.
Thank you everyone for the cooperation and thank you to all the dignitaries for giving us their time. सिनी यार अब मुझे बहुत भूख लग रही है.
अरे खाने का इंतजाम के लिए डिनर ही नहीं गाला डिनर अरेंज किया है.
अगर इवेंट इतना अच्छा है तो खाना तो और अच्छा होगा.
So I request everyone to move towards the backstage for the delicious gala dinner.
Thank you and here we are signing off. Bye. Good night.